to confirm if necessary. Not all the diagnosis needs even confirmation. And I think with this hypothesis that the clinical examination with preceded by a good history is the basic skill that all of us must develop and practice. And if that is so, then this puzzle of pyrexia or an enigma of pyrexia is no longer going to worry us. My talk today is totally clinical based and not investigation based. And you may not be aware what's happening all over the Western world. And the same thing is happening even in India now. It was just 5 years ago that the American Medical Association held a funeral service for physical examination. And they said history taking had died long back. What does it mean? The Western physicians today may not even take the history or touch a patient for clinical examination, but just look at the reports. And I think this is an eye opener to most of us. Having said this, what is this pyrexia of undifferentiated type? It simply means that the fever refers to absence of any localizing symptom or physical sign. So we have no clue where we are going. But I must say that the job of a family physician is even most difficult, simply because in the first 2 3 days, the fever usually remains undifferentiated. And I think that is the challenge the family physicians have to bear in mind. And as the time goes, the problems that we create iatrogenically is we use irrationally antibiotics, we suppress the symptoms and signs. And I think today the partially treated bacterial infection is the biggest puzzle, the code for pyrexia that needs to be really uncoded. Of course, sometimes the symptoms or signs are very non-specific. For example, headache, body ache, vomiting, irritability, not eating well, vague abdominal pain does not help us to localize the problem. And same way, if some lymph nodes are enlarged or if a liver and spleen are enlarged or if there is some skin rash, one doesn't know what's the probable cause of these illnesses. So you have non-specific symptoms and signs. And lastly, there could be genuinely undifferentiated fever for a long time. We'll see some of these examples as we go along. But suffice to say that our challenge starts from first 2 3 days of fever, where every fever is usually undifferentiated. Let's see how we solve this puzzle at all. The first thing that every one of us must do in the first 2 3 days of fever, when there is no clue whatsoever, is to rule out seriousness. And how do you rule out seriousness? Simply, most important pointer is a behavior change. Don't forget the basic physiology that the brain takes away 15%, 1 5, 15% of the blood flow. And naturally, if there is anything going wrong with perfusion or oxygenation or electrolyte abnormalities, the first thing that is seen is the brain function is getting disturbed. And what's the first symptom of a brain function getting disturbed? Simply some confusion, irrelevant talking, restlessness, lethargy, which then slowly worsens to become drowsy and even comatose. So, in every child who comes to you in the first 2 3 days, be sure that he has no behavior change. And I recall many times the mother telling me that, sir, the fever is not high, but I don't like the way this child is behaving. He never behaved like this. She was giving me a clue of some seriousness. And the next important thing is the urine output, again, because the kidneys derive 25% of the blood flow. Naturally, if there is anything going wrong there, the first thing to happen is uh, urine output is reduced. Of course, on clinical examination, you will find disproportionate heart rate and respiratory rate, which means that even a child who has no fever is having a tachycardia or a tachypnea. There could be a purpuric or a ganglion skin rash. There could be an abdominal distension severe enough, which has no clue whatsoever. And of course, don't forget a diphtheria as a partial membrane. So, friends, in the first 2 3 days, you just rule out seriousness. And if the serious is ruled out, your next job is to find out whether you want to consider an antibiotic to this fever. Don't make a mistake of starting an antibiotic without judging the provisional diagnosis of a bacterial infection. Now, how do you base that diagnosis? I think generally bacteria produce toxins. So, even when you use paracetamol, the response to paracetamol may not be very good because the toxin mediated fever continues. And even when the fever comes down, the child appears sick during interfebrile period, again because of toxins produced by bacteria. Viruses don't produce toxins, and non infective conditions also don't have any toxins. So, this is a good way to differentiate a probable bacterial infection. Mostly these fevers are very rhythmic, and as soon as the paracetamol effect goes away, the fever rises again. So, to recapitulate, toxin mediated sickness, even when the fever is partly under control, is a good way to consider a probability of an acute bacterial infection. If you don't have this kind of a thing, then wait and watch. Don't give an antibiotic. It will cause more puzzles to solve. But if the bacterial infection is suspected, observe the trend of fever, whether the fever is worsening, and look for very subtle differentiation. For example, a child may have had a vomit on day 3 and looking irritable. Well, this could be an early meningitis. A child looks a little tachypnic. So this could be a bacterial pneumonia coming. One could diagnose such condition even before a laboratory test demonstrate the correct diagnosis. And if at this point of time you are suspecting a bacterial infection, but there is no clue whatsoever, don't forget a urinary tract infection. It gives you no clue, but you have already made a provisional impression of a bacterial infection based on sickness, and then look at the urinalysis. Only the other condition where you may suspect malaria without a clue. And how do you suspect that clinically? Most important is when there is no fever, the child looks very well. And the fever is erratic, sometimes very high and sometimes none at all. If this is so, you will do a peripheral smear before starting an antimalarial therapy. So, in the first 2 3 days, make sure there is nothing serious. Wait to consider whether it's a probable bacterial infection, and if not, just wait and wait. Do not start an antibiotic. In fact, I would stretch my imagination to find out which fever would need antibiotic in the first 2 3 days. There are very, very few. Majority of them cannot justify antibiotic in the first 2 3 days. This is very, very important because when you look at a fever for 4 to 14 days, the only fever which give you no clue are typhoid, UTI that I mentioned to you, and rarely even a bacterial endocarditis. That fortunately is not so common. So if you have gone past 4 days suspected a bacterial infection. Urinalysis was normal. Malaria was ruled out. On day 4, you are suspecting typhoid fever. Make sure you have already suspected a bacterial infection based on what I said. But unfortunately, most practitioners would start antibiotic if possible even before fever starts. And I think partially suppressed bacterial infection is the commonest cause today of an undifferentiated fever. You develop a chronic pneumonia and a lung abscess, but you have no clue. You have a brain abscess or a subdural empyema in a chronic meningitis, but you have no neurological symptom. And you have those hidden abscesses. Why does this happen? Because somebody started without thinking irrationally an antibiotic. This is the commonest cause of fever, which is undifferentiated in the first or second week of life. Of course, sometimes, as I mentioned, you may have a hepatosplenomegaly and you suspected a bacterial infection. And keep in mind unusual organisms like Brucella or sometimes a leptospira or a rickettsia. These are not common infections, but they are often seasonal. And I'm sure in the rainy season, you would see the leptospira coming up, etc. And if there is a tick bite, then you have a chance of even a rickettsia. Then don't forget that viral infection usually settle by day 3, day 4, but few viral infections go on like an EB viral infection, Epstein-Barr, and sometimes even a CMV, a cytomegalovirus. But what is more tricky is many of these viral infections trigger the host immune response and it continues to prolong fever, often with some hepatosplenomegaly or some organ dysfunction. This is what happens possibly commonly in a dengue fever, for example, when the fever starts like any viral infection, but fever continues beyond 4 or 5 days, and now it may be overlapped by a child getting into a shock or child getting into a severe abdominal pain, a complication which is due to host immune response. And we are seeing the same in COVID today, that an apparently benign viral infection settles down only to prolong with some other manifestation. So we need to keep in mind the host abnormal responses as well. Well, there are genuine fevers in the second week where there is no clue whatsoever, and they are connective tissue disorders. The most important of them would be a Kawasaki, and sometimes the systemic onset juvenile idiopathic arthritis, and some vasculitic illnesses. These illnesses demonstrate some localizing clues only after 2 3 weeks of fever, but much before that, in the first 3 4 days, you have made a clear impression that these are not bacterial infections. The point that I'm making is just because fever has lasted for 2 weeks is not a justification to try another two antibiotics because you have already made a provisional impression that it is not a bacterial infection. And same is true about malignancy. And a classical malignancy that presents with high fever is a neuroblastoma in childhood. Having said that, when fever goes beyond 2 weeks, don't forget tuberculosis. Tuberculosis can have a hidden foci, like a primary focus in the chest may be unnoticed. Biliary disease, abdominal TB goes unnoticed. Tuberculous pericarditis has hardly any clinical sign. Urinary tuberculosis, fortunately rare today, has no clue, and so also may be a spinal tuberculosis. Some of the parasitic infections like Kala Azar or a toxoplasma, malignancies like a lymphoma, and immunological disorders like histiocytosis, sarcoidosis, and what is known as a periodic fever syndrome. They keep on getting fever with no clue whatsoever. But again, we have already enough justification not to give an antibiotic. And I think that is the crux of the problem, where there are miscellaneous causes of prolonged fever, where the temperature regulating system is not functioning well. These are central fever, heat fever, drug fever. So, as we go down beyond 2 weeks, you have seen we are going away and away from infection. And having given this idea about the basics, let me show you some of the classical examples of how undifferentiated fever can be differentiated. The fevers are not undifferentiated. We are unable to differentiate them. And if we just follow simple rules, then we will know that this thing. I'll just give you a brief idea about how CBC cannot be interpreted without clinical correlation. And if you look at this first CBC, typical polymorph nuclear leukocytosis, it's an acute bacterial infection. But look at this, looks similar, but it's a systemic inflammatory disorder, not a bacterial infection. And look at this. This is a simple acute viral infection. And don't forget that acute viral infection in the first 2-3 days have a polymorph nuclear leukocytosis. All three look alike. But what's the difference? The difference is really one, eosinophils are zero in infections and they are normal in non infective illnesses. And the platelets often give you a clue. The platelets may be low in a viral infection, or a platelet could be increased in a systemic inflammation, usually normal in the acute bacterial infection. So what we have learned, most important are eosinophils and platelets and not the polymorphs and lymphocyte. And look at this. We have a low count. The count is low and there are lymphocytes, but still it is an acute bacterial infection. Why is it acute infection? Eosinophils are zero and platelets are low. Look at this again. Most
Sir, please share
important
the
part
screen, sir.
most important part of CBC is eosinophils and platelets. Of course, you need to look at the total count and polymorph leukocyte. Well, these are non-specific ones. Malaria is also very non-specific, though generally hemoglobin is low and the platelets are low. And of course, leukemia is all that. Let me elaborate in the next 15 minutes some case scenarios which bring home the point that I was making. This is a child who had fever for 15 days, and the physical examination on day 2, he was not sick. Not sick often tells you he may not be having a bacterial infection. But the doctor thought he had a congested throat. So he started amoxicillin. This is a common scenario. The fever continued. On day 3, the counts were low and he was concerned. But he continued amoxicillin. Fever increased and child got sicker. He put the child
Sir,
on cefixime.
sir, just a question. Do you want to share the screen, sir?
I am sharing the screen. My
Sir, I
screen
can't
is,
see. We can't see, sir. We can't see.
my screen is on. I will try again.
Sir, just a second. Yeah, yes,
My
sir.
my screen is on.
Screen share.
Hello.
My screen is on.
Yeah, just at the bottom, you will see the share screen option, sir.
I have already done that. I have already done that. I have already done that.
So in that option, have you selected the slide and then share click the button?
Yes, no. I have already my slides on my desktop and I've already shared the screen. It's already on. Let me try again.
Yes, sir. Just stop share and please try it again.
Can you see my screen now?
Yes,
Yes, sir. Yes, sir.
Yes.
Yes, sir.
Okay, all right. Let me continue where I have. You did not see any part of my slides?
No, sir.
Okay, I'll just quickly go through what I said
Yes, sir.
without wasting time, and we will see how we go by that. But let me first go with these things and then go by that. See, I was talking about how in the first 2 3 days you need to really get about trying to solve the puzzle on all these things. And I was showing you how in the first 2 days we have to look at seriousness, and it's easy to pick up seriousness with a behavior change and a reduced urine output with disproportionate heart rate and respiratory rate. If you had a purpuric or a skin rash, you know you are in trouble. If you suspect a bacterial infection because of sickness, even when fever comes down, make this very clear. When you give paracetamol, fever drops a little, but the child's sickness continues. This is likely to be a bacterial infection, and in no other infections or in non-infective condition, the children look well when fever is suppressed. This is a good way for a baseline doctor to start differentiating acute bacterial from non-acute bacterial infection. And I think if you keep this in mind, then you will not make a mistake of giving antibiotics in the first 2 3 days. If you did that without knowledge, you get into trouble. You miss bacterial infection because you have suppressed them, and they land up with big trouble. Of course, there are genuine reasons why fever can go on for even more than 2 3 weeks. And as you go beyond 2 weeks, you have more often non-infective condition, but TB stands to be with us all the time. And I have already said that the CBC has a very low problem because acute bacterial infection not necessarily has nucleocytosis, even typhoid has. And that's why I was coming to this child where a doctor started amoxicillin right on first day because he thought throat is congested, and he got into trouble. Finally, he missed a step ladder pattern fever. CBC showed clearly a lymphocytosis, monocytosis. Viral was positive. Culture was negative because antibiotics were already given. This is a common scenario of a puzzle made into trouble because of irrational antibiotics. So beware of mild congested throat. There is nothing like mild congested throat. Congested throat has to have a symptom, either acute tonsillitis with difficulty in swallowing or an acute viral pharyngitis with a cough. But if there are neither, don't call mildly congested throat enough to give an antibiotic. This is very, very important. This was a 1 year old child. He started with fever and vomiting for 10 days. Initially, fever was high, thereafter became moderate. But again, the child was sick during interfebrile period. What does that mean? On very first day, you would have suspected an acute bacterial infection. But this was not done. Child was given antibiotic based on these counts. Polymorphs were high, urine showed pus cells, so maybe urinary infection. And this child was given amoxicillin from day 1, worsened, quinolones were added on day 5, and finally on day 10, he started looking lethargic, became more sick, and final diagnosis was a chronic meningitis with brain abscess. This child will remain mentally retarded. He will move about in the community, but nobody will know it was our fault of having given antibiotic unnecessarily without a diagnosis. This is what can happen. It stares at you for lifelong, but it is not difficult to decide when not to give an antibiotic. And I think if you keep this in mind, look at this child. 8-year-old child presented with fever and severe cough and mild breathlessness. Now, starting on day 2 with amoxicillin changed to cefixime, he is not sick. He has a mild tachypnea, and X-ray showed he has a typical pneumonia. But look at the basic information. Acute bacterial pneumonia never have severe cough. This child had a severe cough. So this is not an acute bacterial pneumonia. This is an atypical pneumonia. This was mycoplasma pneumonia, and this required a antibiotic like a macrolide. But there was a clue. There was a easy to differentiate acute bacterial pneumonia from a mycoplasma pneumonia only if you kept in mind severe cough is not a feature of acute bacterial pneumonia. This was a 8-year-old child with high fever for 2 days without any symptom. He was well during interfebrile period. What does it tell us? Very unlikely a bacterial infection. On physical examination on day 3, there was a white patch on the tonsil, and therefore it was thought to be an acute bacterial tonsillitis. But this child is not sick. This child doesn't have swallowing difficulty. This child doesn't have a submandibular gland. Enough clues against a bacterial tonsillitis. Amoxicillin was started. On day 10, child developed a skin rash, hepatosplenomegaly. Fever continued. This was typically an Epstein-Barr viral infection. But we knew it was a viral infection on day 1 because moment the fever came down, the child looked well. And I am sure as family physician, you must have seen very commonly a mother complaining that moment the fever comes down, the child keeps on playing. The child is telling you, don't take me to a doctor, and telling the doctor, don't give an antibiotic. It is that important. This was the 5-year-old child who presented with fever for last 1 month. Now, there were no other symptoms. Moment you find that this fever is going on beyond 1 month and there is no clue whatsoever, one thing that you need to rule out in our country is tuberculosis, even without symptoms. And every test was normal, including chest X-ray. What did it show? 2 sets of antibiotics failed. Now, on thorough examination, there was a mild tachypnea, and the saturation was 90%. This gave a clue that this child had a tuberculosis in the lungs, but chest X-ray would not show it. This is one time where you may do a CT scan. It showed a miliary shadow, and this was a miliary tuberculosis. But there was enough clue. Fever going on beyond 2 weeks, not localized, rule out tuberculosis. This was another child, again fever for a long time, but this child had enlarged liver. Now, what is the cause of enlarged liver in a child who is going on for a fever for a month? Again, we want to keep in mind tuberculosis, yes, but tuberculosis of the liver or a tuberculoma in the liver is not isolated in liver. It's a disseminated part of infection where there is a liver spleen and maybe even lymph nodes. So this was something funny. X-ray chest was normal, cultures normal, antibiotic failed. ESR was high. This meant that we had to find out where is this possible TB is, and one missed an engorged neck veins. And hepatojugular reflux was negative. What does it mean? There was a block in the superior and inferior vena cava, and this turned out to be a tuberculous constrictive pericarditis. Again, a point is a good clinical examination. What this is taught us, whenever you have an enlarged liver, look always at the neck veins. This was a child who was presented with moderate to high fever. He was sick in between fever. He was very irritable. But whenever the fever went down, He had hepatosplenomegaly, no jaundice. Antibiotics were changed. Non-specific liver dysfunction, none at all. This suggests reticuloendothelial cell involvement, and I think on day 14, same symptoms and signs. This child had a multiple micro abscesses, and the diagnosis was a brucella. Again, a point is bacterial infection was diagnosed, suspected. We didn't know which one. Hepatomegaly is a very non-specific sign, and we need to suspect which kinds of high fevers have a hepatomegaly. We saw constrictive peritonitis due to TB, and this is another microabscesses is a classical feature of a brucella. And I think this is where it is. This child had a severe myalgia, headache, and last 10 days. This meant possibly a viral infection, but it was going on for a long time. This should arouse suspicion. He was sick looking, so likely to be bacterial, not viral. And probable bacterial infection, amoxicillin had failed because we had used without knowing what it is. After 9 days, this child developed jaundice and hepatosplenomegaly. This is what classically happens in a leptospirosis with an immune phase causing hepatosplenomegaly, jaundice, and even sometimes a renal failure. But there was a clue that this was going to be a bacterial infection. And what's the crux of the problem? Bacterial infection which go on for a long time could be non-localizing like typhoid TB, or could be immune stimulated illnesses like a leptospira, etc. I think this was another one with moderate fever, cough, considered as viral infection. Routine test, no clue, antibiotic tried. 2 weeks later, fever worsened, enlarged liver without dysfunction. Again, it means infiltration. There was a bicytopenia. The WBCs are low and the platelets are low. Something is infiltrating the liver. What is it infiltrating? This is known as an HLH. It's a type of a histiocytosis. It's a semi-malignant disorder. Again, there is a clue. This was not a bacterial infection, and if viral infection continues long, you end up with an immune disorder. This was a child who had high fever and irritability. But every time his fever came down, he was feeding well. So this irritability was not because of fever, but he was eating well. So this was unlikely a bacterial infection. He had a lot of symptoms, irritability. It suggested some cerebral irritation or pain. This was no evidence of localized pain at all. He was a cerebral irritation causing pain in an aseptic meningitis. This is something that we should never miss. This is a Kawasaki syndrome. One can damage the coronaries permanently, and this is one cause of a heart attack in young children today. It is not rare. It presents as fever with irritability, and infant is very irritable, but he feeds well. And I think this is something that you should.
ए अगं तिला नाही माहिती ऋतिक काढ ना
This child has fever
मग
for
तिला दाखव
this child has fever for 4 weeks, and
मग मी
had
थोड्या
cough.
वेळ त्याच्या आधी येऊन जाईल ना म्हणजे मला थोडं
This child had fever for 4 weeks, dry cough, and urticaria. The variation of fever pattern, normal interfebrile period. This meant that this was not an infection. And with urticaria and cough, it was thought of allergy, but allergies rarely cause fever. This turned out to be a Hodgkin's lymphoma. There was a big lymph node which was pressing over the airways, and that was causing trouble. This was a child who had high fever for 20 days, and physical examination, he was sick looking. He considered UTI, but antibiotics failed, likely to be non-infective, but no clue. Again, This turned out to be a neuroblastoma. What's the message? A thorough examination. The mother pointed out that there was some nodule over the skull that was secondary in the bone, and that was that. This is a interesting child for a prolonged fever with normal interfebrile period, amoxicillin failed, cervical lymph and skin rash. Fever continued. This is known as a periodic fever syndrome. They look like a viral infection, but they go on for a long time. But don't forget, you had already made a diagnosis excluding bacterial infection, so you would never give an antibiotic. This is my last slide where fever went on for 4 months. And on direct questioning to the mother, when I asked this mother, what brings down fever? She said, sir, all antipyretics she has tried have failed. When antipyretics don't work, you have a central fever, and this child turned out to be a hypothalamic tumor. My take home message is in every child, rule out seriousness at first visit, change of behavior, urine output, heart rate and respiratory rate, which could be disproportionate, and a purpuric or a gangrenous skin rash. In acute onset fever, group diagnosis is feasible. What is the group diagnosis? Is it infection? If so, is it bacterial? If it is not bacterial, do not give an antibiotic. Today, the whole world is facing a problem of irrational use of antibiotics, and we in India are at the top of this irrationality. Now, we have to change. Otherwise, tomorrow, no antibiotic will work and we will die out of simple infections. CBC is not justified initially. Partially treated bacterial infection pose big problem beyond 1 week. Irrationally treated bacterial infection or a chronic infection or non-infective which need consideration. Thank you very much. If there are any questions, I will take them.
Thank you, sir, for such an elaborate lecture. We really enjoyed it. So, friends, the golden rule is history taking and clinical examination. Please use antibiotics judiciously. What mind do not know, eyes cannot see, and so please have a knowledge before trying to solve the case. Thank you, sir. I would like to thank you again for accepting our invitation and agree to be a speaker. Thanks a lot.
Thank you very much. Thank you.
Thank you, sir. And thank you, Dr. Ashwini. I now request the IMAFEST team to felicitate the speaker with the e-memento. Once again, thank you very much, sir. Now we felicitate the moderator of this session, Dr. Ashwini Acharya, with the e-memento. I thank JB Chemicals for the educational partnership. Now we move on to the next lecture. Those who snore always fall asleep first. Nearly everyone snores now and then. But do you know that it may indicate a serious underlying health condition? Today we have yet another interesting topic, Snoring, the Noisy Nights by Dr. Sameer Bhargava sir. I call upon our own Dr. Ghanesham Shirali sir, the renowned ENT specialist from Dombivli. Dr. Shirali sir has completed his post-graduation from LTMC College Science and worked as a lecturer and associate professor there before starting private practice in Dombivli. I welcome our moderator for this session, Dr. Ghanesham Shirali.
Hello, am I audible? Audible? Thank you, Dr. Suchitra, for the introduction. I am very much pleased to introduce Dr. Samir Bhargava, who happens to be son of my guru, Dr. Krishnakant Bhargava, ex-honorary professor ENT, Lokmanya Tilak Medical College, Sion Hospital. So, Dr. Samir is my guru bandhu. Dr. Samir completed his MBBS, GS Medical College, and KM Hospital. He had a brilliant academic career, rank holder throughout his undergraduate exams. He secured gold medal in MS as well as URL exam. He has also done DLO from Royal College of Surgeons, London. Dr. Samir Bhargav is currently professor in Hindu Hriday Samrat Balasaheb Thackeray Medical College and R.N. Cooper Hospital, Mumbai. And he is also honorary consultant at Hinduja Hospital, Khar. He is the national president of the Association of Otolaryngologists of India, AOI, for the year 2020. He has been invited faculty at more than 70 live surgical and cadaveric workshops all over the country and has been a guest speaker and panelist at several conferences and workshops, both national and international. He has been course director for sinus surgery workshops in HBT Medical College every year since 2015. He has delivered several prestigious orations across the country. To name a few, Dr. Sansgiri oration at IMA conference at Goa in 2015, Dr. S.N. Cooper oration at Ophthalmic Society in 2016, AOI Belgaum oration at South Zone Conference 2018, Dr. M.N. Mahore oration at Vidarbha AOI Conference 2018, Dr. Ramkumar oration at Bihar AOI Conference 2018, and Dr. Abirlal Mukherjee oration at Kolkata in 2019. He is a co-author of a short textbook of ENT diseases, which has been read by more than 2.5 lakh UG students. He has also contributed as author of chapters in several postgraduate books. He is a dedicated Rotarian, member of Rotary Club of Bombay Seacoast, and received Best Rotarian Award in 2015-16. He was awarded Vocational Excellence Award in 2019 by Rotary Club of Bombay West. He has featured in the list of Mumbai's top doctors published in India Today for 2 consecutive years, 2019 and 2020. I present to you Dr. Samir Bhargav. Dr. Samir, please take over.
Good morning, everybody. Let me start sharing my screen first. Can you see my screen?
Yes, sir.
And am I audible enough? ENT surgeon asking if he is audible. Yeah, can you hear me?
Tell him you are audible.
Yeah. So good morning, everybody. And thank you, Shirali sir, for this very kind introduction. And I would like to thank IMA Dombivli and Shirali sir for this honor to address IMA Dombivli. And it's always a pleasure to be hearing Amdekar sir. We've shared the dais a number of times in the last year or so. So the topic that has been given to me is snoring noisy nights. Now, normally, whenever I take a talk on snoring, sleep apnea, of course, comes along with that. And I generally schedule the talk about 2 weeks before conducting a surgical workshop on sleep apnea. And generally, the talk is in the afternoon siesta time. So we can pick up some candidates for surgery. but today it is in the morning, and so nobody has an excuse to be sleeping or snoring during my talk. Now, snoring is rather a peculiar problem where the protagonist, which can be male or female, is generally not the one who is suffering. So is what we used to believe many years ago. We now know that there is a medical aspect to this whole thing. So generally it is the spouse or the bed partner who lands up bringing the patient to the doctor. That because of this spouse, they are not able to sleep well. So look at this poor child who is getting disturbed every time the father is snoring. Now, for many years, snoring has been a topic of, fun, jest. Even till the 90s, it was not very well understood that there is a serious component to it. So we used to always say, कि दादाजी तो बहुत अच्छी नींद से सो गए, घोड़े बेच के सो गए, and सोते सोते वो चल बसे. So quite often it is possible that this very deep sleep or loud snoring elderly gentleman could have had a cardiac arrhythmia early morning and succumb to that. And snoring is a rather, if I may say, common problem. I would not be incorrect, because males, of course, are more prone, and at the age of 30, almost 10% of males would be snoring, maybe mild or severe, depends. But by the age of 60, almost 40%. And females, not to be left too far behind, almost 25% at the age of 60 would be snoring. Now, what is common in this slide? This gentleman waiting for an interview, this gentleman at a traffic signal, gone off to sleep, a broken car, a broken marriage. Sleep apnea is what is common to all of this. So we have patients coming to our OPD telling us, Doc, I fall asleep at the wheel and I've had 3 accidents. Please do something. What is wrong with me? Or a lady coming saying that I really love my husband, but when he sleeps, I really, really hate him. Do something. Or, Doc, I'm a walking zombie. I don't know what's wrong. I'm not fresh all through the day. I've slept 8 hours. I'm in bed, but I cannot function properly. So let us first see what exactly happens when there is a sleep apnea. So you have this gentleman who is snoring and snoring loudly, and then suddenly in the middle, there is a choking. There is a collapse of the airway that takes place. The breathing is stopping. There is a buildup of CO2. The patient then gasps for breath. And this story can repeat a number of times during that night. So when there is this total obstruction is when the patient gasps, gets up, gets some breath, and then goes back to sleep. So depending upon the severity, we can face the consequences. So let us look at the entire spectrum of sleep disordered breathing. So at one end is snoring, primary snoring, where there is an obstruction, but the patient doesn't necessarily wake up, or an upper airway resistance, where the patient will snore without apnea, but will get up, or a full-blown sleep apnea syndrome. So when you are normally breathing, there is enough air that is going down, but in a partial airway obstruction, there is a blockage. And in a total obstruction, you find a sleep apnea pattern. So this is during normal breathing, and this is when there is a blocked airway. So what exactly happens is when there is a collapse of the airway, there is apnea, the O2 is going down, PCO2 is increasing, and that reaches to a sympathetic surge, the airway opens, and this episode terminates. And this could happen a number of times, can be ranging from 5 to 15 to 50 to even more. So before we go into the main symptomatology, let us just describe a few definitions. So what exactly is apnea? When there is a cessation of the breathing at the nose and the mouth for a period of more than 10 seconds. And a hypopnea is when there is a decrease in the ventilation and the O2 saturation. And this is terminated by an arousal. You basically have three patterns. One is obstructive, where you have an absence of the airflow despite attempts to make a ventilatory effort. The second is central, where you're having no airflow, but there is no ventilatory effort as well. And the third is a mixed pattern, which is both central and obstructive. So in our obstructive sleep apnea, these recurrent episodes of upper airway obstruction during sleep, they go on despite you making an effort and an arousal. So there is a derangement of the blood gases, there is a fragmented sleep, and hence an excessive daytime sleepiness. So friends, why is sleep apnea important? And more importantly, why should sleep apnea not be ignored? So there is enough data now to show that almost 1 in 4 men, 25%, or 1 in 10 women would be having sleep apnea. And men in the age group of 40 to 70 with severe OSA, there is doubling of the chance of dying, especially due to coronary disease. And you can have these arrhythmias and sudden cardiac deaths, and quite often between 10 p.m. and 6 a.m. So sleep apnea can be dangerous in many ways. So it leads to affective problems. It leads to problems while driving, industrial accidents. There are so many major accidents that have been attributed to sleep apnea, including the Chernobyl disaster, the Challenger spaceship disaster, because of someone went wrong because of lack of sleep. Hemodynamic manifestation. So you have hypertension, arrhythmias, strokes, MIs, excessive daytime sleepiness, and of course, as I mentioned earlier, sometimes this dangerous arrhythmia can cause a sudden death. Now, according to the American Sleep Association, there are almost 6,000 lives that are lost each year due to drowsy driving. So being deprived of sleep for a 24-hour period gives the same cognitive impairment that a blood alcohol level of 0.10 would cause. So there's a 12-fold increased chance of a vehicular accident in patients with significant OSA. In our country, luckily, we do not have so many cases of broken marriages just due to snoring, but in the West, this is an important cause for filing for divorce. So how do we measure our apnea? So the number of times that the patient is stopping breathing for a period of more than 10 seconds is the apnea index per hour of sleep. And if you combine it with the hypopnea, it is the AHI, apnea hypopnea index. And there is another entity which I will just briefly allude to, is the RERA, which is a respiratory event related arousal. So really speaking, we need to take a combination of all this, which will give us the RDI, respiratory disturbance index. So RERA is a increased respiratory effort for 10 or more seconds, leading to an arousal of sleep. But what is different is that it does not fulfill the criteria for hypopnea or apnea. And anything more than 20 times in an hour of sleep, if your respiratory disturbance index is more than that, that will induce a daytime sleepiness and an increased cardiovascular risk. So all our modes of treatment are aimed at reducing this RDI to less than 20. So if we grade snoring, you could have mild, moderate, severe, more than 60 decibels of sound. Normally when I'm talking, it's at about 50 to 55 decibels, but more than 60 decibels is loud snoring, and the loudest snore recorded in history is 111 decibels. And this is like a jet engine hovering around you while you're sleeping. So if we label severity of sleep apnea, a mild event would be 5 to 15 episodes in 1 hour of sleep. A moderate would be 16 to 30, and anything more than 30 would be counted as a severe sleep apnea. And if you look at the oxygen desaturation, so if it is less than 65, it is severe, and between 65 and 85 is a moderate degree. So let us see what are the symptoms. We all know what is snoring. Snoring is by its volume itself, but there are subtle signs and symptoms of sleep apnea which should not be missed. So if you have a bed partner who is choking or gasping during sleep and is a loud snorer and suddenly wakes up to restart breathing, that could be a sign. Waking up in a sweat during the night, feeling tired in the morning, headache in the morning, excessively sleeping while working in the daytime, morning fatigue, dry mouth, all these are symptoms of sleep apnea. And it leads to a lot of personality changes. Patient can become irritable, there can be memory impairment, and can result in a sexual dysfunction as well. So this article in the Journal of Clinical Sleep Medicine talks about, does snoring intensity correlate with the severity of obstructive sleep apnea? Yes. So if the intensity of snoring is very loud, there is a very high likelihood that the OSA also may be very severe. So we should keep in mind certain factors that are associated. So upper airway masses, if there is a neuromuscular disorder, it leads to poor tone that could precipitate OSA. Hypothyroidism. So we must check the thyroid functions of this patient. Acromegaly, hormone therapies, chronic renal failure, all are associated with OSA. Irritants like tobacco, so smokers will have a higher incidence. If there is alcohol use, the day you consume alcohol, and if the patient is a moderate snorer, his snore will turn into a roar just because of the lowered muscle tone. If you are taking any antihistamines which are sedating, these can tip the patient from a mild snorer to become a moderate or a severe snorer. Weight gain, we will elaborate on that a little later, and the significance of obesity as far as OSA is concerned. Now, this is very important. So far we are talking only about adults, but even children who snore, is it serious? Should it be attended to? Do they become sleep apneic when they become adults? This is a $1 million question. And there are lots of studies which have been done on twins to show that if there is a nose blockage in a child, particularly due to adenoids, the nose not being used as it should be, the palate starts growing upward. So you see this arching that is taking place, and the persistent mouth breathing causes the jaw to drop, and hence the mouth has more space for the tongue to grow bigger. So you have a bulky tongue, and all these facial features result in a child who is a snorer, a mouth breather, turning into an adult who will later on snore and have sleep apnea. So how do we diagnose this condition? A good history taking is very important. Whether there has been weight gain, whether any medicines, drugs are being used. Examine the patient thoroughly. Epworth Sleepiness Scale, a laryngoscopy with a Muller's maneuver, a sleep endoscopy, a PSG, which is the gold standard, a dynamic MRI, and a nasal spray test. So I will very briefly elaborate on all these because these are our way of doing a clinical diagnosis. So as I mentioned earlier, presence of snorts, gasps, observed apneas, periodic leg movements, frequent awakenings, these are all symptoms that we must inquire, do a detailed questioning to the patient. Obesity, this is a very, very important factor because this results in a smaller airway if your neck circumference in males is more than 17 inches and in females more than 16 inches. And this results in an increased collapsibility of the pharyngeal airway. So man from a four-legged animal moved to walking on 2 feet and then straight headed towards McDonald's. And this is what happened. So that's why obesity is a very significant factor. You have 70% of OSA patients are obese and almost 40% of obese patients will have OSA. And this entity called as the morbidly obese. So when you have a BMI of more than 40, 98% of patients will have sleep apnea. So a lot of patients who have undergone bariatric surgery for whatever be the other reasons land up with their snoring and sleep apnea in a large number just disappearing. So when you examine these patients, you need to look at the body habitus of the patient, the BMI. First, look into the nose. Is the septum deviated? Are the turbinates swollen? Are there polyps in the nose? And we have seen patients who have polyps have been given CPAP machines without even checking what is inside the nose, and you treat the patient for the polyposis and the patient's sleep apnea goes away. Look at the size of the tonsils. Look at the bulkiness of the uvula. See whether the palate is high arched. Is this whole space edematous? What is the bulk of the tongue? Can you see the epiglottis? Look at the neck circumference. Look at any neck masses. Look at the mandible in profile. Is there a retrognathia? Look at the maxilla. Is there a recessed maxilla? And of course, do a blood pressure screening on these patients. Now, excessive daytime sleepiness. This is very important. The person in question here, I'm not sure whether he has sleep apnea, but a reason enough to go to sleep anywhere. So you have reduced quality of life, reduced daytime performance, and you do this Epworth sleepiness scale. It's a very simple questionnaire of how frequently a patient is likely to doze off in 8 frequently encountered situations. Simple situations like sitting and reading, watching TV, as a passenger in a car, sitting and talking to someone, sitting quietly after a lunch without alcohol, or at a traffic signal. So if your count is more than 12, then that is abnormal. So this is a very important questionnaire that you can get your patient to fill up, and from that you will come to know that this patient is having ESS or no. But the gold standard is a polysomnogram. So this is a simultaneous recording of the multiple physiological signals during sleep. So this includes an EEG, an EOG, ECG, check the nasal and the mouth airflow, look at the respiratory effort, a microphone if you want to monitor the volume of sound, and of course a pulse oximetry. So this, if we need to do, we need to have the patient coming to a proper sleep lab with a video recording, but that is not always necessary. This is the kind of polysomnogram that comes up and it gives you an idea as to what all is happening. You have the O2 levels, the airflow, the respiratory effort, the sounds, and all the other physiological parameters. But a level 3 study with at least 4 channels, which include the airflow, the effort made by the patient, a pulse oximetry, and the heart rate, may be good enough to diagnose this, and these now can be done at home very easily so as to get an idea if the patient is apneic or not. But if there is some doubt or if something else is being suspected, then in that case, you must do a full PSG. A very simple test to find out if the nose is a contributor. You ask the patient to use the decongestant nose drops and ask the spouse to compare the severity. And if it's much better, it indicates that there is a very simply a nasal obstruction which is responsible for this problem to get aggravated. But to diagnose where exactly is the blockage that is happening, we do what is known as a sleep endoscopy, a drug-induced sleep endoscopy. And this tells us exactly where the blocking and the narrowings are, and we can diagnose where the condition of obstruction is. Certain other parameters include radiological, so cephalometry, we have various parameters to find out which angles are incorrect, which lengths are incorrect. You can do a CT scan to diagnose if there is a nasal obstruction. You can see if there are polyps, adenoids. Of course, in children, we don't want to do CT scans, but it can diagnose the site of obstruction. And something that has been very well studied is a dynamic sleep MRI. So this tells you exactly in a dynamic fashion. So the patient goes into the MRI gantry machine, and while the patient is asleep, you can actually check which parts are collapsing. Now, why it is important to know where the collapse is, because then only can you address the problem properly. So once again, this slide showing that what are the grades. So once we know how severe is the problem on your PSG and your other parameters, you try and diagnose where is the problem. And here there are three types. So first is an obstruction at the palate with the tongue being normal, which is a type 1, or an obstruction at both levels, at the palate as well as at the level of the tongue, which is a type 2, or only a type 3 where there is an obstruction at the base of the tongue, the palate is normal. So a lot of treatments and a lot of trigger happy surgeons have gone and tackled a palate and done a UP3 surgery, whereas the problem was at the base tongue. So the surgery got a bad name because the problem wasn't at the level of the palate. So coming to the treatment. Now, how do we treat snoring? How do we cancel this snoring? Medical treatment, unfortunately, there's nothing very much that one can offer, but certain devices and surgery can be one of the treatment modalities. So having said that there is no medical treatment, but conservative treatment will help greatly. The most important thing being weight loss. You have to ask your patients to lose weight, and it's important that they maintain losing this weight. It has to be a journey where you always try to remain slim. Sleep positioning. Ask your patient to sleep not on the back, never on the back, but on a side, and that will reduce the snoring. Sleep timing and hygiene. So the spouse who is the sufferer is the one should go to sleep first and then the patient. Allergy medicines, make sure you're not taking any sedative antihistamines. Completely avoid alcohol and smoking, which also aggravates the sleep apnea. Do exercises to reduce weight, and a very important, myofunctional exercises. So these are exercises that help to stiffen the tongue. So these exercises you can see on the net, various exercises have been described. CPAP. Now CPAP is the gold standard in the treatment of sleep apnea. We know this for many, many years because what it does is that a continuous airflow acts as a pneumatic splint and prevents the collapse. And this restores the normal respiration during sleep. Today, you have very good machines, and what one recommends is an auto CPAP or an auto BiPAP if there is a difference in the pressure levels during inhalation and exhalation. But we must always remember that sleep medicine is dominated by CPAP. But very importantly, the compliance rate is very poor. Less than 40 to 50% of patients do not continue to use their machines, and particularly in patients who have a mild sleep apnea or a moderate one. It's the severe ones who will definitely want to go on to. So we need to offer treatments to all our patients and not only to the severe apneics. So as I mentioned that CPAP therapy increases the caliber of the airway and increases the lateral dimension of the upper airway and prevents the soft tissues from collapsing. So you have various types that are there. You have the nasal insert, you have the full face mask, you have the nasal mask. So depending on what the patient is comfortable with is what the patient should be using. There are various other devices, more than 250 patented devices may be there on the internet. You can find these other than, of course, the CPAP, these dental appliances. So you have the mandibular repositioners, which help to make that retrognatic mandible in the correct position, or the tongue retaining devices to prevent the tongue from falling behind, or these chin straps, which again prevent the collapse from happening, and a very popular breathe right nasal dilators. But we must remember that it is not common thing for everything. It is not just one device that will help all your patients. Depending upon the site of obstruction, the patient will benefit. So if the patient has a tongue that's falling and you are giving the patient a breathe right dilator, is not going to help. So we have various shapes and sizes of all these devices that have been described in literature. Drugs, nothing much. Modafinil has been tried, which for patients with residual daytime sleepiness, but not with very great benefit. People have also tried other selective serotonin reuptake inhibitor agents, but these have very limited role. They only help to decrease the REM. So coming to something that has now once again revived, which is surgery. But again, we must remember that there is no one size fit all situation. We have to tailor whatever you have to do depending upon the requirements of the patient. So what is the philosophy of management? So if we have an infarct, a heart attack, what do we do? If find out where the obstruction is, put in a cardiac stent, and if that doesn't work out, then do a CABG. So similarly, sleep apnea surgery, we like to tackle the soft tissue first, and if it does not work out, then either do a revision or then do a bone related surgery. So if we look at the entire pharyngeal airway as a container, and the palate and the uvula and the tonsils and the tongue as a content, then we address the content first and then look at doing something for the bony cage. So there are various surgeries that have been devised, which a long list of these is there. I will very briefly allude to this in the next 5 minutes, ranging from nasal surgeries to palate surgeries to mandible surgeries to even a tracheostomy. So if there is a significant deviated septum, septal correction is what is advised. The turbinates, if they are bulky, we would like to shrink them. If there are polyps, medical line of treatment or polypectomy or radiofrequency. If there are bulky tonsils, big palate, loose, lax palate, look at doing a UP3 surgery, whether you use the laser, which was in the very early days, or radiofrequency. So this is what one will achieve by doing a reduction of the contents inside the oropharynx. And something that is now coming up, barbed wire pharyngoplasty, I will allude to that a little later, and palatal implants. These showed a lot of promise, these palatal implants into the soft palate, but the chances of extrusion have made them unpopular. So this is what we do in a uvulopalatopharyngoplasty, where the excess length of the uvula and the bulky tissues, including the tonsils, are removed and tightening sutures taken. So this opens up the airway significantly. This is a barbed wire pharyngoplasty, where after creating a raw area, this barbed wire, which is 2 needles at both ends, hitches the raw area to the pterygomandibular raphe near the hamulus. So this is what the picture would look like initially, and these stitches take the pharyngeal wall laterally and open up the airway space. Various other bony surgeries have been described also reduction of the tongue base, move the mandible forward, suspend the hyoid, move both the mandible and the maxilla forward, and something that in the years to come may hold a lot of promise, which is the upper airway stimulation surgery, where the hypoglossal nerve is stimulated to contract whenever there is an apnea that is happening. And in a worst case scenario, sometimes one may need to do a tracheostomy also if nothing works for the patient. So the newest technology, which has shown a lot of promise, is coablation. So this is basically a low temperature plasma excision, where we are using electrical energy to excite some electrodes in a saline medium. The temperature is less than 70 degrees. So it's not electrocautery or where it is charring the tissues. It's a specific temperature. And these energized plasma particles, they break the molecular bonds and cause a tissue ablation. So this is a patient where a UP3 uvulopalatopharyngoplasty is being done using the coablator wand. So you can see this wand, and we are making a cut trying to open up the band over here. Look at the ease with which this surgery is done, hardly any bleeding in this surgery. So this has revolutionized things significantly. The same is repeated on the other side. and then the excess part of the uvula is also excised. Similarly, a tonsillectomy also can be done using this technique. It reduces the bleeding significantly. Or an adenoidectomy. Now, this has also greatly revolutionized. So, even a 2 or a 2.5-year-old child whom the ENT surgeon would fear to even tackle and operate, these are the patients where you can do a very effective ad. So, look at this blade. This is actually the coblation wand, and with the ease of this suctioning, hardly any bleeding. So we're not worried about any blood loss. And you can literally layer by layer ablate the entire adenoid tissue. And finally, the space has been opened up significantly. The other ways where this wand can work is create the lateral cuts to open up the airway and then do a channeling. So this channeling later on in the healing process will result in scarring. So the loose lax tissue is what we are trying to stiffen with the help of this coblation wand and channeling. So the picture, which was like this, finally becomes wide and open like this. So the advantages, of course, are significantly less bleeding, there is less pain, there is faster healing, and fewer bad days, because this oropharyngeal surgery can sometimes be very, very painful. And this has revolutionized things to a great extent in the last, I would say, 5 to 7 years. So friends, that more or less sums up the current management of snoring and sleep apnea. And we realized that something that used to be a topic of jest in the 80s is no longer funny, and certainly not hopeless with all the new modalities of treatment that we are now having in our armamentarium. And this last adage saying, laugh and the world laughs with you, snore and you sleep alone, probably would be history. Thank you.
Thank you, Samir. That was an excellent presentation, very lucid language, and you explained almost everything about snoring. You mentioned that more than a snorer himself, the family members bring him to the clinician, and you should diagnose whether it is severe, mild, or moderate. And during sleep apneas, patient can get increased blood pressure, arrhythmias, and he can develop stroke and even MIs. And it is a cause of sudden deaths also in some cases. So it is very important to investigate the patient thoroughly. Weight gain or obesity is a main cause of this snoring and obstruction. And these obese patients should undergo the sleep studies. Sleep studies are done at a center or at home also, it can be done. But the level 3, minimum level 3 study with 4 channels is very important that you mentioned. Clinical examination of the patient is also very important, because many times when a patient comes with a history of snoring, they are referred for sleep studies and put on CPAP machines. And if there are any obstructions in the upper airway, which can be treated with medication or by simple surgeries, which can relieve their snoring and sleep apnea, they are missed if you don't do proper clinical examination. You also explained all the treatment modalities and importance of surgical treatment also when but the gold standard in sleep apnea is CPAP machine, but obstruction also should be relieved. And why this surgery become important? Because of the non-compliance of the patient to CPAP machine, because 40 to 50% of the patients, they discontinue using and they can land up with serious complications. So lifestyle change is also very important in the treatment of sleep apnea. That is losing weight, uh, reducing smoking and alcohol consumption, uh, to avoid taking uh, sedatives during while going to sleep, like antihistaminics, and positioning during sleep is also very important. If you sleep sideways, not supine. Supine position will increase your obstruction. So in sideways, in lateral position, it will reduce. And also one important thing which you mentioned, that the spouse should go to sleep first, then the patient. So that is also a very good point, I think you mentioned. And now we'll invite questions for the uh, from the delegates. There is one question: where can we get? We can buy mandible devices.
So these mandible devices are of course available now, and everything and anything is available on Amazon. But you must consult your either your ENT local doctor or the maxillofacial. So these can make a specific device tailored, suited to what is exactly the problem. So what happens is then whenever things are just bought across the counter without an actual measurement, they will not work that well.
Samir, can sleep apnea itself lead to weight gain?
Yeah, so it's a vicious cycle that because one is lethargic because of having sleep apnea, you do not have the energy or the feeling that you want to do some exercise, and then it leads up in a vicious cycle. So whether the chicken came first or the egg came first, it is difficult here to say. But yes, sleep apnea itself will lead to increased weight gain.
Thank you, Samir. Now I invite MOC for the further proceeding.
Thank you, Dr. Bhargava sir, for a brilliant lecture. Thank you for sharing the various diagnostic tools and the investigations and the modalities of treatment. Thank you, Dr. Shirali sir, for moderating this section. I now request the IMAFEST team to felicitate the speaker, Dr. Samir Bhargava, with a e-memento. Thank you, sir. Thank you for a kind participation. I request the team to give a e-memento to Dr. Shirali for moderating this session. Thank you, sir. I extend heartfelt gratitude to Abbott Pharma. Thank you, Sun Pharma and Radiant Division. Before we proceed to the next lecture, I want to make a few announcements. A gentle reminder to all the listeners to please write in your name to avail MMC points. If you are unable to do it because of any reason, you may type your name, MMC registration number, along with your email in the question answer section. Now we move on to the next lecture. LGBTQ is an umbrella term for the sexuality and gender identity. It stands for lesbian, gay, bisexual, transgender, along with the letter Q for all those who question their sexual identity. Indian society is very rigid when it comes to defining career, marriage choices, and LGBTQ community has faced intense prejudice, discrimination, isolation, and even violence because of this. All this has caused a lot of psychological impact. To discuss this issue further, I welcome the moderator for this session, Dr. Advait Padde, consulting psychiatrist, director of Manas Health Center, and author of various books on mental health awareness and rehabilitation. He will introduce our speaker for today, Dr. Avinash D'Souza, who will speak on LGBTQ mental health. Are we ready for the challenge? Welcome, sir.
Thank you, Dr. Suchitra. Today, we have selected an offbeat topic, but yet very important topic. And it is my immense pleasure to introduce my friend and eminent speaker, Dr. Avinash D'Souza. He's a research associate at the Department of Psychiatry, Lokmanya Tilak Municipal College, Mumbai, founder trustee of D'Souza Foundation and Trust, which works in the area of mental health awareness across all sectors, associate professor and secretary of International Institute of Organizational Psychological Medicine, an organization that works in the field of organizational psychological medicine across 7 countries, international faculty for UNESCO chair in bioethics, working in over 8 countries for the same. He is Chief Editor for Indian Journal of Mental Health, Associate Editor for Annals of Indian Psychiatry, Industrial Psychiatry Journal, Global Bioethics Inquiry, Assistant Editor for Indian Journal of Psychiatry, works with 8 mainstream and special schools in Mumbai as a visiting school psychiatrist, counselor and school mental health expert, visiting faculty and professor at various teacher training courses across Mumbai at multiple and psychotherapy training programs across India, has over 700 publications in national and international journals, and is the author of 12 books in the area of mental health. One of the few psychiatrists who, in addition to psychiatry degree, has a master's in counseling and psychotherapy, and MPhil in applied psychology, and MBA in human resource development. He has been awarded a doctorate in clinical psychology from the University of Hertfordshire, UK in the year of 2011. So presenting to you an eminent speaker, Dr. Avinash D'Souza, who will speak on LGBTQ mental health. Are we ready for challenges? Dr. D'Souza, please.
Yes. Please enable me to just share my screen 1 minute. Yes. Okay. I've got that. Good morning, everyone, and it's an absolute pleasure to be here. Well, thank you, Advait, for inviting me, the entire IMA team for inviting me. Are my slides visible to everyone?
Yes, sir.
Yes. Okay, thank you. My topic is offbeat because the LGBTQ plus community has come into, I would say, the limelight or awareness more so in the last 5 to 10 years, not before that. And I would say in the 80s and 90s, homosexuality was regarded even as a disorder. So it was very often treated psychiatrically. It's only now that we look at it more as a way of life, and we look at it as an alternate sexuality. So I'm going to be very basic because the whole aim is to open up this avenue just to primary care physicians who may sort of come across this, so that you have an idea. General disclaimer that I would want to say is that it's a very special population. So one thing which I often tell many physicians, even many psychiatrists, many psychologists who I meet is, do not treat these patients for their LGBTQ plus related problems if you're not comfortable in that area. You personally have to, have a relative comfort to try and hear them out, understand them, and be non-judgmental from your own side. If you are non-judgmental, probably it would help better. So I just want people attending here to know that there is an association called HPQI, which is called Health Professionals for Queer Individuals. If you go online, you can register yourself with your specialty there. The whole aim is that people who belong to this community, they like to go to doctors who are sensitive to their needs. Otherwise, they have found very often that some doctors may not be really aware about what terms to use and what to say. So therefore, you could register them. Certain cautions also, I would say, is that take help from an advice from an expert in this area while you're treating a patient. One of the common myths with regard to, and I'm going to talk about myths and facts related to mental health because I think that's very, very important. One of the commonest statements I have come across when I have spoken to professionals is, we don't see LGBTQ plus patients in our practice. And, we don't really know anyone who belongs to the LGBTQ plus community. So your lecture, your talk, this is of very little usefulness to us. But the fact is that individuals from the LGBTQ plus community are all around us and you may not even know it. They're not going to openly come to you, thump their chest and say, yes, I belong to the LGBTQ plus community, because they know acceptance all over may not be the same. Even patients who come to you for cough, cold, fever, ENT problems, surgical issues may not tell you their sexual status, and it may not be related to their problem. So you may not really know. It's only as psychiatrists when they come to us very often, when we ask them about their sexuality, their orientation, their preferences, then it is at that time that they very often reveal to us that, yes, I am either bisexual, or I am lesbian, or I am gay, or I am belonging to this particular kind of sexual orientation. So these people are all around, and I think they're all over India. They're there in the rural areas, they're there in the urban areas. It's just that people aren't aware and we don't really think about them. A common myth that people have is that members of the LGBT community are promiscuous in nature. When I mean promiscuous, they are sexually hyperactive and they're always looking for sexual partners. Another issue here also is that they cannot have mental health issues. Both these are myths which are very often seen, and it's very important to understand that members of the LGBT community may be as likely to be single, partnered, live with their partners, be faithful to their partners like anyone else, and they may have mental health issues like you and me. They have two lungs, the same heart, the two kidneys, they have everything same, everything functions. Cardiac failure in them and us does not change. The symptoms of respiratory distress in them and us does not change. The symptoms of depression, anxiety, and various other mental health issues also do not change, though the environment and social factors probably causing these issues may differ a little. Though at times the presentation of depression is similar, the treatment of depression is similar, the treatment of anxiety is similar, nothing really changes. It's only that the factors that have led to this depression and anxiety may at times change or vary. Also, what's very important to know is that a common issue is that you see a lot of aggression and violence happening in their relationships, which people are not aware. Many people feel that no, their LGBT community people are always happy-go-lucky and never have a problem. But as a psychiatrist, when you treat someone from the LGBTQ plus community, you will find one of the major reasons they come to you is relationship issues. Now, here again, I caution a number of professionals that their relationships are a little different because they are same-sex couples. So their love, their feelings, their affection is similar to that of any other couple. But you're not doing marital counseling there. You're doing couples counseling for LGBTQ plus individuals. So you need to be a little cognizant about the fact about how their relationships run. They also have trust issues. They also have jealousy. They also feel upset when their partner leaves them. They have partners who have affairs with other people, though they are committed in a relationship, just like we see in our normal heterosexual relationships. Also, very importantly, one of the things I want to tell you is that when you question a person who about sexual orientation, one of the common mistakes made by health professionals is you ask them, is your sexual orientation straight? There is no crooked sexual orientation. And that very often hurts members of the community. They believe they either is heterosexuality or there are alternate sexualities, but you don't normally use the word straight. It's a term which we use as a slang. It's a term which we use in our day-to-day conversations, but it's not a term that they prefer to be called as. And similarly, a common question which we ask patients who come to us, when did you feel you should become homosexual. Please do not use these terms because again it offends them. I'm not saying this so that I am here to,
कधीपासून
uh,
ताप वगैरे काय आला होता?
can they just mute whoever is, yeah. So I would normally not want, the reason I'm saying this is because in a primary care setting, when you have a large number of patients, sometimes we may ask these questions very generally. So it's something that you should be aware when you deal with these people.
ते पण 2 दिवस झाले.
Another issue that also comes up here is why I'm saying this is, these are all issues with which people will come to you. Now, members of the LGBTQ plus community also sometimes experience a lot of anxiety, a lot of panic. One of the most common reasons why they experience this anxiety and panic is stigma. When they are taken to see a doctor, and I'll tell you, many of them may present with simple sexually transmitted diseases to a primary care physician. And at that time, if you may see that, yes, there are sexually transmitted diseases which could be penile in nature or anal in nature, and very often you want to question them, you have to have that little sensitivity to ask them what happens. And they face this stigma very often that they say doctors change their attitude the moment they realize that we belong to the LGBTQ plus communities. The moment I tell the doctor that I am gay, or the moment I tell the doctor that I am homosexual, immediately they suspect that, yes, probably you have HIV, and they get an HIV test done. And that immediately adds to our stigma, which is a common myth again, that HIV statuses are higher in this community, but it isn't. It is the same as that seen in the common population. So these are things which often come up. I'm going to skip this one myth. Yes. A very common myth that people often have is that members of the LGBT community may engage in child sexual abuse. Now, why I'm saying this is very important from the mental health perspective, because many members that belong to the LGBTQ plus community may not engage in child sexual abuse, but they may themselves have probably been victims of child sexual abuse. So you have to be very careful when you address this issue with them. It's a very sensitive issue. I would request physicians to talk to members of this community alone, because their close family members also may not be aware of their status. Their close family members may also be not aware of the fact that they have these issues. And the worry is that you may sometimes get someone who comes and tells you, should I reveal this to my family members? The process in psychiatry is referred to as coming out. Should I say this? Should I say this to my parents? Should I tell them that I belong to the community? As a general practitioner, he's probably seeing you for many years and has some faith in you. As a physician, he's seeing you for many years and has some faith in you. Please assess his family situation, cultural background, orthodoxy before you advise him whether he should come out or not, because it could sometimes have serious repercussions. There are a lot of people from this community who develop depression post coming out, who develop anxiety post coming out, and it becomes very, very difficult at times. Also, another mental health issue that worries members of this community is bullying. The moment people come to know that someone belongs to the LGBTQ plus community, they are bullied, troubled, tormented at the workplace. They are bullied, tormented, troubled in college. They are bullied, tormented, and troubled in schools. Nowadays, those of you in primary care practice working with adolescents will see young adolescents in schools at the age of 14, 15, and 16 coming to you and telling you that I think I have tendencies which are lesbian or gay. And I don't find myself getting attracted to members of the opposite gender. It's very important as physicians that we do not jump to sort of label them as belonging to the community. One very important mental health implication, which I wanted to tell you, is that it's very normal for adolescents to explore same gender sexuality while they are in adolescence. So it can happen that, there may be an occasional homosexual encounter for a girl. There may be an occasional homosexual encounter for a boy. So normally what I tell children who come and adolescents who come to me with this issue in school is,
fine, if you feel this way, we respect it, but we wait till you're 18, 19, 20, 21 and see in which way your sexuality moves. We are not in a hurry to label them as belonging to this community because sexual orientation is in development at that phase. It's also important that these facts aren't revealed at the workplace. These facts aren't revealed where he works because he'll be looked upon with a lot of negativity. Also, a lot of people believe that suicide rates in the LGBTQ plus community are low, but that's not the case. Suicide rates are equally high compared to anyone else. Self-injurious behavior is equally high because they have different kinds of trauma. They are rejected by their close friends, they are rejected by their family members, they are rejected by housing societies, their friends leave them and go. People don't talk to them, they aren't invited to weddings once people come to know that they belong to the particular community. So these are the issues that they face. They are ridiculed by their parents. A large number of parents face a lot of shame and guilt with regard to the fact that their son or daughter belongs to the LGBTQ plus community. Since we are on suicide, I'm going to just digress for 1 minute, and I want to say this to all members of the IMA Dombivli group that yes, you have, of course, excellent psychiatrists in your area, but one fact that has remained is whatever we have done all over Bombay, all over Maharashtra, suicide rates haven't reduced. So I would want that IMA Dombivli in the long run takes up something with regard to suicide prevention. And I think that is something which we should take up. Advait and his team could take that up. But this is just since we were on suicide, I digressed for 1 minute. Also, a common thought is that all members of the LGBT community abuse alcohol and drugs. A lot of people feel they are into drugs and alcohol. That is why they get into this LGBTQ plus formation. No, it's not true. Members of the LGBTQ plus community do drink, they do use alcohol, but the rates are similar to that of the general population. They drink because they are depressed. They take to drugs because they are upset. They use that as a coping mechanism to cope with their issues. Do not think or perceive that giving them an antidepressant would change their sexual orientation. No, that's a very common mistake that people make. You know, he's depressed, he's upset, so that's why he's behaving in this LGBT manner. Probably if you help him to sort of overcome his depression, he will recover. No, it doesn't happen that way. Their stress rates are similar to the general population, and so are their alcohol consumption rates. Another common myth with regard to the mental health of LGBT people is that all members of the LGBT community are well educated and rich. It's a fad of rich people. The fact is no. Mental health problems, depression, anxiety are seen across the board. We see it in the rich, we see it in the poor, we see it in the rural areas, we see it in the urban areas. Similarly, members of the LGBT community come from all walks of life. I have seen members of the LGBT community from South Bombay, and I've seen them from Dharavi since I work in Sion Hospital. They come from all walks of life, and their mental health issues are similar. One question which I always ask every patient that comes to me from the community is your depression purely work-related or related because of a problem with your mom? Or do you face depression also because there are certain factors of belonging to the community that cause it? And they'll very often tell you, yes, sir, in my own community, there is competition, there is ridicule, there is multiple things. So you have to rule out those factors as well. While they may also have financial issues, they may have loneliness, they may have issues with their parents, they may have issues at work, which cause depression. So multiple factors can play a role together. Like I told you, they do face discrimination at work. And members of the LGBTQ plus community respond to medication as much as anyone else does. I remember I was a little upset when I attended a program where one of the physicians mentioned that, don't you think because they belong to the LGBT plus Q plus community, antidepressants and anti-anxiety drugs will work less in them? There is nothing like that. Their brain is as functional as your brain and my brain. There is nothing like a LGBTQ plus brain which is different. So antidepressants and anti-anxiety drugs, SSRIs like escitalopram or sertraline or fluoxetine or duloxetine, and drugs like clonazepam or alprazolam will work the same way as they work in anybody else, because their brain is the same, their receptors are the same. It is acceptance which is a problem. A lot of people feel that members of the LGBTQ plus community can use health and mental health services freely. This may not be true. They do face a lot of stigma and ridicule. And not all health and mental health professionals are equipped to handle their issues. The term I used some time ago called coming out is a term when a member of the LGBTQ plus community informs his friends, his family, that I belong to the community. I remember one of the psychologists did not know what the term coming out meant. And she asked the patient, where did you come out? Was it that you went for a walk? Was it that you went to the garden? Where did you go? And the patient felt very insulted that this professional doesn't know what I mean. Similarly, for that matter, very often colloquial terms, in the sense that, a lack of respect shown, that I remember a doctor who came to me with his son, who came out to him and told him that I belong to the LGBTQ plus community. And the doctor told me, sir, he is now in the 3rd year of his MBBS. And he's telling me that he is LGBTQ plus. Do you think he'll make a good doctor? I said he will. It doesn't mean that because he belongs to that community, he's not going to be able to study medicine. He's not going to be able to operate. He's not going to be able to think. He's with this one particular boy he likes for the past 1 year. It's like being with a girl you like for the past 1 year. It's a very normal relationship. I thoroughly understand that my views at times may be a bit, a little radical for our society, but the whole aim is that to make you realize that this is what happens. Parents of members of the LGBTQ plus community feel very depressed. I've had a doctor parent, the same doctor parent said, I had great ideas for my son's marriage. Now what am I going to do? I had thought of a girl who's my best friend's daughter to marry him, and I've given my word. What am I going to do? What do I tell the world? That my son is gay? We have eminent doctors in Bombay that belong to the LGBTQ plus community, and they're doing good work. Some of them have come out and admitted openly, some haven't. Also, another myth is that members of the LGBT community, being non-religious, face more mental health issues. It's not true. Members of the LGBTQ plus community can be as religious or spiritual as anybody else. They go to church regularly, they mix with others regularly, they do everything possible that the others do. We need to counsel them like we counsel anyone else. We need to treat them like we would treat anyone else. We need to examine them like we examine anyone else. I remember a particular doctor who was a chest physician told me that this particular person comes to me who belongs to the LGBT community. He has a chest issue. I have to examine his chest. I have to at times examine him. And I think that, maybe I feel a little uncomfortable doing it. And I said, has the patient done anything out of the way while you were examining him? He said, no. Has the patient touched you or done anything that you felt inappropriate about? He said, no. These are our own roadblocks in our minds that we very often have. That we think that a member of the gay community is after every other man. No, it isn't that way. They are also very strict and rigid in their relationships, just as we are. Certain religions may not permit it. Yes, that's a religious perspective. Medically, we do not hold our biases towards members of this community. Many physicians practice sexual medicine. And a common myth is that members of the LGBT community do not experience sexual dysfunctions. This may not be true, and members of the LGBT community experience sexual dysfunction just like any other member of the general population. We've had a lot of members come to us with premature ejaculation, with erectile dysfunction, with anorgasmia, with inability to experience sexual pleasure, and we have treated them like we would treat any other person with sexual dysfunction. The partner may be different, but the mechanism of sexuality is the same. So the mechanism of erectile dysfunction doesn't differ in an LGBTQ+ individual. The mechanism of premature ejaculation doesn't differ in an LGBTQ+ individual. The mechanism of lack of sexual desire does not differ in an LGBTQ+ individual. This is another myth we have, that all members of the LGBT community may have AIDS. No, they don't. Don't get on the back foot and give them and not examine them. They are the same as anyone else from a medical perspective. Their liver functions the same way, their gallbladder functions the same way, their mind functions the same way. Yes, they have some environmental factors that do play a role, which are different. A very important aspect is we all know about geriatric psychiatric issues that confront us. Dementia, geriatric depression, geriatric anxiety are very, very common. We believe there are very few elderly that belong to the LGBT community, but that's not true. And there are many elders that are present in the LGBT community. They probably have never told anyone because they were belonging to this community in the 1970s and 80s, where it was a taboo to even mention that they thought this way. Today, they are 65+. They have their own group in Bombay, which is called Seen-agers, not teenagers, Seen-agers. It's a support group for elders that belong to the LGBT community. They face geriatric depression, they face dementia, they face forgetfulness, they face anxiety issues in old age, loneliness, just like anyone else faces. Please, as a member of the medical community, do not think that belonging to the LGBT community is a matter of lifestyle choice. No, it isn't. There are many factors that play a role in determining sexual orientation, right from genetic to biological to multiple factors. And there are multiple factors that play a role in determining one's sexual orientation and preference. So it's determined partly genetically, partly biologically, partly environmentally. So there are multiple factors. It's not a lifestyle choice. I don't get out of bed one day and decide, oh yes, I'm going to belong to the LGBTQ+ community. No, it doesn't happen that way. I want to narrate my own personal experience in this field. Up to a few years ago, I really didn't know much about the LGBTQ+ community. It was by chance that I was pushed into working with the LGBTQ+ community when the Indian Psychiatric Society, which is our largest body of psychiatrists, requested me to be part of the LGBTQ+ mental health task force. And at that time, I told them, sir, I know nothing about this. Myself, Dr. K.S.C. Chawda, another psychiatrist from Mumbai, and Dr. Amrit Pattojoshi from Bhubaneswar, we were pushed into this. We pleaded, begged, and tried to squeeze our way out, but it didn't happen. And when we went home, told our families, they said, oh, you all are going to get labeled, your practice will go down, people will think you all are also belonging to this community. And we faced all those kinds of worries. And they said, soon people will think that probably you also have some personal interest in this community. That is why, you're a doctor working for them. Because we've always worked in child psychiatry and school psychiatry and nothing beyond that. We ourselves had to go and read about mental health issues, read about what matters, particularly when working here. We were very lucky to be backed by the IPS president, Ajit Bhide, who at that time was, very proactive and we became a part of history without really wanting to be a part of history, because it was in our tenure with our statements given to the Supreme Court that Section 377 was withdrawn. And today, fortunately, unfortunately, everyone in the community knows us. And they come to us thinking that we were people who have changed the face of their life. No, the struggle had been going on for many years. It was luckily in our tenure that this happened. So we got the credit. And then, of course, we've had other members of the task force that have been running this. But what I'm trying to tell you is I've had patients come to me. Initially, I was as uncomfortable as anyone else. But over time, I realized that these are individuals who are just like you and me. Yes, their sexual orientation is different, but otherwise there's nothing wrong with them. And they would give you the same amount of respect, the same amount of regard that anybody would give any doctor. They never in their behavior behaved in a manner which was rude, inappropriate, or something which would make you feel uncomfortable. No. And rather they would say that we have psychiatrists who at least understands our perspective. And I think they need physicians, they need doctors, they need endocrinologists, they need gynecologists, they need surgeons, they need cardiologists, they need everyone who understands their perspective. We are in the year 2020. In unprecedented times, we've been through a pandemic. We're going into 2021. In an era where I think life is changing. We have to change our perspective and we have to shed the archaic garbs that we have and realize that the new world is going to be very different. Let us open not only our minds, but our hearts. Inclusion and management of mental health issues of the LGBT community won't happen till we change our brains to accept them. Then only we'll probably be able to handle them. I end with this quote from Pope Francis. If someone is gay and he searches for the Lord and has goodwill, who am I to judge? We shouldn't marginalize people for this. They must be integrated into society. Thank you. So you're muted.
Thank you, Dr. Avinash, for your lucid and an excellent presentation, and which was an eye opener for almost all health professionals. You dwelt with in detail about so many myths about LGBTQ and explained the facts in detail. There are many general health and mental health issues which are same in all the people, whether they are LGBTQ or they are of heterosexual community. Challenges are there, but our rational acceptance is going to make things easy for all of us and for LGBTQ community per se. And you narrated it through a self-experience about it, and we are very glad to hear that you were the and also congratulate you for being a part of that mental health task force regarding section 377 IPC. So there are many questions about your topic also. So we'll have some question answer session. There is a question that is the incidence of LGBTQ is increasing, or they were there and now they are coming out openly? And also there is a sub question that are there any structural brain changes in these?
Okay. The first question is, I think they were there, but they never came out. Now probably they're coming out more. So we feel that the incidence of people belonging to this community is increasing. So I don't think it's increased. It's just that they're coming out more. Well, there are some fMRI studies that talk about certain minor structural changes in the brain that does happen. And these are more functional changes than structural changes, particularly, for example, if say you take my brain, put it in an MRI and show me photos of beautiful women, I will have my sexual centers probably light up. That may not happen if you show pictures of women to a man who is gay. And if you show pictures of men who are attractive, probably the sexual centers light up. So what does happen is functional changes happen more than structural changes. It's not that there are the sexual centers are smaller or bigger or anything that way. So there are a large number of MRI studies where functional changes have been noted rather than structural changes.
Another question is, what are the causes of this different sexual orientation?
See, I think the causes are, one, they say it does run in families, but there's no gene that has been discovered. Second, I think exposure to child sexual abuse, I think, is one of the foremost causes that very often makes them develop some kind of either attraction or a sort of aversion towards certain forms of sexuality, which makes them explore alternate sexualities. Apart from that, I think there are environmental factors and personal sexual preferences. So some people may prefer members of the same gender, some people may not. So the environmental factors play a role. Accidental, incidental exposures at times may play a role. So there are multiple factors together put in that play a role. Psychological trauma. Apart from that, having seen, I think one of the main psychological factors that I have seen also is people come to me and say that they've seen normal relationships, normal sexual relationships, meaning husband-wife relationships, fail, and they feel probably men and women don't understand each other, and men would be able to understand men better, and vice versa. So probably that also puts them into this thing. But these are not hard and fast causes. These are factors.
There is another question that if the LGBTQ person knows about his orientation and still marries to a heterosexual person, and later that spouse comes to know about his orientation, his or her orientation, and then if the complaint is been done, then whether it's called as a crime or what?
No,
Yeah,
it
from a legal
definitely,
perspective.
yes, there have been many instances where this has been a ground for divorce and separation, but it's not been a criminal offense because now it has been decriminalized as a whole. One thing I will tell you is I remember a case I saw where I had a banker who was 48 years old, who came with his wife who was 46 for marital issues. They had two children. One was 12-year-old and one was 14-year-old. And um, it so happened both were bankers, both were working. The wife went out for work. She was going to Pune. Midway, her meeting got cancelled, so she returned. When she returned home, she found the husband in bed with the best friend, with his best friend who was male. And they were family friends for many years. Their children would play, they would meet for Diwali and multiple things. And she was shocked to see the husband in this form of a homosexual orientation with this man. And then the husband admitted that he had been with this man for the past 25, 26 years, and they were in a homosexual relationship, and he got married because of parental pressure, societal pressure. He had to produce children because of that, and their own personal sexual life wasn't really great. And this lady threatened to come out into the open, tell his bank, tell his workplace, but she said, I'm going to tell the children. The man frantically called me and said, please tell her not to tell the children because I don't want them to know, because what would they feel about me as a father? So they all came to my clinic, and the wife came and started crying bitterly. And she said, I told both my children that your dad is homosexual and has cheated on me. The children who were 12 and 14 said, so what if he's gay? We love him. He's been an excellent father. He's never done anything out of the way to us. You be the one who's been not treating him well for the past 10 years, and we for the past 7 or 8 years, and we've been seeing it. You're always shouting. And we love our dad. If you want to separate from him, you can leave. We will stay with our dad. So, so this is the new generation that thinks. So I just wanted to bring this out here. Yeah.
So that rational attitude should be there about
Yes,
the orientation.
yes.
So, but still we come across many, like you mentioned also in your presentation, that many parents who come to know about their child's different sexual orientation, and they come to us for changing the orientation. So can
Yes.
we really change the sexual orientation?
I don't think you can change that at all, and it's unethical to even tell them that psychiatric treatment can change orientation. I think we have to probably counsel them to accept that this is what is going to be. Acceptance may not come immediately. It may take months, weeks, years at times, and finally probably then it would come.
And one last question, are there any support groups for LGBTQ community?
Well, there are support groups for LGBT. Like there is an NGO called Humsafar, the Humsafar Trust. So if you approach them, there are support groups for parents of LGBTQ plus also. So they can probably go there, and there are support groups for siblings of LGBTQ plus also. So they can probably go there and get help.
Thank you, Dr. Avinash, for your great presentation and great explanation about the issues related to LGBTQ community. Now I hand over to MOC.
Our sacred text Rigveda says Vikriti evam Prakriti, which seems that what seems unnatural is also natural, which recognizes various sexual dimensions of human life like all other forms of diversity. I think what Dr. D'Souza said was right, that it is time that we should open our minds and our hearts too. Thank you very much, sir, for a lecture on an offbeat topic. It was brilliant. And now I request the IMAFEST team to present a e-memento to Dr. Avinash D'Souza. Once again, thank you, sir. Now I request the team to give a e-memento to Dr. Padde. Thank you very much. I thank Sun Pharma for the educational partnership. Before we move on to the next lecture, I want to make a gentle reminder for the UP Rao oration at 12:30. A child is the most beautiful gift to this world. Fall 7 times and stand up 8 is a Japanese proverb, which means that you can become a parent if your heart desires. This is where the IVF doctors come to our help to lift our hopes and shape our future. We welcome our own Dr. Krishna Kumar sir, the chief consultant at JK Women's Hospital. He is responsible for putting the town of Dombivli in the map of India after he became the president of Indian Association of Gynecologic Endoscopists for the year 2020 and 2021. I welcome sir to introduce the renowned IVF specialist and the beautiful Dr. Rishma Pai.
Good morning, everybody. Am I heard? Yeah. Hello. Yes. Can I speak? Good morning, everybody. Yes, thanks for the kind introduction, Dr. Kamath. And really thanks to the local IMA. It's always a great moment for me to be along with our local IMA group, Dr. Pate, Suniti Upasani, Niti Upasani. And it's a great moment for me because I'm introducing none other than a great friend of mine for the last almost 3 decades, and Dr. Rishma Pai, whom Mrs. Kamath already described as a very famous and a beautiful lady. But more than that, I can tell you that she is a really person with a great heart and great warmth, because I've been in the same society where she was the president for 2 years, the IAG and the ISAR. I was the Secretary General at the same time. So my relationship with her goes a long way, not only just as a friend, but professionally, but also in administrative, and really enjoyed the time with her. But it is my great honor that I should introduce her. Dr. Rishma Pai is the consultant at Jaslok Hospital, Leelavati Hospital, and at Hinduja Hospital. As already mentioned, she was the past president of IAG, Indian Society of Assisted Reproduction, the FOXY, or the Federation of Obstetric Gynec Society of India, and she is currently the president of Mumbai Obstetric and Gynec Society. She has the rare distinction of the only person being a president of all these 4 major organizations. That's really a great honor for her, for us, that she is here to talk about infertility or making parents, bringing miracles to life, which was also her theme during ISAR presidentship. Well, apart from that, she has got a lot of accolades. She is the only Indian selected to be on the board of International Federation of Fertility Society, or we call as IMAFEST, where specialists from 66 countries are involved, and she is the assistant treasurer. And she was honored in 2018 the fellowship honoris causa, the RCOG, the Royal College of Obstetrics and Gynecology, one of the few Indians to receive this honor from the prestigious 90-year-old British Society. That's indeed a great honor for her. She was the first Indian to be appointed as the board member of World Endometriosis Society, and she has received tremendous awards, Inspiring Gynecologist of Western India Award by the Times of India Group. She is the recipient of the Midday Health Wellness as Icon in Obstetrics, Gynecology and Infertility, and she is the recipient of the Women Empowerment Award 2017 by the Indian Medical Association. She has also received RK HIV Research Center Award for Excellence in Medicine 2017. She is the recipient of Bharat Nirmal Award for Women's Entrepreneurship in 2017, and she is recipient of 50 Outstanding Women in Healthcare. She was awarded in 2017, and she was also awarded the Newsmakers Best Doctor Award and the Great 8 Women Achievers Award for Excellence in the Field of Medicine. And she has been an avid orator, and she has delivered more than 66 oration and has been invited speaker at 400 national and international conferences. She has written many chapters in more than 63 books and published articles more than 14 leading journals, national and international. She is there for you, going to talk on making parents, bringing miracles to life. It's a great honor for me that I'm introducing you, Rishma, and it's a great pleasure that Dombivli IMA has invited you, and the people in Dombivli, or the medical personnel in Dombivli, will be able to listen to your wonderful talk. Thank you.
Thank you. Thank you for those really, really warm words. Thank you. Just give me a second while I share my screen with all of you. All right, the most commonly asked question, am I seen and heard?
Yes, ma'am.
Wonderful. Thank you. Thank you all for inviting me here. Thank you for this beautiful introduction. Only a dear friend like Krishna Kumar can do that, say such wonderful, kind words. Really a pleasure for me to be here today and share with you something very, very close to my heart. Very special thank you to IMA President, Dr. Sumit Upasni, Mrs. Upasni, and of course, the organizing chair of today, Dr. Mangesh Pate. Really, thank you for thinking of me and giving me this honor. So, like I said, I'm going to speak to you about a subject very, very close to my heart, that is making parents, bringing miracles to life. I do believe we are the blessed and chosen ones because we have the ability to do miracles, actually bring miracles to life. And let me begin by saying that out of difficulties grow these miracles. And you will see when we go through this. I have had the privilege of having many, many patients over the years, really challenging ones. And let me share with you some of the acute problems that we faced. Mrs. Ritu was a 25-year-old Rokitansky-Kusterhauser syndrome. As you all know, it is a woman born without a womb. She never had periods, did not have a womb. Vijay had childhood mumps and then found that he had absolutely zero sperms in his semen sample because of that azoospermia. Nina was a young girl who developed breast cancer at 28 years of old, went chemotherapy, had to undergo chemotherapy. She became okay, but obviously because of chemotherapy, went into premature menopause and is now in menopause. Preeti, her uterus, her tubes were completely damaged by tuberculosis, such a common problem in our country, went into complete stoppage of periods and complete damage, adhesions inside the uterine cavity. Shelley had a very unhappy marriage. Finally, she got divorced and got remarried at the age of 43. Now she's happily married, but wants a baby, and she's 43 years old. Meena, and this is really heart-wrenching, it actually made me cry when the patient was with me. She lost her only son, who was 25 years old, in a bike accident. Now, poor Meena is 50 years old, and she's devastated. She wants a child desperately. These are real-life situations and seemingly impossible situations. What can we do? I believe that if you run into a wall, don't turn around and give up. Figure out how to climb it, go through it, or work around it. It all began way back in 1978, when Sir Robert Edwards and Patrick Steptoe's work resulted in the first test tube baby, Louise Brown, who was born in 1978 in Manchester. That was the beginning of the story. This you can see Sir Edwards with the mother, who was actually Mrs. Brown, who actually had the baby. And this is Louise. Louise is now having her own baby, natural conception. And that's a little baby of Louise Brown, who was herself the first IVF baby in the world. And this is the miracle that started it all. This is me last year with Louise Brown at the American Society of Assisted Reproduction Conference. I was so excited to meet her. She's the first IVF baby in the world. And because of her, all of us are here today practicing some amazing science. After this first miracle, there was no stopping. Millions of babies have been born worldwide with the help of fertility treatment. In fact, the number of babies born by IVF today are more than the population of an entire US state, such as Colorado, or even a full country like Ireland or Lebanon. This is an amazing success story. And I had the privilege of meeting Sir Edwards many, many years ago. That's Rishikesh and me. You can see how young we are looking. And of course, I've had the privilege of working with Dr. Indra Hinduja, who gave the first IVF baby in India. And that is me with her a few years ago. IVF was basically made for bilateral blocked tubes. So the idea was that the fallopian tubes are blocked, patient cannot become pregnant naturally. So let's take her eggs out and then fertilize them and put them back. And this was the basic concept behind the IVF. And that hasn't changed in all these years. What do? We give ovarian stimulation to the patient with the help of injections. We produce many eggs in the ovary. These eggs are withdrawn through transvaginal sonography. Just a needle is put inside, eggs are taken out, no cuts, no stitches. Patient goes home the same day. After that, in the laboratory, these eggs are fertilized. And after 2 days, 3 days, or 5 days, these embryos, you can see these beautiful embryos developing here. These embryos are then put back into the uterus, which is a 1-minute procedure. And we support the pregnancy with hormones. All these years, many injections used to be given. We used to start in the previous menstrual cycle, give injections, suppress her own hormones, give hormones from outside. But now even ovarian stimulation has been very simplified with the help of the antagonist protocol. So to put it simply, once a patient's period starts, we give her injections every evening to produce number of eggs. Once the hormones start to rise, we give her antagonist injection for about 4 or 5 days so that her own LH surge does not occur and she does not spontaneously ovulate. And with this controlled environment, we give her a trigger shot and remove her eggs through transvaginal sonography, like I explained to you. So when we are doing the follicle study, you can see how many eggs are developing. Normally just 1 egg develops, but that gives poor outcomes in IVF. So we produce a number of eggs. And all these are follicles. Many of them may contain an egg. Very little monitoring is done, just 2 or 3 sonographies. We literally don't do any blood tests or hormones anymore. And this is the transvaginal sonography procedure. You can see there's an actual white needle. You can see that going inside the follicle. And if you watch for a minute, the entire follicle, the fluid is being aspirated out, and that follicle is now almost collapsing. And this fluid with the egg is been drawn into a test tube. And then in the laboratory, which is right next to the operation theater, we are actually analyzing or looking at the egg, which is all surrounded by cumulus. So once this is fertilized, embryos are created. Like I said, after 2 or 3 days, these are put back into the uterus. That procedure is very, very simple. Doesn't even take 1 minute. Very thin catheter, just put inside the womb, gradually sliding inside with the help of ultrasound control. And the patient rests for 10-15 minutes and she goes home. And 2 weeks later, we have the outcome with the help of a beta HCG test, whether it's positive or negative. So simple standard procedure has been there for many, many years now. But despite in vitro fertilization, there were many situations in which the couple still could not conceive. So we had to find many more ways in which to overcome the many, many obstacles that we already started by speaking about. What if there is severe male factor infertility, very low sperms or almost no sperms in the semen sample? In this way, the normal IVF process will not work, because in vitro fertilization, the eggs are taken, the sperms are taken, the normal sperms, they're put inside a dish and they're allowed to fertilize on their own. But when the counts are very poor or zero, this is obviously not going to happen. This all changed when this man, Dr. Palermo, in 1991 introduced ICSI. I'm a huge fan of his. I meet a lot of film stars, I meet a lot of people, but I never take photographs with anybody. When I met Dr. Palermo a year ago, I said to him, I need a photograph with you. I'm a huge fan. And this is me with him last year. He's the one who invented intracytoplasmic sperm injection. You can see in the video, one sperm is picked up with a small pipette and is actually injected inside the egg. So even if the patient has hardly any eggs, 1 egg, 2 egg, 3 eggs, or 1 or 2, 3 sperms, or no sperms at all, we can actually help her become pregnant. So ICSI started for the process of helping couples where the sperm count was absent or very, very low. But now it has become almost the norm. And almost every case today, rather than doing IVF, most centers are doing intracytoplasmic sperm injection because it gives excellent results and no fertilizing failure. We've even had men who have paraplegia, who are not able to give a semen sample. In those patients also, we're able to extract the sperm, inject it inside the egg with the ICSI procedure, and make their wives pregnant. So you can see sometimes we have 0 sperm counts. So either the vas is blocked, or else there is complete testicular failure, high FSH. There are no sperms in the semen sample. In those patients, we can actually put a very fine needle into the testes or into the epididymis. Few sperms are aspirated out, they're processed, and these few sperms can be actually injected inside the egg. Nowadays, very, very poor prognosis patients, high FSH, almost no sperms, even on normal biopsy when it is done by an andrologist, there's no sperms. With the help of micro-TISA, many tiny microscopic tubules are removed and sperms are obtained, and these couples can achieve pregnancy with their own sperms, which is something very, very, they desperately desire. Then a few years ago, we were the first to bring into India IMSI, intracytoplasmic morphologically selected sperm injection. You know, when you see the sperms under a microscope, all of you have seen that, you can see them as tiny little dots just wriggling around. With this new machine, the IMSI machine, you can magnify the sperms 7,000 times. And with this magnification, you can actually obviously identify sperms which are unhealthy, which look abnormal, and you can pick up the best sperm. And by picking up the best sperm and injecting it into the egg, obviously the chances of pregnancy as well as the rates of miscarriage become way, way better. So IMSI, in fact, we're proud to have that introduced for the first time in India, and for well-selected patients, it really gives good outcomes. In female factor infertility, you all have understood already, there are huge amount of challenges. And I believe that almost anyone who's achieved something meaningful has overcome some kind of a barrier. And there are many, many barriers. One of the commonest and the most difficult problems all of us face is poor ovarian reserve, premature ovarian failure, older patients, 45-year-old patients, menopausal ladies. How do we make them pregnant? We are seeing today many girls getting married late. After their marriage, they want to delay pregnancy even further. lifestyle, various problems has really caused damage to the ovaries. So we see many young ladies, maybe in the late 20s, early 30s, coming with a very low anti-Mullerian hormone, which is a sort of a measure of their egg reserve, how many eggs they have in their ovaries. When we do the sonography, we see the number of eggs, the antral follicle count has fallen terribly. So we tell these patients, oh my God, you're only 28 and your eggs are becoming less, your anti-Mullerian hormone is becoming less. Let us get your eggs out and freeze them before they're actually completely finished and over. So these are the patients which, if we pick them up early, we can give them some support and we can advise them. But what if they come to us already when the eggs are nearly finished? What if the girl is already 40, 42 years old? What can we do for these patients? Because eggs are limited in the ovary. They will finish in a period of time. In many patients, they finish by the age of 42, but in some at 30, at 28. I have girls who've gone into premature menopause at the age of 19. It is really, really scary. But this has happened and it's happening more and more today. So fortunately today, we have many techniques, and I'll take you through some of them just briefly, what we can do to handle these patients who have poor ovarian response. One of the amazing things that has now become fairly easy and available, and we ourselves have had good pregnancies in very, very difficult patients, is the autologous platelet-rich plasma intra-ovarian infusion. And this particular study, it's a very recent study, just come out 2-3 months ago, and has been tested, this technique, on perimenopausal, even menopausal patients. So what is this thing we do? This particular study, 120 patients, very poor, hardly any eggs in their ovaries, or have gotten into menopause. In this PRP, platelet-rich plasma infusion, taken from their own blood is withdrawn, PRP is extracted from there, and this is given into the patient's ovary. And after 2 months and 3 months, you can see that the ovary actually becomes rejuvenated. And where you had no eggs or no periods, the patient may start growing eggs and may even resume period and even achieve a pregnancy. So we have been doing PRP in our clinic as well and have already reported our live births with this technique. That's a very, very simple technique, not even expensive. Take the patient's own blood, PRP, and inject it transvaginally through the vagina into the ovary. This technique, in vitro activation, is actually a lot more difficult. In fact, about 3 years ago, Rishikesh had gone to San Francisco to learn this technique because it was amazing. This is what they reported. Menopausal ladies, periods have stopped. FSH levels are more than 35. So they are totally in menopause, these girls. In these patients, what was done? Laparoscopy was done. Pieces of the ovary were removed. These ovaries were cut into strips and they were frozen away. Whenever the patient was ready, these strips were taken out, cut into pieces, because that actually activates the hippo pathway, hippocycle. And these pieces were actually activated with AKT kinase, and then it was put laparoscopically back underneath the fallopian tube. These patients, surprisingly, patients who were in menopause, it followed that they started getting periods, started growing eggs, and out of these patients, 3 pregnancies were detected and 2 successful deliveries happened. So look at the impossible task of a menopausal lady with her own ovaries being implanted after activation, becoming pregnant and delivering patients. There's a lot of talk about stem cells nowadays, and the patient's own stem cells, autologous stem cell ovarian transplant. The stem cells are derived from the bone marrow, and these are actually introduced inside the ovary or even into the blood. They actually find the ovary and they start to grow there. And it was found that the ovarian function improved in 81% of women who had this Ascot procedure done on them. 5 pregnancies were obtained, some naturally and some through IVF. So remember, we are talking about patients on whom the world had given up. They had stopped their periods, they had gone into menopause. In fact, this is very exciting. It's still in early stages. There's a lot of focus on ovarian stem cells. They are saying that forever and ever and ever in the ovary, there will be some ovarian germline stem cells. And if you can remove these, they're very early stage, they can be converted into normal oocytes, which are haploid, and you can use these to give the lady an unlimited source of eggs. So whether she's 40 or 50 or 16, from this, you'll be able to create eggs. And that is very, very dramatic. And there are lots and lots of new papers on this subject. And you can see again, very, very recent studies, all that I'm quoting to you, that you can actually generate oocytes from ovarian stem cells. So this particular aspect is very, very exciting. There's another amazing field that is developing, and that is the role of gene therapy in premature ovarian insufficiency. Why did for example, 25-year-old girl go into premature menopause? Maybe because of some genetic problem. So what is being done, and this is not theoretical, this is in practice today. We know that germ therapy, gene therapy can actually help the patient's modification of her abnormal genes. The defective gene is actually removed, replaced by a therapeutic gene. And this is put back. It can be put back into peripheral blood. It can be put into target organ. And these altered stem cells may actually produce a colony of new specific cells which start to function. So stem cells, gene therapy has a huge role in the upcoming years. So all of us know that not everybody can be subjected to these fancy therapies, and always we can resort to egg donation. Egg donation we've been doing for the last 25 years. It's very, very simple. We just get a young donor, and fortunately we have many good completely tested donors, or we have egg banks from where we can get the donor who's fully tested, including genetically, and we fertilize with the husband's sperm, we make the baby, and we put it back inside the recipient who has a normal uterus but has no eggs. And of course, the pregnancy rates are excellent in this technique. It's not very expensive. It's very, very easy and non-invasive. This is how we can make any lady pregnant. In India, we have the dubious reputation of having the oldest lady ever to have a baby with IVF. This lady, Rajjo Devi, made the world records. She was 70-year-old when she became pregnant. The question is, can we make a 70-year-old pregnant? Of course we can. Should we make her pregnant? That's a big question mark. Many, many years ago, I remember maybe about 15 or 20 years ago, I had done IVF on a 60-year-old and had delivered her at Just Loke Hospital. But after that experience, I have never again gone beyond the age of 50 or maximum 52. I don't think just because we can do something, we should do that particular procedure. This was as far as the ovaries were concerned. What about uterus? All of us know in our country, there's so much tuberculosis. The uterus is completely damaged. The lining is thin. There is Asherman syndrome. Patient doesn't get or gets very, very scanty periods. Sometimes, like I said, your girl is born without a uterus. RKH syndrome is quite common. In RKH syndrome, the ovaries are normal. Hormones are normal, but there's no uterus, or there's a tiny, little nodule of a uterus. How can this lady ever become pregnant? And so for this purpose, many things have come up. If you have a very thin endometrium, if the uterus is, just not responding to hormones, we have many medical therapies. We have, we use aspirin, vitamin E, sildenafil. We give infusion of many substances like, again, platelet-rich plasma, granulocyte colony stimulating factor. So many simple therapies are first tried, which are very inexpensive, easy, and we try to see if we can increase the thickness of the endometrium. Because you know that unless the lining of the uterus is at least 7 millimeter, the chances of pregnancy are very less. And again, I'm bringing to you very, very recent studies on the intrauterine infusion of platelet-rich plasma. Like I said, this is a very simple technique. We are doing it regularly now, and this actually helps in a lot of patients. You can see many, many studies. This is a putting together of 7 different studies that the endometrium thickness increases with infusion of PRP, and the implantation rates increase in patients who have been failing IVF earlier. I spoke about granulocyte colony stimulating factor. Again, a very, very big study, amalgamation of hundreds of different women who have been studied. And GCSF, again, very easily available, inexpensive, cheap. Just take it and just infuse it inside the uterus. And there seem to be better outcomes, thickening of the endometrium in patients who have failed many previous cycles because of implantation failure. Again, here stem cells comes in, and mesenchymal stem cell. Please note, this particular paper has reviewed 4 different types of mesenchymal stem cells. Those derived from the bone marrow, from adipose tissue, menstrual blood mesenchymal stem cells, and umbilical cord mesenchymal stem cells, because many women are now storing umbilical cord blood. And it was found that you could actually use these stem cells on collagen scaffolds, and they have been used to treat patients with recurrent uterine adhesions. If the uterus is badly damaged inside, there's hardly any endometrium, it's very thin, you can actually use these stem cells. They've been shown to improve the proliferation, neovascularization inside the uterus, and these patients may resume menstruation where they didn't have any, and they may actually achieve pregnancies. So I believe we should be all like the stem cell. Differentiate yourself from others. Do something different. Don't be routine. So, like I said, we have been discussing factors in which the uterus is either absent or badly damaged, and we can always in these patients resort to surrogacy. So if all the techniques I spoke about fail, then fortunately, even today, the government has not banned surrogacy, but I believe it's on its way out, because the government is bringing very, very strict laws on surrogacy. And I'm sure in the next parliamentary session, it will be passed. But in surrogacy, we can use the patient's own eggs, the husband's own sperm, the baby is genetically theirs. It is just taken and put inside another womb, because this particular lady either doesn't have her womb, it has been removed because of some cancer, or she's born without a uterus. And in this, the surrogate mother can carry the biological child to term, deliver the baby, and hand it over to the biological parent. So this, of course, we've done hundreds and hundreds of cases, fabulous results, and really no problems at all. But even this was challenged. In 2009, Mats Brandstrom, pioneer in the field of uterine transplant, went ahead and actually did something we thought was impossible: uterine transplantation. And this was actually reported in 2014. This patient, the first patient, was a 35-year-old lady who was, like I've been speaking about the Rokitansky syndrome, born without a uterus. So her uterus was donated to her by a 61-year-old lady. And this transplantation was done. Uterine transplantation was done. So 65-year-old lady's uterus transplanted inside a girl who was born without a uterus. Like I said, RKH, the ovaries are normal. So her eggs were already removed. Embryos were created. Once this uterus was transplanted, patient started getting periods. Uterus grew and took properly. And then these pre-prepared embryos were transplanted back. And a male baby, 1.7 kg, was born. This was an amazing, amazing development which was reported in the Lancet. Obviously, the moment something happens, the floodgates open. And last year, the British Journal reported 45 detailed cases of uterine transplantation, 9 live births. And of course, since then also, many more have been born. But this is not an easy technique. Remember, there are a lot of risks, not only to the donor, but even to recipient, both of them. So it's not something you want to choose in a hurry, unless it's a very, very desperate situation. Going from one situation where you just can't have a baby to the problem of plenty. All of us know that there is an epidemic of multiple pregnancies. And multiple pregnancies are something very, very risky. Preterm births, lot of problems in the newborn, etc. So we don't want this. IVF is moving from multiple pregnancies to one single healthy baby. And that can only happen if we can select one beautiful embryo. We were not confident. So we were putting back 2 embryos and 3 embryos. And in certain places, like they put back any number of embryos, we never go beyond 3. But now we are moving more and more towards one perfect embryo. And how do you do this? How do you select that one embryo? With that, there has been the development of omics. There are many different omics: epigenomics, genomics, transcriptomics, proteomics, metabolomics. Basically, all these different technologies try to analyze either the proteins or the genes or something of the embryo, which gives us the information that this embryo is fantastic. And when this is put back into the lady, pregnancy will happen. And we were actually one of the first ones to introduce even metabolomics in India many, many years ago. And you can see the different sciences which have developed: lipidomics, metabolomics, like I said, glycemics, proteomics, so many different technologies, just with one purpose: to select that one single embryo, which we can put back and giving us excellent outcomes in pregnancy. Another very frustrating problem is that of recurrent miscarriages or having a baby who is born with some genetic disorder. How do you prevent this? We've had so many patients, 2, 3, 4 miscarriages, very, very depressing. And fortunately, there was a ray of light when this Alan Handyside gentleman actually introduced pre-implantation genetic diagnosis. And this is an amazing technique where an embryo, an embryo is microscopic. You can't even see it under a normal microscope practically. This embryo was actually biopsied. This is something now we are doing very, very regularly for many, many years. What we do is we have laser hatching. So the embryos here, we cut open the zona with the help of a laser. So very, very fine, no damage to the embryo. Then a biopsy is introduced inside, a biopsy needle is introduced inside. 1 or 2 blastomeres are taken out, and you can see that in the video if you observe, like you can actually draw a cell inside. That is analyzed genetically because it's a representative of the entire embryo. And we can actually find abnormal or normal embryos. And the normal ones only are then transplanted back into the uterus, ensuring that you have a genetically normal baby. So this is not unusual. This has been with us for many years, and we are doing it on a regular basis. So excellent ability to pick up genetic disorders. Earlier, it was only like big chromosomal defects. Now, many details can be picked up. And many women will benefit, those with sex-linked genetic disorders, single gene disorders, chromosomal disorders, older women, recurrent miscarriages. All of them will benefit by this technique of pre-implantation, even before pregnancy, genetic diagnosis. Obviously, once the lady becomes pregnant, we can biopsy the baby, we can do amniocentesis, but all those are very late diagnoses and they're all risky and interventional. What about CRISPR? All of you must have read about CRISPR. This is a gene coding technique to actually alter genes in human embryos. Extremely precise and effective technique. In fact, the Human Embryology and Fertilization Authority of UK, which is very strict organization, has actually allowed CRISPR to permanently change the DNA in a human embryo. So in the UK, this technique is actually now legal. And in India, recently we attended a workshop on CRISPR. Many scientists are working on it. In this system, you can actually edit out bits of DNA that prevent an embryo from developing properly. So you can remove the defective DNA, and actually this CRISPR opens the door to unprecedented level of control over the human genome, because the damage, the bad, the wrong DNA can be edited out, they can be replaced, they can be actually changed. And this is the CRISPR-Cas9 system. Very complicated, but is happening, is a reality today. In many labs, it has started already. And like I said, UK has actually given permission to go ahead with editing of the genes of the human embryos. I always like to say this, that the more I live, the more I learn. And the more I learn, the more I realize, the less I know. We know so little. There's so much happening in the world, so much science, so much development. And I'm just going to take you through some of the things which are happening. For example, in patients with repeated IVF failures, I mentioned already to you pre-implantation genetic diagnosis. That is if a patient has a disease. But today, things have changed. In the USA and in many advanced countries, they won't do an IVF without sampling the embryo. So this is pre-implantation genetic screening, which means even if there's no disease expected, even if there's no family history, every embryo is biopsied, it is checked, and only normal embryos are put back. So this is becoming the routine rather than the exception. Another fantastic technique reported in the UK a few years ago, augment technique. All of us know that mitochondria are the energy source of the cells. If the mitochondria are damaged or they are poor, there will be either mitochondrial disease or the cell will not be able to function properly. So in augment, what is done? Egg precursor cells are taken from a small biopsy of the ovary. These precursor cells containing mitochondria along with the sperm are then injected into the egg during the ICSI procedure. And the mother's egg now, or the embryo, contains mitochondria, which is sort of rejuvenating to that particular embryo. And you can see with this augment technique, women who had failed more than 2 IVF cycles earlier actually got 25, 35, 45% success rate. So from 0% success rate, almost going to 50% success rate because of infusion of healthy mitochondria. And I'm backing everything that I'm saying by science. You can see this mitochondrial replacement therapy is now a reality. And the House of Parliament in the UK actually passed regulations putting the use of this mitochondrial spindle transfer, pro-nuclear transfer, actually to become a reality. And so this ruling may shift the whole world's consensus to which actually prohibits gene modification in the human gametes or embryos towards allowing the correction of altered genes in the germline. So you can imagine at what level, at what microscopic level we are able to go. This is a very, very strong message to all of you I want to give. We know that with changing lifestyle, delayed pregnancy, there is very often a need to postpone fertility. Also, we are seeing cancers in young women, and many of them, they become okay after the treatment. But like I mentioned, because of chemotherapy, they may go into premature menopause. Preserving her fertility is now a possibility. And if you do not offer them fertility preservation, you are liable. The woman, or the man for that matter, with maybe a testicular tumor, can come back to you and blame you and sue you because you did not tell them that there was a possibility of fertility preservation. Maybe you don't do it, but you can refer them to somebody who can offer them fertility preservation. And so this became possible because of this Japanese gentleman, Dr. Katayama. Again, we had gone to him for training many, many years ago because he introduced rapid freezing. Earlier, freezing has been there for many years, but the slow freezing technique was expensive, very, very slow, and it gave you very poor pregnancy rates. But with this new technique of vitrification, the saving of the eggs, 100% eggs survive. And our success rates, and we've presented this in an American conference as well, almost 100 or 99 or 95% success rates in saving eggs. You can take out the eggs or embryos, you can freeze them, and when you thaw them, none of them die. They are as healthy as they were, even if they're frozen many, many years ago. And you can see we have now hundreds of these cryocans. This is an embryology team with all of these tanks containing many, many thousands of eggs and embryos. Many of you may have heard the name of Professor Jacques Genet, very, very famous gynecologist from France. And what he did, he had a patient who had Hodgkin's lymphoma in 1987. What did he do? He's a laparoscopic surgeon. So he went inside, took out part of her ovary and just took it out and froze it. The patient underwent treatment for Hodgkin's lymphoma and luckily got cured. 6 years later, she came back to doctor and said, I'm cured now. I want to have my baby. So what did he do? He took out her frozen ovary and with laparoscopy, just put it back near the fallopian tube. Lo and behold, she started ovulating and she conceived naturally and had a baby. This would never have been possible if fertility preservation had not been offered to her. So you can see this is a very nice study. And like I said, this is for each one of you, whether you're a gynecologist or an andrologist or a surgeon or any medical specialist, because you all see patients who might have cancer or who may be getting older and not able to have a baby for some reason. This is a study of 159 patients coming to the hospitals for fertility preservation. Many different techniques of it could be just hormone injections given to them to suppress their hormones, or it could be preservation of the eggs or the ovaries. And please note that out of these patients, out of the 91 patients who were in remission, the women who wanted to have pregnancy, almost 55% of them became pregnant. So this is after chemotherapy, after radiotherapy. These couples could have their own baby because they had undergone fertility preservation. So the key to embrace this is to embrace disruption and change early. Don't leave it to, reacting decades later. You can't fight innovation. Changes will happen. You have to go along with the changes. And I'm going to end with just a few headlines which have been grabbing the newspapers in the last few years. Scientists grow human eggs to full maturity in the lab. This was in the newspaper headings from very, very early stages of the ovarian tissue all the way to full maturity. Eggs have been grown in the lab for the first time. Artificial ovary may help cancer patients. Artificial ovary? Yes, this was reported. I was at this conference 2 years ago at the ESHRE conference where they first reported this. They've actually made a scaffolding into which eggs can be put, and this artificial ovary can actually grow. So even girls who have had ovarian cancer, so you can't preserve their tissue, ovarian cancer patients can have this artificial scaffolding and may be able to actually get an artificial ovary. And note the last line, this work could develop into an artificial ovary in 5 to 10 years. So in our lifetime, we are going to have all these developments taking place. This particular headline again, human embryos survive outside the womb for 13 days. This is the maximum. It has never been allowed before. Maximum 6 to 7 days the embryo was grown outside the womb. Here, 13 days the embryo has been growing outside the womb. This is the headline in the Time magazine, which I love to read, and I'm sure you do too. The future of babies. How are babies going to be born in the future? Gene editing, uterine transplants, 3 biological parents, mitochondria from here, cytoplasm from there, nucleus of the patient, womb from another patient. The future of babies is going to be really very, very different. So Aldous Huxley, many years ago, I had actually read this book, very, very old book, published in 1932, Brave New World. He had written, IVF is science fiction. IVF is, of course, a reality today. He had also described what he called exogenesis, where an artificial womb successfully grew babies to term. You all know that we have actually managed to grow sheep to full term in an artificial womb. This is the reality. You can see the pictures. These are sheep which have been grown outside the womb. This is the reality for sheep. I am sure in the future, it may be a reality for humans. So even without a womb, we will be able to grow babies, maybe to full term outside. So our dismal patients, Ritu, who was born without a uterus, now is a proud mother. Vijay, who had no sperms because of mumps infection, fathered his own child. Nina, who had breast cancer and chemotherapy and cured out of it, recovered and had her baby, even though she was in menopause. Preeti, whose uterus and tubes were totally damaged with tuberculosis, finally has her own baby. Shelley, who had an unhappy marriage, who divorced and got remarried at the age of 43, now has her own baby. And finally, Meena, who had lost her only son at 25 in a bike accident, who is now 50 years old, has her own baby. So I believe miracles happen, but you have to work very hard for them. Thank you. Thank you so much.
Wonderful, Rishma. The more I listen to you, the more I learn, I feel less I know. And you could see the passion she has. Even for an IMA, she has delivered a wonderful lecture covering, and somehow I always envy her because from somewhere she takes out the latest evidence. Means she would be delivering a talk and just 15 days prior, some of the evidences which only she has. I've never seen anybody getting such great evidences. And she has given in a lecture that options for fertility is for every couple, but you have to be directed properly. If you can pick them up and guide them to the right person, right center, today every couple has something that she can never be say that there is no treatment options. That was wonderful, very lucidly detailed. I think you have covered everything. The latest, I think everybody would have loved it. Great, thank you. I don't have time for question because you have covered it wonderfully.
I'm just trying to stop the screen share for some. Has it stopped the screen share?
Yes, ma'am.
Yeah, okay, because I was not able to.
The possibilities are numerous once we decide to act and not to react. Extraordinary people visualize nothing what is impossible or probable, but rather they would see what is impossible and go for it. Thank you, ma'am. Thank you for a very impressive lecture.
Thank you.
I request the IMAFEST committee to honor Dr. Rishma Pai with the e-memento. Thank you once again, ma'am.
Thank you.
I now
Thank you.
request the IMAFEST committee to honor the moderator for this session, Dr. Krishna Kumar sir. We wish you all the best for your tenure as the president, and thank you for moderating this session.
Thank you for
Thank
keeping
you,
me
NSP
involved.
Pharma.
Great.
Thank you, all of you, and all the best for the rest of your meeting. Congratulations for an
Thank you,
excellent.
madam.
Thank you. Thank you, Dr.
Thank
Kumar.
you, madam.
Thank you.
It was our honor.
Thank you very much, ma'am. The next lecture is the UP Rao Oriation lecture.
Aditya, are you ready with the PPT presentation? Thank you. We'll be beginning with the oration ceremony. Good afternoon, everybody, all the dignitaries and the delegates to the oration ceremony of IMA Dombivli. Next slide, please. Dr. U. Prabhakar Rao oration ceremony, and which is being conferred upon. Next slide. It indeed is a great honor to me to welcome the man of tall repute and a great repute, Padma Shri Honorary Dr. Raman Ganga Khedkar sir, to my branch IMA Dombivli. I extend my heartfelt thanks for graciously accepting our invitation, sir. I also feel honored to welcome our IMA Maharashtra State President, Dr. Avinash Bhondwe sir, as chief guest of the ceremony. Dr. Mangesh Patel sir, as our beloved national dignitary, and Dr. Sunit Upasni, IMA Dombivli President. Before we proceed with our ceremony, I will give a very brief overview about our oration. That is Dr. U. Prabhakar oration. Dr. U. Prabhakar oration is a prestigious oration ceremony of IMA Dombivli. Dr. Pradeep and Dr. Prashant Rao, sons of Dr. U. Prabhakar Rao, wish to felicitate great doctors from our IMA Dombivli to be felicitated from our IMA Dombivli, as was a suggestion of our beloved Dr. U. Prabhakar Rao. Dr. U. Prabhakar Rao sir is a veteran surgeon of city of Dombivli, and he was the first person to start his hospital, Srinivas Hospital, and later on a state-of-the-art Mamta Hospital in Dombivli. With his numerous contribution in field of surgery, he also has contributed to development of Dombivli city in field of education and art. Arita, can we have the slide where Dr. U. Prabhakar Rao's image is seen? The third slide, please. Dr. U. Prabhakar Dr. U. Prabhakar Rao oration was started in the year 2015 and is bestowed upon the doctors of great repute. Till now, from 2015, Dr. Alruraj sir, Dr. Mrudula Phadke madam, Dr. Ved Prakash Mishra sir, Dr. Mohan Agashi sir, and Dr. Asokan sir have received this citation. And this year, we are extremely proud to have amongst us the face of government to the world as COVID situation observer, controller, and guide, who literally held our hands over the last so many months to tide over this emergency in our country. So once again, I welcome you, sir, with folded hands to my branch. And I request our president, IMA Dombivli, Dr. Sunit Upasni, to give a brief introduction of Dr. Ganga Khedkar sir to our delegates. Over to you, Dr. Sunit.
Thank you, Dr. Good afternoon, all dignitaries. Padma Shri Honorary Dr. Raman Ganga Khedkar sir, Chief Guest, IMA Maharashtra State President Dr. Avinash Bhondwe sir, our national leader Dr. Mangesh Patel, all delegates. It's indeed my absolute proud privilege to welcome and introduce today the esteemed moderator Dr. Ganga Khedkar sir to our branch IMA. Sir can be aptly described by a Sanskrit shloka, विद्या ददाति विनयादयाति पात्रताम् पात्रवत धनम ओपन्ति धनात धर्मम तथा सुखम. That knowledge makes you humble, humility gives you character, good character attracts wealth, with wealth good deeds can be done, and this leads to the happiness in the world. Friends, for the last 8 months, COVID has become a household name because of the global pandemic. We are at war with a deadly virus, but the person who is responsible for making us emerge victorious in our continued war is Dr. Ganga Kedkar sir, an ex-head scientist and epidemiologist of ICM. We are following all the guidelines from the ICM. Before ICMR, sir has worked with many other prestigious government organizations like National AIDS Research Institute Pune as a director. He did his master's in public health from US. He started work for AIDS in early 80s when HIV was a big taboo. He started working at the grassroots levels and studied virus epidemiology in depth. He devised national guidelines for policy making for AIDS and HIV. He was the face of government of India for controlling Nipah and coronavirus. A man of true wisdom and humble background in education from his Zilla Parishad school, he knew to keep language of communication with non-medical persons simple, and soon he became favorite of the press reporters for his explaining complicated scientific concepts into simple vernacular language of Hindi. Sir is an excellent philosopher, thinker, researcher, scientist, and a great human being. To his patients, he is next to God. For his contributions to work, he was awarded many national and international awards and citations. Some of the few which I'll be naming will be Fogarty Fellowship from the Johns Hopkins University, USA, FXB Fellowship from Francisco Zaven Foundation, Switzerland. He was awarded Padma Shri by the Government of India in 2020 for his work in AIDS and HIV. He is currently serving the nation as Dr. C.G. Pandit, National Chairman, ICM. Friends, indeed, I find myself falling short of words to describe such a larger-than-life persona. So without taking much of the time, we should begin our oration ceremony. Now I request Dr. Hemant Patil, Honorary Secretary, IMA Dombivli, for further proceedings. Thank you. Jai Jai.
Okay. Thank you, Dr. Sunit sir, for wonderful introduction of Ganga Kedkar sir. Now I request all the dignitaries to join the dais and start the oration ceremony. First, I will like to invite Dr. Avinash Bondwe sir, our chief guest. Aditya, can I have the slide of Dr. Bondwe sir? Dr. Avinash Bondwe is President IMA Maharashtra State. He's a past President Indian Medical Association Pune branch. He's a physician at Dr. Bondwe Clinic. He's an active Rotarian and is a wonderful writer with many publications to his name like Arogyatil Andhashraddha, Tarunya Gan, Tarunyacha Umbarthyavar. He's a great poet as well and has an exceptional leadership in the state during this COVID pandemic. We welcome you, sir, on the dais. Now I request our own Dr. Mangesh Patel sir to be on the dais. Dr. Mangesh Patel sir doesn't need any introduction. He's our own member, true national leader and patron for our branch. He's a chairman board of Hospital Board of India, IMA Maharashtra State, honorary treasurer, IMA Hospital Board of India headquarters. He's been to many prestigious posts in national and state level. I welcome you, sir, on this oration ceremony. Then I request our president, Dr. Sunit Upasni, sir, to be on the stage. Dr. Sunit Upasni is President IMA Dombivli, an eminent pediatrician and senior IMA soldier associated with IMA since 25 years. We welcome you, sir, on the dais.
Aditya, can we have the slide of the oration topic? I request Dr. Ganga Khedkar sir to start his oration on the topic navigating during pandemic. Sir, over to you.
Yeah, can I request you to make me host so that I can share the screen?
So you can share the screen.
Sir, you have already been made host,
Yeah, I
co-host,
got
so
it.
you can.
Yeah, I got it.
Yeah. Yes, sir,
It
your
is
screen is
visible now.
visible. Yes.
Yeah, am I audible?
You're audible and your screen is visible too.
Yeah. So thank you. In the first place, let me thank IMA Dombivli, Dr. Pate, and that entire group, Dr. Upasni, and then Dr. Bondwe, for inviting me for this oration here. Now, today, what I'm going to try and do is try to look at, how did we negotiate the threat of the pandemic, and pandemics essentially lead to pandemonium because everybody is scared. No, such a kind of a pandemic that can alarm all the stakeholders was something which was new for all of us to handle. And how did we do it, and what is expected out of us as practitioners, healthcare practitioners as such? Just look at the backdrop with which we started. Nobody in the world must have had imagined that we would wake up to a new reality on 1st of January 2020, because the last day of 2019 was actually the one when China reported occurrence of this particular outbreak. On January 11th, we had the first discussion in the Ministry of Health, where WHO India's head, WR India, was also present, and he started discussing the stuff that this is being reported in China. What do we do? On January 17th, for the first time, an interdepartmental meeting of all the related secretaries was hosted by the cabinet secretary. This was one thing which I had never experienced in my entire life, because I worked enough in HIV as well as TB, but I have never seen such a kind of interdepartmental coordination taking place, and at the earliest, when the threat was also not as visible as it sounds now. One of the decisions that was made in the first meeting was we need to create the capacity for testing by RT-PCR. And the first case that occurred this as a pandemic. Nobody had, which included non-health related issues as well. Now, education, and definitely health and patient care. Perhaps nobody thought that it would panic all the stakeholders. It was a panic that was set in, perhaps because of the videos that were circulating. Lack was there, and we had to imagine the adverse outcomes that may be occurring in China at that time. The pandemonium, or the turbulence that was caused by COVID-19, it requires careful navigation, whether is a crucial thing for any doctor, while ensuring the safety of oneself and of the family. If you look at where we are today, we are among the top 5 countries. We are second in number of cases that have occurred in the world so far. When it comes to deaths, we rank third. But then, if you actually look at the entire data, 5 countries tend to represent 55% cases that have occurred so far, and 54% deaths are also represented by 5 different countries at this point in time. So this is a dreadful outbreak, which is time. We can just imagine the kind of magnitude that this infection has as of now. Today, incidentally, USA has passed 1 crore figure. We have altogether in the world, we have passed 5 crore figure for estimates of the number of infections that have already occurred in the country, which have been detected. When it comes to transmission dynamics, which we have to understand a little bit, one is it's a droplet infection. It's rarely an airborne infection. An individual can infect 4 others as maximally. The R0, as we understand at this time, in absence of any effective drug or a preventive vaccine, only non-pharmacological interventions remain as the mainstay. Use of mask, cough etiquette, safe distancing, and frequent hand wash are the only available options as of now. The broader strategy continues to be test, isolate, trace contacts, and treat them. Avoid what the advice that we tend to give is avoid closed indoor settings, crowded places, and close contacts. So let's try and understand some of these issues. One is there is a phenomena which is labeled as over dispersion. This is a very important phenomena that you by and large have seen in measles, influenza, and pneumonic plague. Not every individual tends to be a spreader. The transmission potential tends to be different in different individuals. But what does it do? It ensures that the disease becomes endemic because you cannot protect everybody at one given point in time. Neither can there would be a pockets of vulnerability and the infection becomes a endemic infection over time. If you actually see the evidence that is emerging, 80% of new infections tend to occur from only 20% of the cases. So there are small number of people, 1 in 5 individual is likely to be spreading this infection in the community. The rest of them perhaps do not. If you look at, does this kind of picture, is it seen in India? Yes, it is seen in India. 71% of individuals do not lead to secondary transmission, and that's something which is important for us to understand. But at the same time, we must also remember the secondary transmissions that occur are more likely to happen in same age contacts, which is a threat for schooling that is likely to be opened soon. Do we know who will spread this infection? Perhaps not. Spread 60% of the spread could occur from symptomatic people, and 40% of the spread could occur from asymptomatic individuals. There is no relationship with viral load. We do not understand who is the spreader. There are no biomarkers which can define who can be a spreader, and social contact and social events are extremely critical in terms of understanding the events that would lead to super spreading activities as such. Now, one of the things which we understand is almost 45% of the infections that occur, they occur within the family or within a household. Now, if that is the case, if I delay the diagnosis, perhaps the risk of transmission to the family members tends to be very, very high. And that's something which we have to keep at the back of mind. If you look at the yellow dots, they tend to tell you all social events are likely to be super spreading events if somebody is infected. So we need to be careful in terms of the delay from onset to confirmation of the infector. You find that social events have a very high, large propensity to spread it. When it comes to transmission risks, what do we find? Those places where there is poor air circulation and the duration of contact, close contact tends to be high, the risk of transmission can continue to be higher. And the risk of transmission is measured by the amount of exposure that you would need in a given setting. And that's something which we have to keep all the time at the back of mind, that how do we improve the air circulation in addition to what non-pharmacological interventions that we are following. Now, when this all started happening, when the first case was reported, the cases were reported from China, we started discussing the issues as to what we can do as a country. Now, one of the things which was done was, since this is infection which was occurring in other countries, one of the means that was adopted was try to curtail the spread of this infection or an imported outbreak, and that was done by making certain efforts to not to issue visa and then subsequently international flights were banned. But there is one issue which became worse. That is, we could not have it said to Indian citizens that they cannot return back to the country since they had traveled outside. So visas was something which regulated foreigners from coming to India. But at the same time, we also had to fight out with the Indian citizens who could have had been potentially infected from certain countries. So they kept on coming in India. Now, one of the issues, as I said, that the issue was how do we enhance our testing capability? Now, if you actually go back in the history, Jan 21 was the first time when first RT-PCRs were done in ICMR, National Institute of Virology. Now, that time globally, the number of cases were only 314. Now, you have to understand one thing, that ICMR was interested this task because ICMR had close to about 116 virus research diagnostic labs. 35 labs were used to doing RT-PCR for influenza surveillance. And then we thought we will have to expand then. By January 28th, there were only 22 tests that were conducted so far. And if you look at the first case when it occurred, globally, the total cases were only about 8,000 odd cases. And if you look at how many actually occurred outside China, there were only 82 cases, but they were being reported from 18 countries. So 18 countries had the seed sown at that point in time. Today, we have conducted 11.5 crore tests. Every day, we are conducting 12 lakh tests today. There are about 2,069 labs, of which 1141 labs are from the government. We are third highest in number of tests that we have conducted after China and USA in the world. At that time, WHO said on March 16th that we need to test, test, and test. And then once you diagnose, you isolate and trace contacts. That was a strategy that they talked about. Now, one question which we are always asked, was the testing restricted ever? We never restricted our testing. It was in consonance with all the guidelines which were drawn from all the countries. So we were never falling behind. Lockdown, despite the fact that there was lockdown and provision of kits to different centers was a major challenge, we continued to provide them, and our testing capacity was never fully utilized until June end. That's something which we take pride in. Then Prime Minister, he gave a call for being Atmanirbhar. The reason was very simple. You know, at that time when lockdown was implemented, there was hardly anything that was being manufactured which could have had been used as easily in the country. When we first went for buying the kits, we found it was extremely difficult, mainly because the entire world was looking at the Chinese kit manufacturers. Even the reagents used to come from China. And then one of the fears was, how would we be able to fight with this infection? So the call was made, and domestic manufacturers gave such a beautiful response that we became self-sufficient, and importantly, we also became exporters of kits. The first kit that received emergency use authorization by US FDA was in June 2020. And today, because of domestic competition, the cost of kit is close to about 140 rupees for RT-PCR kit per test. That's how it has come down, just because of competition. One of the issues was whether we go for lockdown. And that was at a backdrop that China tended to suggest that military was being used for non-pharmacological interventions, and it appeared to be successful. You have to remember that in India, if we were to fight in a normal way, that if we were to teach everybody how to follow these non-pharmacological interventions, it would have taken years for us to reach. Now, the only way we thought we could be doing this was to go by lockdown. However, because we recognize that mobility is an important determination in exposure and spread, so the lockdown was started on March 24th. There were a couple of episodes of focal outbreaks that occurred that led to prolongation until May 31st. But the major success was there was a delay that we could make in onset of this outbreak. And the challenge was migrants and economy, but some of the things were unavoidable. This lockdown actually helped us in production of PPEs, disinfectants, ventilators, even RT-PCR machines, which were not available in India at that point in time, for supplies to the labs which were being upgraded, and the reagents. And we didn't have sufficient ICU beds. We had to also train the manpower in ICU management, which was something which many centers were not exposed through. This was done through telemedicine. If you look at what impact did it have, today if you look at it, India ranks in the bottom second place when it comes to death per 100,000 population, and that's something which is an achievement which we cannot reconsider. The one of the reasons is, you need to remember that if you even look at the death rates that occurred earlier, that were observed earlier in the outbreak, continue to be sliding over a period of time. The risk of death has started diminishing. Now, is this virus mutating is a question which people tend to ask. There is a mutation at D614G, which is talked of as one that may be causing it. But one must remember that these are purely association studies or standalone phylogenetic studies, so not much of inference can be drawn on that. We also need to remember there are only the virus mutates at a rate which is very low of two mutations per month, which is half of what influenza is and 1/4 of what HIV mutation rates are. And therefore, that's something which is important for us to remember. What is a good thing out of it? The good thing is, we know when the mutation rates are low, we know that drugs will continue to work for a long period of time, and also about vaccines which will continue to work. We need not fear about it. What could be the reason for lower death rates? Could it be underreporting, as some people negatively, when they start thinking, but we don't have such a evidence available? That it gave us the time advantage, and it was used successfully to prepare ourselves for risk mitigation. We could apply, in terms of medical management, whatever the world learned in the first half to improve the patient management in India. And it is also that perhaps it could be because of cross protection that may be existent because of other coronavirus infections that occur within the country, as well as provision of BCG. We still don't know. We continue to think about it as one researchable area. Could we have had a shorter lockdown? Perhaps not. Now, if you see in the table, these are the dates when the lockdowns were announced, and the total number of infections and deaths are represented there. Now, what does it tell you? It tells you that we started with the lockdown very early. What is also important is India has one of the better kind of public health infrastructure compared to any country across, except perhaps Bangladesh, which is as strong for us to think about. We were almost 2 months into an outbreak when we started. We thought that perhaps we will be able to go for better contact tracing and control of this infection. However, for whatever reasons, no, it could not happen. It is possible it is because of the lockdown, people stayed in the houses and they did not report very quickly. The result was they spread the infection to other family members who perhaps have led to this explosion that we are seeing. When you think in terms of contact tracing, now there were certain challenges that we had to overcome. One was stigma, because this disease is associated with fear of death, ostracization of the family, probability of finding a family member as infected. People tend to hide this infection, as well as the number of risk contacts that they had so far. So one of the things which one needs to contemplate is provide counseling support to such people, train the peer counselors on communication skills, improve the communication strategies for stigma reduction. And since this infection occurs more often in lower socioeconomic group, provision of ration and economic support for somebody is a family who has been found as infected would become important given the fact that the isolation tends to occur within the family once within their houses are sealed, the movement or their movements are stopped of even the family members. Now we try to understand the epidemic curve among the high burden countries as such. What is it that we are seeing? You tend to see that there are close to about 3 waves that you are seeing in the green line as such, which is represented by USA, whereas the red curve actually belongs to India, which will the implications we'll try and understand later. Now, some people, if you look at the curve, epidemic curve of Germany, you suddenly find that the curve is very clean. The first wave occurred, and after that, that was a smaller peak. But after that, what has happened is suddenly the curve went into a second wave, and the second wave is far stronger at this time in Germany. Now, the question that arises is, will there be a second wave in India? Now, if you actually see at the epidemic curve, you suddenly start feeling whether our outbreak is yet to mature. Is it that it's a reflection of test kits that are being used? Mainly because rapid antigen tests, tend to have high false negativity even among those who are symptomatic, and it actually needs to be followed up with a RT-PCR test if rapid antigen test comes negative, and that's the reason you tend to miss almost 2/3 of the cases. Is this that it is being reflected in this particular curve is an issue we need to think about. But there is one thing which we don't know, and that is, when do you call the curve as flattened? Is it degree of decline, or is it time correction, that once it reaches around the baseline, perhaps they spend about 1 or 2 months time at the baseline itself, and then it starts climbing up? Because these kinds of waves like pattern, ups and downs, are likely to be common. So to my mind, we need to have a relook at this particular question. And the reason why we need to do that is our situation is slightly different. If you look at our situation, you find that ours was an imported outbreak, and there is a heterogeneity in maturity of outbreak, because maturity is essentially meaning the seeds that are sown. Not every state in the country would have people who would go outside the country as often. So the seeds could have been sown at a different point in time. Heterogeneity tends to exist even for our intensity of outbreak, because that essentially depends on the drivers of the epidemic. The population density varies in different geographic area. Migration and mobility is also different in different geographic areas, including states or cities. And mobility is extremely difficult to control in any given area as such. So what is the inference that I would like to perhaps make? One is, overall second wave may not be seen in near future. Now you will find that there would be ups and downs in the numbers, but you will not find that we will touch the baseline very quickly. And the reason is, there are different cities and towns which mature at different times. So they would keep on contributing or not contributing at even any given point in time. There is stronger likelihood that there would be available, the preventive interventions would be available with respect to vaccine, or drug treatment would emerge in near future. The result is the likelihood of occurrence of second wave is minimized in these circumstances. But still, one must remember that these infections can increase due to the festival season, and that's the issue which we have to keep at the back of mind. So is the second lockdown possible? That's another question that we tend to face, and that is mainly because European countries are going for second lockdown. To me, in India, this will not happen. The reason why it will not happen is lockdown requires a balanced strategy between the adverse health outcomes and economic impact. And now what we have understood this issue, and we are going for decentralized calibrated strategies that by levels of outbreak and the impact that it has generated. So essentially at every particular city, the calls will be taken as to what kind of strategies would be adopted, or even within a large city, even in a small area, what intervention strategies should actually be adopted there. Now let's come to diagnosis. How would you know that somebody is infected or not? We know the gold standard is RT-PCR. It takes about 4 to 5 years to test them. But if you look at the sensitivity of this particular test, it is also low. You can do 90 tests in a single run. What is more important for us to understand, in order to overcome the whole thing, a point of care antigen test has been approved. But even there, the sensitivity, when you compare it with RT-PCR, is only between 50 to 84%. Now, this essentially means that the test would have more number of false negatives. So you need to confirm them. Those who become negative and are still symptomatic, you need to confirm with RT-PCR. The whole test would require 45 minutes, up to 45 minutes to complete. India was the first country to use the same. Today, the recommendations are being adopted elsewhere in the world, where we had identified two different settings: in the field to do it in containment zones, and in the hospitals to segregate patients as such. One issue which we commonly face is provision of antibody test. Now, when it comes to antibody test, we need to remember that we don't understand the significance of IgM or IgA as much. We know IgG perhaps has a small component of neutralizing antibodies. But when do you do it? You have to do it in the second week that tends to follow. You will find that the frequency that people could have in terms of positivity drops down, the sensitivity drops down, and as the time passes by, the sensitivity increases. Ideally, you should do it after 3 weeks of becoming symptomatic, only then it becomes positive. And this could be a useful tool to understand whether the person has no longer the fear of developing any kind of complication, since the immune system is reacting. Now let's try and look at the pathophysiology of COVID-19. We know the virus enters through nematocytes, and once it enters through them, you find there is a direct cytotoxic effect. And in the second stage, you will find there is dysregulation of RAS, endothelial cell damage could occur in the third stage, where thromboinflammation may occur, and a dysregulated cytokine storm could be seen in the last stage as such. Now, what is worrisome is this disease tends to have many extrapulmonary manifestations. And why do they become important? Mainly because this virus has hardly been seen. It is the frequency of finding it in the bloodstream is so low that we tend to worry why these extrapulmonary manifestations are occurring. And that's something which is extremely critical for us to understand. We remember that about 20% of those patients who are admitted in the hospital with severe disease, moderate to severe disease, you will find they may develop what is called as cytokine storm. Now, can we predict who is going to worsen? Do I need to repeat all the investigations for all parameters of inflammatory, cardiac, renal, hepatic, and immunologic test all the time? Perhaps not. Now we are understanding little more. Baseline D dimer levels have been associated with the risk of development of thrombosis, acute kidney injury, and it is also something which talks about all-cause mortality. The risk tends to vary by the levels of D dimer level, and any level that is above 230 nanograms should be considered as a predictor for adverse outcomes as such. But if you look at this particular disease, it tends to lead to some kind of concern about diversity. And why does this happen? 40% of the individuals who have COVID-19, they remain asymptomatic, and only 10% require hospitalization, and only about 1.5% tend to die by this infection. Only some tend to develop post-COVID syndrome, irrespective of the fact whether they were symptomatic or asymptomatic. There is a little difference in viral loads between symptomatic and asymptomatic individuals. Now, why worry about such an infection? The reason is very much simple. Now, recent evidences tend to point to one fact that 10% of these individuals who acquire this infection, they will develop autoantibodies as such if they have severe disease. And the implication of autoantibodies tends to become immense, mainly because it is those become suddenly responsible for the secondary outcomes that tend to occur after discharge in the post-COVID syndromes. And we still do not understand much with respect to polymorphisms in toll-like receptors and TIMPRES, which are important for entry of this virus into pneumocytes as such. Now, think in terms of who is likely to develop autoantibodies. Among critical patients, there is one thing which we must remember, where people more than 65 years of age and males are more likely to develop autoantibodies. It is likely that we will understand the implication of development of autoantibodies in much better fashion over next few months with the studies that have been launched at this juncture. But what is worrisome is persistence of symptoms. No, 87% tend to have at least one persistent symptoms even after discharge from the hospitals, and that could be fatigue or dyspnea. It's never fever, and this could continue at least up to 2 months period, and that's something which is a more worrisome thing. 35% of the people who have COVID-19 and get into the hospital, they are likely to become persisters. And who among them are more likely to be persisters? Those who are older than 50, those who have their BMI above 30 kg, and if somebody has a psychiatric condition, the risk of development of becoming persister tends to increase by almost 2.3 times, and that's something which is a worrisome feature. Now, why must this be happening? This must be happening because there it could be an effect due to unmasking of underlying chronic comorbidities, residual damage from the acute infection, persistent or restricted viral replication that may occur in sanctuaries which we do not know as of now. But there may be some sanctuaries like you have in HIV, which we will understand later, or a poorer immune response that the host tends to give. Persistent immune activation could be a phenomena that may lead to the same. What is it that you are supposed to do for all those cases which had COVID-19 for preventing post-COVID complications as such? Most of the things that you have to do are related to exercises. And thromboprophylaxis prophylaxis has perhaps to be continued for 10 days post-discharge among those who had pre-existent cardiac lesions, and that would prevent the major problems that may ensue after COVID infection. But one thing which we must remember, that once somebody acquires COVID-19, there is a fear that he may forget about non-pharmacologic interventions. We need to emphasize correct use of mask, social distancing, and hand wash. That's something which is very critical because we don't know much about reinfections as of now. When it comes to reinfections, one must remember reinfection is a feature that you see in coronaviruses as such. There are at present 5 cases which have been confirmed to have reinfections in India so far. Now, if you look at the rough estimate of what proportion of cases would have reinfection, it's very low. It is less than 1%, which essentially means that's a good feature. And perhaps the fear that we have that there is no protection after COVID-19 infection is perhaps exaggerated, and that may not be so much true. But another redeeming feature is these cases are not known to transmit infection to others, and therefore they may not pose a risk to others at least. Another important feature of this disease is when it occurs in pregnancy. We need to remember mother to child transmission is rare. The mode of delivery does not impact transmission. There is no transmission that occurs through breast milk, does not result into congenital abnormality, but use of favipiravir has been shown to produce teratogenic impact in animal studies as such, so we need to be careful. COVID appropriate behavior while feeding tends to protect these babies from acquiring this infection. And the severe PIMS syndrome that we generally talk about is very rare, so we need not worry. And that information can be utilized to counsel a pregnant woman who's extremely worried when she comes out as COVID-19 positive. We need to explain the risk of acquisition, that it is easily preventable, there is a low risk of transmission to baby, and there are factors which are involved in severe maternal disease. Test can be performed. The fear of isolation during and after delivery needs to be alleviated, and any hospitalization or death due to COVID in family tends to create a botheration for this woman. We need to talk about it to her and explore the socio-economic impact, because some of them may have had lost their own husband and he may be the sole earner. These issues need to be posed to a pregnant woman during this pandemic time, because you find that pregnant women are not attending even antenatal care clinics. The sole reason is the fear that they may acquire, and it may be a difficult thing to handle for the baby. Now let's try and look at the kind of medicines that we use. Now I would perhaps focus this way through the 5 tenets that have been discussed in by one of the scientists I said. This is medicine without magic or bullet. And the second principle is think Bayesian. Bayesian is actually related to posterior probabilities, no, which essentially means you need to rely on your own past experience. No, and that becomes very important for us to think about when it comes to zinc, vitamin C, and D. You will suddenly find that these are the drugs which have been prescribed very heavily for any infection where we don't have a specific management as such. Now, which essentially means they are less likely to be successful, because over a period of time we realize there is a different antiviral that you have to use, there is a different antibiotic that you can use. So it essentially means that the reliance on these managements have to be reduced to a larger extent. When it comes to therapeutic drugs, now that's something which is a major challenge. We need to understand about it little more. The reason is, this infection tends to provide you a very small window for intervention, because the transmissions tend to occur on -2 days, that is 2 days before being symptomatic, and 2 days after. You find 76% of transmissions can actually occur. Now, if I want to reduce this virus and the viral loads as such, you would like to do it at the earliest. And therefore, it becomes a major challenge. What we have done so far is taken a approach which has never been hitherto taken. We started dropping ineffective drugs instead of adding an effective drug for management. And that's an approach which actually is mainly because of the panic that was set in. People wanted to save lives. Which are the drugs which are now known to be ineffective? Lopinavir, ivermectin, oseltamivir, favipiravir, hydroxychloroquine, tocilizumab, convalescent plasma, interferon, and now there is a question even for remdesivir. What is the best thing which we can do? Is provide quality supportive care and provision of steroids at the right time. Look at remdesivir. You find 5 days regimen. There was only one evidence that 5 days regimen is almost, there is no difference between provision of this drug for 5 days versus 10 days. Though there was no major sort of positive outcome that you would expect, except for the median duration of hospital stay, which was almost 4 days shorter for those who received remdesivir. Did these evidences change? No. But then at the same time, we need to remember, when solidarity trial that was conducted by WHO, what is it that is being reported? We found that remdesivir is useless, hydroxychloroquine is useless, lopinavir and interferon is also useless. Now that creates a confusion. Now, do I use remdesivir or I don't use remdesivir? For rest of the drugs, we are very comfortable, they can be dropped off. One must remember, neither can it become standard of care, Neither do we have evidence to say that this is absolutely useless, because this solidarity trial was an effectiveness trial. Now, we don't have an evidence which could actually take you to it as a standard of care, though US FDA has also approved, but we don't understand, that doesn't appear to have a strong evidence base to make it into standard of care. So remdesivir may be useful in certain circumstances. We don't know when to do that. When it comes to recovery trial, this was the biggest success story. In recovery trial, tended to show to us that those patients who required oxygen, if they are provided with dexamethasone, there could be a rapid improvement in terms of clinical outcomes. But there is one thing which we have to keep on remembering, that you should not give it to people earlier or prior, because if you provide it to a patient who doesn't need oxygen, it is possible that immune suppression that may follow may lead to increasing odds of developing an adverse outcome. And that's why you see that the risk is almost 1.22. Now, if you think in terms of 28 days mortality among patients who don't require oxygen. So don't provide it too early. You provide it only among those who require oxygen, and that would be extremely helpful. The tenet number 2, which we have to remember, is the essential practice is doing almost nothing, as many of these drugs are ineffective. Look at ivermectin. Ivermectin actually requires 100 times more dose to achieve adequate blood levels in the lungs, and there is no robust evidence currently for its use, whether it is for treatment, whether it is for prevention. So it would be good not to use the same. When it comes to lopinavir and darunavir with cobicistat, these studies perhaps were backed by evidences of ex vivo studies, but there is no evidence that it can make a clinical impact so far, so it should also not be used. When it comes to hydroxychloroquine with or without azithromycin, there is no clinical benefit that is associated with it. It tends to have higher toxicity, especially prolongation of QTC in older patients as such, and that is also to be avoided. When it comes to, we talked of cytokine storm, which occurs among 20% people. One of the things that happened was we started using tocilizumab. Now, this also works on IL-6. If you actually see, the manufacturer himself, Roche, they did 2 trials. One of the trials tended to show no difference, and the other trial tended to show that it has almost 44% protection in patients who have pneumonitis, that they don't require ventilation, or they don't go, they tend to die. One of the bigger worries of use of tocilizumab is we have latent TB infection, which is very common. Secondary bacterial infection tends to be common once you use this monoclonal antibody, and especially the worry is with respect to LTBI, because we don't know what will happen out of it. We must also recognize that majority of these monoclonal antibodies which are directed towards cytokine storm using IL-6 related issues, we find that they are failing over a period of time, whether it is sarilumab, whether you are talking in terms of Kevzara, all of them are failing at this juncture. When it comes to convalescent plasma, some of the studies tended to say that this is a useless thing to do because there is no difference, especially Mayo and ICMR's Placid trial. Though US FDA continues to keep it as emergency use authorization, it should not be treated as a standard of care as such. Why convalescent plasma may not work? Because this is a polyclonal thing. No, you would have many antibodies, but they may not be neutralizing antibodies, or their titers could be very low. When it comes to the virus dies in 10 days of being symptomatic, and the damage that it is causing is mostly through indirect approach, and that is immune response that leads to the damage. And this may not be easy to be controlled by monoclonal antibodies, by antibodies as such. By the same logic, one must understand hyperimmunoglobulins will also have limited impact, though their assessments are yet to be done. When it comes to monoclonal antibodies, Trump made it more popular or more readable, but you must remember that they are also going to have limited impact because you need to provide it very early in the infection. What matters in the management, as tenet number 3, we need to tenet number 4, we need to remember that elevate usual care. And what is it that we are hinting at? High nasal flow oxygen, provision of prone positioning, quality management of morbidity, and what is important is provision of steroid. Dexamethasone works really well. You can provide it for for about 10 days on ventilator or requiring oxygen. What is important is you don't need to provide it for somebody who doesn't need oxygen. You could actually even substitute using different preparation of steroids, and their equivalence for methylprednisolone is about 32 milligram, prednisolone is about 40 milligram, and hydroxycortisone for 160 milligram. The frequency will vary by their half-lives. Now, there are so many papers that are getting published, and this as COVID-19 has led to an infodemic. One of the worries that we have is how do I rely on social media is also full of all kinds of recommendation. You need to believe in the tenet number 5, focus only on high quality evidence. We need to remember that researchers or healthcare professionals, all of them are doing the same thing as we heard of the blind men, 6 blind men touching the elephant and talking about them wherever they have touched, thinking that that could be a root cause. You need to remember the hierarchy of evidence. When it comes to hierarchy, you'll find that most of the evidences that you would like to weigh should be from randomized control trials for primary research. And when it comes to secondary research, you need to have meta-analysis, systematic reviews, and evidence-based guidelines which you can rely on. If you actually look at the craze that is actually taking place when the entire scientific fraternity is going on publishing about this infection, you find in COVID, there are close to about 70,000 publications in 10 months. Compare that with influenza, HIV, TB, those which are there for many decades, their numbers are far too small. So there is an explosion of information. The pyramid for hierarchy has also been reversed. You find large number of systematic reviews and meta-analysis, and that's mainly because you find there are delays in publication and there are preprint unreviewed manuscripts which become available for people to see. When you read a meta-analysis, please try to focus more on most recent one rather than otherwise. We come finally towards vaccines. There are people who believe vaccine will not come for multiple reasons. But the reality of life is most of the vaccines against viral diseases required almost decades. However, in this case, in 10 months, you have close to about 200 odd candidates vaccines which are being developed, of which 27 are already under trial. Certain issues which we need to know about vaccine trial. We don't know how long the immunity will last. Reinfection tends to appear as rare, so booster dose may not be required. If I take adenovirus based vector vaccine, no, there could be a fear that once you administer it, if a booster dose has to be given, the antibodies that the first dose has generated can impact and ensure that perhaps no, the take may not occur for the second time. The efficacy in vulnerable groups has to be studied because the take tends to be lower. Then there are newer platforms. There is no past history of experience and understanding. You need to look at safety because there is no compensation for adverse events that will occur after use of these vaccines through emergency use authorization. There are prioritized populations which are being considered. What is important for us to evaluate is the acceptable efficacy bar has been maintained by WHO at 50%. But you will have to evaluate whether protection of masks, which is up to 40%, no, do I take that kind of risk or advise my patient to take the risk of that kind is something which we'll have to remember. There would be a need to test for antibodies before you administer vaccine, and we currently don't know the surrogate measure of protection for COVID-19. When the vaccine will come, the vaccine will have whatever vaccine efficacy is there. If I want to ensure that adequate herd immunity occurs after vaccination, I will have to look at coverage. So the coverage has to be as rapid, as large as possible. But our experience with respect to adult immunization tends to be very poor. Look at H1N1 vaccine. Now this was being provided free for Maharashtra state, and look at the acceptability. There are very few people, proportion, which are accepting, and that's a major cause of concern. More importantly, if we were to provide vaccination to all, it might require between 3 to 5 years to provide these vaccines, one single administration to everybody in the world. Being second highly populous country, can India deliver? Yes, we are a vaccine production powerhouse. Our track record, we have to believe that when we do census, we can do it on one particular day. We count 1.3 billion people. If we want to do it, we will do it successfully. So don't worry about it. Now, patients, when they will come to you, you need to select a vaccine because there will be multiple vaccines. So what do? You look at efficacy, especially for the vulnerable age groups, that is older age people and children. You look for duration of protection, whether you would require a booster dose. You go for toxicity, evaluate that. The production capability, cold chain requirement will perhaps decide whether you can use that so easily, and the community acceptability. At the backdrop of this kind of information, you find that non-pharmacologic age-old interventions are the only option. Whether you are infected or not, whether you are vaccinated or not, people will have to continue using non-pharmacological interventions until the time we understand more about reinfection. Because if the virus will find any vulnerable person, the attack will suddenly be mounted again. So universal masking is critical. It reduces the risk of transmission by half in India, and indirectly it may lead to reduction of third of the deaths that you would expect by February 2021. Fortunately, if you ask people, always use of mask is as high in India as one would think of, which may not be a reality elsewhere. We have 73% of the people who report always use. But despite that, there is high seropositivity. What does it tell you? That its use is improper. While talking, they are lowering it. So we need to involve the communities. Please talk about this particular issue whenever you see patients. Be opinion leaders by wearing the mask yourself. That will make a major difference. But unfortunate part is primordial prevention tends to have a different connotation for us now. Spanish flu, SARS, and MERS, we remember that they had the same non-pharmacological interventions, but our practice and memory of precautions doesn't last long. We need to involve the communities. When it comes to doctors, how have we navigated so far? Exemplary response in the most challenging times, never lost sight of patient safety and health, laudable untiring efforts, especially by juniors in particular, undeterred dedication, despite the fact that many lost their own lives. Every doctor's death is not only a loss to their family, but it reduces access to their thousands of patients. If you look at case fatality rate, which is very difficult to understand, it is almost 10 times higher in India when it comes to the doctors' fraternity. And if you look at only practicing doctors, the risk is also 2 times higher. And that's something which is worrisome thing. If you look at who is likely to die, no, in terms of proportionate deaths that are occurring, 59% of them were general practitioners. And if you look at medical specialists, a significant proportion is coming from pediatricians. Now, what does this connote? That perhaps these are the people who never thought that they are vulnerable. If you look at people who are intensivists or working in ICUs, the risk of death was comparatively lower. And that's something which tells us that we need to adhere to different risk practices. Please use your PPEs, never lower your guard, and test the patient whenever you are in doubt is a principle. In conclusion, we must remember COVID-19 is more likely to become an endemic. The new norms will continue to exist for quite some time. Industries will become more mechanized. There would be a long-term impact on how we live our daily lives. Newer economic order in a contracted global economy is likely to emerge. We will learn the futility of outwardly happy and free world to the internal peace or family time that we understand today. Please follow COVID appropriate behaviors rigorously and continue to remain safe, not only for you, but also for your own family. Thank you.
Thank you very much, sir. Sir, you have really simplified COVID with your listed presentation and dispelled many doubts in the minds of us healthcare workers. And sir, we are in awe of the scope of work done and governed by you. And we do feel encouraged by your reassuring words that second wave is unlikely. Now, may I request our national leader of IMA Dombivli, Dr. Mangesh Patel, sir, to deliberate over today's topic. Dr. Mangesh.
Ganga Khedkar sir, very thankful to you for this great oration. And I will say today, it was not honor for IMA Dombivli or for the medical fraternity over here today, but India is honored to have stalwarts like you. Taking few of the gist from your presentation, absolutely apt as far as the scientific aspect is concerned. And Dr. Bondwe sir, our state president, will definitely echo my feelings, agree with me that you have put forth in different words what was the say of Indian Medical Association. Sir, you have very categorically mentioned one sentence that the management of a pandemic is a very delicate and sensitive and has to be national. In other words, if we say the federal mechanism has to be applicable when we deal with the pandemic, and definitely may it at the state level or at the civic body level, we definitely witnessed flaws in the execution. Indian Medical Association always appreciated every guideline whenever you gave right from the 1st of the March. Let me assure you, sir, it was 28th of March 2020 when myself, Dr. Avinash Bondwe, our state president, it was the day one when we gave the first guideline, which was parallel to your guidelines to the government of Maharashtra state. Not only that, from our state IMA branch, we have sent all the guidelines, simplifying them for the common people for public awareness. Unfortunately, the scientific say in this country does not have a much platform and much say. I will just, before ending up and summing up this phenomenal oration, sir, I'll put forth my version over here. Pandemic management is not a joke. It needs the scientific stalwarts like you to handle this management. Unfortunately, the political way of management of pandemic is overtaking the great stalwarts like you. And Indian Medical Association always has reiterated this stand all across the country. I am very thankful to you for this lucid and phenomenal oration. Thank you so much, sir. Thank you.
Thank you, Dr. Mangesh. Now I request our IMA Maharashtra State President, Dr. Bondwe sir, to deliberate over the session. Over to you, sir.
Bondwe sir, unmute yourself, please.
Sir, you'll have to unmute.
I will say there are no words to express our gratitude towards Dr. Raman Ganga Khedkar. Rather, I'm personally very fortunate to have his support, backing, and the intellectual support also, right from the first day of my practice. And literally, in nutshell, whatever he concluded, whatever he delivered, was everything which we need, right from the how the COVID spreads to the doctors' conditions and the number of doctors getting infected, and there are many general practitioners involved. All these figures we have been rather talking to the government, to our people all the time, and all these points which he has delivered will be really really a great pleasure for us. I request Dr. Raman Gangakhedkar sir
अरे
to if you
सर
of
नहीं
this,
है
this is respect to your honor, respect to your ability, sir. So I would request you to make your presentation available for the benefit of all our members, those who have not attended. It will be really a great treasure for us to follow the guidelines and whatever the advice you have given. So once again, I thank you personally and on behalf of Indian Medical Association and of course our team Dombivli for delivering this really phenomenal lecture. Thank you very much.
Thank you. I'll send the slides.
Yeah.
You require that.
Thank you, Bondwe
Thank
sir.
you, sir. It was a great pleasure and honor really to have you for our prestigious oration, and you presented a wonderful presentation made simplified for all of us. Now I request our patron and national leader, Dr. Mangesh Pate sir, to cater the citation to today Dr. Raman Gangakhedkar sir. Sir, please. Aditya, slide of citation.
I'll read the citation.
And I request Dr. Nikki madam to please read the citation for all of us.
Thank you, Hemant. Sir, this is our citation. Indian Medical Association Dombivli, IMAFEST 2020, Dr. U. Prabhakara Oration 2020. The citation reads, Dr. U. Prabhakara Oration is a prestigious oration award of Indian Medical Association Dombivli, instituted in the year 2015 for excellence in the field of medicine and selfless contribution to the medical fraternity. The oration for the year 2020 is being presented to you, sir, Padma Shri Honorary Dr. Raman Gangakhedkar, sir. Sir, you are an excellent philosopher, thinker, researcher, scientist, and a great human being. You have been referred to as the one who is always been beloved of all his patients, and to his patients, you are one who is next to God. You were born in Mumbai in 1958 and did schooling from a Zilla Parishad school. You completed graduation from Government Medical College, Aurangabad. You completed Masters in Public Health from Johns Hopkins Institute, USA. You have been an eminent clinician and epidemiologist and were instrumental for devising guidelines for policy making at national level for management of HIV and AIDS, Nipah virus, COVID-19 virus. Sir, you became the face of ICMR during government briefings about Nipah and COVID-19. Sir, you have worked with many prestigious organizations like National Institute of Nutrition, Hyderabad, NIH, Mumbai, NIV Pune, National AIDS Research Institute, Pune. Sir, you have headed many prestigious government organizations like Director of National AIDS Research Institute, NARI, Epidemiology and Communication Disease Wing of the Apex Health Research Body, Indian Council of Medical Research, ICMR. Presently, you are serving the nation as Dr. C.G. Pandit National Chair of ICMR. Sir, you have been awarded many national and international awards and citations like Fogarty Fellowship from National Institute of Health of the Johns Hopkins University, Baltimore, USA, FXB Fellowship of the Francois Xavier Badgund Foundation, Switzerland, Sir, you were bestowed with Padma Shri Award from the 4th highest civilian award of the Government of India in the year 2020 for your work in HIV and AIDS. You catered to the field of HIV when it was still a big stigma. Your penchant for straight talk was made you popular in press. Your trademark is your ability to break down complicated scientific concepts into colloquial Hindi, and you have earned a fond moniker, Ganga Chachu, on Twitter. Sir, Indian Medical Association of Dombivli feels proud to present the prestigious Dr. U. Prabhakar Rao Oration Award to you on the 8th of November 2020 during 21st Annual Conference of IMA Dombivli in IMAFEST 2020, and we join your many well-wishers in wishing you the best in all your endeavor. Dr. Sunit Upasni, President IMA Dombivli, Dr. Mangesh Patel, Organizing Chairman IMAFEST, Dr. Heman Patil, Honorary Secretary IMA Dombivli. Thank you very much. This was our citation.
Thank you, madam. Now I request President IMA Maharashtra State, respected Dr. Avinash Bondwe sir, to please present the memento to Dr. Ganga Khedkar sir.
So this felicitation is presented to Padma Shri Honorary Dr. Raman Ganga Khedkar for his today's prestigious oration. Please accept it, sir.
Thank you. अरे परत सर म्हणू नको, मला एकदम कस तरी वाटतो. मी तोच आहे, ते काय पद्मश्री मिळाल्याने काय फरक पडत नाही.
कार्यक्रम संपल्यावर.
Now I request President Dr. Sunit Upasni sir to present the memento to our President IMA Maharashtra State, Dr. Avinash Bondwe sir.
Accepted.
Thank you, sir, for your gracious presence. I request Dr. Sunit Upasni sir to present the memento to our national leader and patron, Dr. Mangesh Patel.
Thank you, sir.
Thank you, sir. Thank you for your august presence. This was wonderful oration. First of all, I'd like to thank you, Dr. Ganga Khedkar sir, for giving us your valuable time and a wonderful presentation guiding us in this COVID pandemic. I'm sincerely thankful to our President, IMA Maharashtra State, Dr. Avinash Bondwe sir, for his guidance. Thank you, Dr. Mangesh Patel sir, our national leader and patron, for guiding us for this program. Thank you, Dr. Sunit Upasni sir, our President, IMA Dombivli, for making this event happen. I thank all the dignitaries of IMA Dombivli state and across the country for being present in this oration. I thank all the digital platform, DigiShield, for providing a digital platform to conduct this oration. I'm also thankful to the media team, Creative Hub, for creating wonderful slides and momentum. Thank you. Thank you all.
Thank you, sir.
Thank you, sir. Thank you, sir, for your presence. As we are short of time, we will be skipping the lunch hour and we'll proceed directly with our next session.
Good afternoon, everyone. After a wonderful oration, the prestigious UPira oration by Dr. Raman Ganga Khedkar, We proceed to the second half of the second day and the concluding second half of our IMAFEST 2020. We now go ahead with our next sessions. Dr. Aparna Hegde will speak about incontinence, dribble, and big trouble. Dr. Pritam Kalaskar, family malignancies. Dr. Upendra Kinjavadekar on pediatric COVID. We go ahead to speak about dribble. Dribble, sneezing, coughing, any increase in the pressure leading to leaking urine, a very uncomfortable and embarrassing experience for most of the females out there. Also common in geriatric patients. So let's hear from Dr. Aparna Hegde, the speaker of this topic, incontinence, dribble, a big trouble. We have moderator, Dr. Niti Upasni with us. I invite Dr. Niti Upasni to moderate this session. Dr. Niti Upasni, consultant gynecologist and obstetrician at Indira Hospital and SRV Mamta Hospital in Dombivli. She's done her MBBS and EGO from LTMMC Sion Hospital, past president of IMA Dombivli, past secretary IMA Maharashtra State Women's Doctors Wing, convener IMA Dombivli COVID Task Force, recipient of multiple branch, state and national awards and many social organization awards. Over to you, Dr. Niti.
Thank you very much, Dr. Vijaya Lakshmi Shinde. Dr. Aparna Hegde, madam, it is our honor and glory to have you here as an expert speaker on such an important topic, incontinence, dribble, a big trouble, overactive bladder causing dribble, and it is a problem which is faced literally by, I can say, up to 50 to 60% of women postmenopausal. And before we begin our session, let me introduce our today's great speaker, Dr. Aparna Hegde, MD DNB MS from Stanford University, International Fellowship from Cleveland Clinic, Florida. She has got a big introduction. I'll try to shorten it. Associate Professor, Urogynecology, Kama Hospital, GMC Bombay. Consultant urogynecologist, Global Hospital Mumbai, Surya Hospital Mumbai, and Women's Hospital. Founder and director, CUP, that is Center for Urogynecology and Pelvic Health, Delhi. Founder and managing trustee, Arman, NGO that works in the field of maternal and child health in 16 states and has impacted the lives over 20 million women and their children. A great job. Member editorial board, International Urogynecology Journal. Member International Urogynecological Committee, Prolapse. Member 7th International Consultant on Incontinence. Board member FIUGA, that is Foundation of International Urogynecological Assistance. Senior visiting fellow, IMA Ahmedabad. Madam, you look very young, so calling you senior visiting fellow is not. You are a senior visiting fellow. Principal investigator, NIH grant on dysfunctional voiding in adolescent girls. The awards are many in her kitty. The Skoll Award for Social Entrepreneurship 2020, TED Fellow 2020, WHO Public Health Champion Award 2017, British Medical Journal South Asia Award for Maternal and Child Healthcare Team of the Year 2018. You said Social Entrepreneur of the Year Award 2018. Women Change Maker Award 2018, Fellowship of the Menopause Society of Sri Lanka, one of the five global women leadership featured in the Voice of America documentary, single stage journeys of women leadership, among other awards. Madam, I can just go on and on and on, but we are eager to listen to your topic. So over to you, madam. Thank you very much.
Yes, thank you so much for having me today. It's really, I'm so grateful that you invited me. I just want to share my screen. If you can stop sharing
your... Yes, you have been made a co-host. You can share.
Yeah, I'm just going to share now.
Yeah.
So when I spoke to Dr. Upasni, she asked me to focus on overactive bladder, and that's what I'm going to focus on. So I'm going to start about with the evaluation of, one second, I need to kind of share my screen. Yeah, I'm just sharing this. Yeah. So incontinence is an extremely important issue, and it's extremely important that, you know, general practitioners and gynecologists have a complete understanding of how to treat incontinence and when to refer, whom to refer, and how to treat. Right? Can you hear me well?
Yes, madam, you are audible and your screen is visible.
Absolutely. So now, what are the kinds of incontinence, right? The first most important kind is stress incontinence. That is leaking on laughing, coughing, and sneezing, right? There's when you laugh, cough, sneeze, that there's sudden increase in abdominal pressure, and then woman leaks. That's called stress incontinence. And there's an urgency incontinence. What is that? You know, when your bladder is full and you need to rush to the bathroom, you know, some women are not able to control and they leak. So urine loss accompanied by urgency, they're not able to control. And then what happens in that is that your bladder contracts. Normally what happens is, like, I'm sitting in front of you, and if my bladder is full and I need to go, my brain will tell the bladder, now you're giving a lecture, so keep quiet. So the bladder will keep quiet. Only when I go to the bathroom, sit on the commode, my brain will give permission to the bladder that now no one is watching, so you can pee. However, in women with urgency incontinence as a part of overactive bladder, what happens is, unfortunately, once you feel urgency, the bladder is not listening to the brain and immediately starts contracting. So that is urgency incontinence. That is urine loss accompanied by bladder contraction, which are abnormal in response to severe urgency. Now, most women, that is 60% of women, will have mixed incontinence. It's very important to understand. Now, the first step to understand is overactive bladder. I'm going to focus on the OAB component of it because that is the topic of my lecture. Stress incontinence, I'm going to cover only a little bit, right? Now, what is overactive bladder syndrome overall, right? It is urgency, repeated need to go to the bathroom, along with frequency, that is more than 8 times in 24 hours. They may or may not have nocturia, that is going to the bathroom at night more than once, with or without urgency incontinence. So very important to understand. The overall overactive bladder is not just when they have leaking. You may, you know, there are some women who will, you know, need to go bathroom, you know, repeatedly. Every half an hour they go to the bathroom. They go to the bathroom 10, 20 times a day. They're not leaking. That's also part of overactive bladder, right? So urgency incontinence happens in a third of these women. But overall, overactive bladder would also include overactive bladder dry, where they're not leaking, right? But all of this happens in the absence of any bladder pathology. So it's extremely important to understand that you rule out bladder pathology and they've got urgency, frequency, with or without nocturia, with or without urgency incontinence. Now this affects 20% of the population. It's so common. Right? Now, it's so common that, you know, if you look at overactive bladder dry, it's more common than asthma, than bronchitis, than heart disease, or any, you know, simple things like sinusitis. Now, but unfortunately, because it's so common, women think it's a normal part of aging. It's not. Treatments are available. You don't have to live with this condition. You can treat both overactive bladder wet, dry, and stress incontinence. Now, first step is to find out what are the you know, causes for it and to evaluate properly. So once you understand evaluation, you're going to come to a point where you know how to treat each of these two conditions, right? So how do you evaluate? When a woman comes into your clinic, first thing to do is to rule out, you know, transient causes. So what are the transient causes, right? So if you have UTI, if you have delirium, right? Some women who have got delirium forget to pee and then they're fully bloated bladder and then they will leak, right? Atrophic vaginitis. When you have menopause, no hormones, your vagina is atrophic and it can irritate the urethra and you can have leaking. Medications, for example, diuretics, very simple, right? Or, you know, you're taking any alpha blockers, right? They can cause leaking. Then endocrine disorders, diabetes mellitus. India is the diabetes capital of the world. It may be the first sign of diabetes mellitus. Restricted mobility, right? The only thing maybe you need in an old woman who is not very mobile is to keep a commode chair next to her. If you don't have that and she can't run to the bathroom, she's going to leak. And constipation, right? Any woman is constipated, her incontinence problem is going to worsen. So these are things that are related. So you would rule out these transient causes. Next step is you need to understand if the leaking is because of coughing, laughing, sneezing, that is stress incontinence, or is it associated with frequency and urgency? That is urgency incontinence, part of overactive bladder, or it's mixed. That is, they've got both stress incontinence and urgency incontinence, right? So you have to rule out a type of incontinence based on the history. Detect uncommon forms of incontinence, right? So if sometimes when they have significant post-void residual, women are not peeing properly, right? So when you have high post-void residual, they may be having dysfunctional voiding along with it. Rule out that. Some women may be having prolapse. You know what happens is when you have prolapse, especially cystocele, it can kink the urethra. When it kinks the urethra, the woman is not able to pee completely, right? And if you go to urologist, they may not be able to find out that, right? And so Please, many women come to me with overactive bladder on examination. I find that they have got prolapse, right? So don't miss that. Pelvic mass. I have got patients in whom I've diagnosed fibroid. Why? Because they've been leaking away, and then you examine and you see this huge fibroid sitting on the bladder. So refer to a urogynecologist who can understand how to diagnose properly all of these things. What a complicated overactive bladder or any kind of incontinence, right? So if they have got recurrent incontinence, or along with the incontinence, they have pain, hematuria, recurrent infections, significant voiding symptoms, they're not able to pee properly, or any irradiation done to the pelvis earlier, or some surgery done there, or even fistula, right? Sometimes women will tell you that they're continuously leaking. So all of these are complicated incontinence, and you need to refer to a urogynecologist. So, when you do your, examination or history taking in the clinic, you need to rule out all of these things, so you know exactly what the woman is suffering from. In my clinic, I have an 8-page questionnaire that I send off to the patient, right, so that every symptom is properly diagnosed, right? So how to evaluate? So of course, all that I covered earlier needs to be properly taken care of in history. So good medical history and review of related systems. Treatment planning issues, right? So main thing is find out the goal of treatment for the woman, right? Maybe an old woman does not want complete continence. She only wants, that her life becomes eased. A younger woman will want complete continence. So understand her desire for treatment. Do not impose your goals on her, because 70% of patients can get better only on conservative treatment. So an old woman, you don't need to do Botox in her or second neuromodulation. Maybe when you do really good conservative management, she will be better enough to be able to live a comfortable life. So understand her goals. Right? Understand both storage issues and emptying issues. So if what does the bladder do? Bladder holds urine, that is stores urine, and then you pee, right? So you can have storage. You have to understand whether she has storage issues. So urgency, frequency, nocturia, and nocturnal enuresis, right? These are all storage issues. Normally when a woman bladder is supposed to hold urine, it's not being able to do that. And you have frequency or leaking. And you should also find out emptying issues. Like when she's peeing, does it take a little time to start peeing, called hesitancy? Does she have to push to pee? Is the flow interrupted? Is there burning while passing urine? Find out all of these things, because you need to rule out all of these things and understand whether it's pure overactive bladder or stress incontinence. Right? Physical examination, thorough examination, very, very important. Focused neurological examination, also very important, right? I have young girls coming to me with overactive bladder, and they've been given medication by some doctors earlier, and they're not examined her spine. Remember, in young women, when they come with leaking of urine, which is like overactive bladder, it may be a problem with the spine. So you have to do a focused neurological examination. I picked up so many spinal issues in young women with overactive bladder. Thorough urogynecological examination, along with POPQ, pelvic organ prolapse quantification. When you see a gynac doing pelvic organ prolapse measurement, very important to see that they've done POPQ or Baden-Walker, because POPQ helps you understand the exact measurements of prolapse, which will help you standardize the degree of prolapse that she has. Then you also have to do Oxford score. Now, what is Oxford score? Very simple. Oxford score is an examination which helps you understand pelvic floor muscle strength. I put 2 fingers in the vagina and I squeeze around it. I need to know the strength of the pelvic floor muscle. Why? Because if the woman has poor pelvic floor muscle strength, you need to do biofeedback. I'm going to cover that a little later on, right? Pelvic floor muscle exercises are the first line treatment for any kind of incontinence. So Oxford score, you need to understand. Every woman has to undergo dipstick analysis at least to see UTI, because the first step is rule out infection and treat it, because infection of any kind can worsen incontinence. Next, rule out whether a woman has stress incontinence, right? How do you do that, right? I told you stress incontinence is leaking on any kind of physical activity. So what do? You ask the patient to come in. So how do I do it, right? A woman has filled her 8-page questionnaire and taken thorough history. When I'm examining her, I'm going to ask her to be full bladder, correct? When I examine her. So I will first, on comfortably full bladder, right? I'll ask her to cough. On comfortably full bladder, if she leaks, that's called positive cough stress test. So she's sitting in lithotomy position in front of me, she's comfortably full, and I ask her to cough. If there's leak, it's called positive cough stress test. Then I will ask her to go and pee and come back, right? And when she pees and comes back, she will have a little bit of post-void residual. Then I will again make her lie down, and I'm going to do what? I'm going to ask her to cough again. That's called empty supine stress test. This one, right? Empty supine stress test. Now, why is empty supine stress test possible? Empty meaning you peed and come and you're lying supine and you're coughing. If you leak, that means that is, severe kind of stress incontinence, right? So when a woman has leaking only on full bladder but not leaking on empty bladder, it's a mild SUI maybe. But when a woman is leaking on even empty bladder only with post-void residual inside, that means that the woman may be having a bad sphincter, urethral sphincter. That's a very severe form of stress incontinence, right? So we rule out the severe, whether she has got stress incontinence and the severity of stress incontinence by doing these two clinical examination in the clinic that you have. Then you have to do a bladder diary. What is a bladder diary? Bladder diary is a very important thing. We keep a 3-day bladder diary. It's a record of what you drink, when you drink, right? This is a 24-hour bladder diary. We keep it for 3 days, right? Right. So first is what you drink, when you drink, how much you drink, when you go to the bathroom, how much you pee when you go to the bathroom, when do you have leak, and what were you doing when you had leaking, right? Did you have severe urgency to go to the bathroom, or were you laughing, coughing, sneezing? This baseline bladder diary gives me a lot of information, right? So for example, sometimes even drinking a lot of water, right? Too much, they can be having psychogenic polydipsia. Then you tell her to drink less water, right? If I may diagnose diabetes insipidus on the bladder diary, right? Or if she has frequent small voids and there's pain along with it, that can be a bladder wall inflammation called interstitial cystitis. Right? If a woman is peeing only at night a lot and leaking more at night, right? Then I know that it may be because of varicose veins. Because when you have varicose veins, along the daytime there is a lot of blood collected in the legs. So when you sleep at night, everything comes back to the kidneys, and maybe you leak more at night because you're making that much more urine at night. Right. So what you do in such patients, you will give them in the afternoon, tell them to lie down for 2 hours with their leg raised, so that all the fluid collected in the legs will come back in the afternoon itself, and the night there is not so much overloading. So a bladder diary will give you a lot of information. It'll also tell me whether, okay, is it stress incontinence, because she will say, okay, only every time she's leaking she will have some physical activity, or is it overactive bladder where it's leaking on the way to the bathroom, right? So I will be able to know baseline what is happening with the bladder diary, right? So that's an extremely important component of our examination. Then we do uroflowmetry, right? So it's very important to understand how is the volume and the flow rate, because I told you she may be having dysfunctional voiding, and you also need to look out for post-void residual. Very important. Why do we do post-void residual? Normally, a woman should have only 1/3 of a pre-voided volume in the bladder. Suppose my bladder is 600 ml, 1/3 of that only should be retained in the bladder after I pee, right? If you have more than that, it may be that she must be having, dysfunctional voiding, and that will worsen any kind of leaking that she has, right? So we need to find out post-void residual. Now, there's a test called urodynamics. Now, urodynamics is, I would not go into details of it. Please understand one thing, the urodynamics is just a laboratory understanding of how a woman pees. So we try to replicate in the lab what the bladder does. That is, we put fluid into the bladder and ask the woman to pee with catheters inside, which are measuring bladder pressures and abdominal pressures. So we will come to know the bladder muscle pressure, the detrusor muscle pressure. Now, remember one very important thing. When a woman with stress incontinence or overactive bladder comes to me first, I don't need to do urodynamics immediately. I can do conservative treatment. If conservative treatment fails, before I go into any kind of invasive therapy, I need to do urodynamics. Very important. So any woman, before I do invasive therapy, after conservative therapy, I will do urodynamics. Also, if treatment has failed, right, there's recurrent incontinence, right? So then I would, or neurogenic incontinence or complicated incontinence, I will need to do urodynamics. Lastly, cystoscopy, right? Now, cystoscopy, I would do when there is any pain, when there's hematuria, she's bleeding, there's any fistula you're suspecting, or recurrent urinary tract infections, I would do cystoscopy. Now, as a result, and imaging, when I would do upper tract imaging, when I'm thinking of any kind of upper tract, problems, right? So, for example, she's got prolapse. Any gynec would know that when you have prolapse, there's a lot of pressure on the upper tract, because the prolapse can cause kinking of the urethra. If the urethra is kinked because of prolapse, what will happen? Urine will collect in the bladder and there'll be back pressure changes. So anywhere you're suspecting back pressure changes, right? Or you have hematuria, right? Or you have, any kind of, loin pain or kidney pain, right? Or high post-void residual, I would do upper tract imaging. Ultrasound KUV is the least thing you do. You may go to CT urogram. So I've done all of these investigations, right? So thorough history taking, then her urine analysis, right? Pelvic, I have seen post-void residual. I have done cough stress test, empty supine stress test. I've done a 3-day bladder diary. I may have done upper tract imaging. I've done all of these things, cystoscopy when required, urodynamics, maybe in mixed incontinence. Women who have got both stress incontinence, urgency incontinence. I may do urodynamics earlier. But after doing all of these things, I've come to a point where I've understood whether she's got stress incontinence or overactive bladder or both. Right? I need to understand that. Why do I need to understand that? Because if I don't understand that, I might end up doing the wrong treatment for the wrong patient. If you put a sling, do sling surgery in a patient with overactive bladder, her life will get destroyed. Similarly, if you think a stress incontinence patient, has urgency incontinence and you treat her with medication, again, it will be there'll be no cure, right? It will only worsen her condition. So it's very important to understand what kind of leaking she has. I have done this evaluation. I've come to a point where I've understood that she's got overactive bladder, right? Now, when I say overactive bladder, again, it's urgency frequency more than 8 times in 24 hours, nocturia more than once at night she's going to the bathroom. She's got incontinence with urgency that's difficult to control, but this also includes those who have urgency frequency without leaking. And she's got no bladder pathology. I've understood all of those things. Now, once I've realized this, what is the treatment of overactive bladder? So I'm going to cover that, right? Now, the treatment of overactive bladder is conservative first, right? I need the audience to, doctors in the audience to understand one very important thing. 70% of women do not require, any invasive therapy. If you do very good conservative management, they don't need anything more. And in my hands, in my clinic, we really do very strong biofeedback therapy. And that really makes a woman do very, very, very well. Both overactive bladder and stress incontinence. The first step is conservative management. Now, if that has failed, then we will go on to pharmacology. We will go on to certain procedures, right? What are the procedures? It can be either Botox or intestine, right? Now, in the first line therapy for overactive bladder, what do I have, right? I will do education because, when a woman has come to me with her diaries, right? I showed you bladder diary. When she's got a bladder diary done, I will use that to train her, right? There's so many things that are going wrong in her. For example, doctors, we tend to pee very little, right? All of us so busy and we don't have access to good toilets in our clinic sometimes. So we don't end up going to the bathroom often enough. I had a doctor coming to me from Patna, who would go to the bathroom once in 5-6 hours. And her normal voiding was at 800 ml. Right? And from a bladder diary, I came to know that she's voiding in such huge volumes. The only thing I had to do for her is to tell her, please go to the bathroom every 3 hours. Right? And just doing that, going to the bathroom every 3 hours, her amount of leaking reduced by half. Correct? I told you, right? Another woman had nocturia, right? Only at night, but not during daytime. And she had varicose veins. So I told her clearly that, don't drink any fluids after 6 p.m. Right? And maybe in the afternoon, lie down for 2 hours with leg raised on 2 pillows. So then what happens? The fluid comes back to the kidneys in the day itself. So in the night, she's not overloaded. So these small things you can do to really improve her life, right? So diary tells me a lot what I can do. Somebody is drinking too much water, I can reduce the amount of water to drink. I'm going to come to that, right? So fluid and diet management. Next important thing is fluid and diet management. I'm going to come to that a little later. Time voiding, biofeedback, and delayed voiding. I'm going to come to all of these things. So these are behavioral therapies, right? Now, what are the behavioral therapies, right? So weight loss, any woman who is BMI 30, there's evidence which says that it really leads to increased incontinence. You have to do weight loss, stop smoking, any chronic cough or urinary tract infection needs to be treated. Kegel exercises, right? Now what happens is that Kegel exercise is the first step, right? Pelvic floor muscle strengthening is the first step of treatment of overactive bladder and also stress incontinence. I'm going to cover those aspects of stress incontinence that apply even here. So first step for any women, in addition to behavioral modification, is Kegel exercises. Now, Kegel is pelvic floor muscle strengthening exercises. All gynecologists know that, you tell them to squeeze their pelvic floor. That is, you squeeze the muscles you squeeze to prevent the passage of gas, right? And you need to do 10-second hold, 10-second racks, 10 times, at least 3 times a day, right? And as many times as you can. People even advise 100 times a day, right? Wherever you're sitting, you can be doing it. But that is Kegel exercises. Now, and this should be going on for at least 3 months before it starts showing any impact, right? Diet modification. Any overactive bladder patient needs to undergo diet modification. Now, what is that? A lot of foods we eat irritate the bladder, right? And those foods need to be removed from the diet. What are those? Anything that is acidic, right? So your lemon, musambi, santra, right? Any amchur powder, anything khatta, anything acidic needs to be removed, right? Tea, coffee, bad because it contains caffeine, right? Even green tea contains caffeine. So you should have decaf tea, decaf coffee. Alcohol is very bad. Artificial sweetener. One of the worst products is artificial sweetener. It's very bad for you, right? And then any spices, Indian spices are very, very, very bad. Okay, dhania jeera powder, pepper, garam masala, mirchi, all of this has to be removed, right? And of course, alcohol. Alcohol is another very bad bladder irritant. Now, fluid intake. When you have overactive bladder, you do not drink less than 5 glasses of liquids a day. Now, what women do know when they go to the bathroom repeatedly or they're leaking, what they do, they stop drinking water. That is even worse. Because if you drink less than 5 glasses of liquids a day, what will happen? The urine become concentrated and it will irritate the bladder. So don't drink less than 5 glasses of liquid a day. But you don't need to drink more than 2 liters a day, right? Like people nowadays, natural pati, they'll go and drink 7-8 liters of fluids. That is also very bad. Do not drink more than 8 glasses of liquids a day. So, because why do you need so much of water, right? It will only, make your bladder work that much more. So between 5 to 8 glasses of liquids is what I'll tell them, right? In a day. Now, time voiding. So what is time voiding? After I made the muscles strong, so I told you that we have to do Kegel exercises, right? Now, Kegel is extremely important. You've done it for 3 months. Every day you exercise your muscles. The doctor has taught you how to do Kegel exercises. Now, over 3 months, when you have really strengthened your pelvic muscles, after that, you make the patient do time voiding. What is time voiding? Slowly, you train the bladder to hold more urine. Now, in overactive bladder patient, what is happening? They go into the bathroom repeatedly earlier and they're leaking on the way to the bathroom. But the bladder has gotten used to holding less urine. So what do? You impose a schedule on the bladder. Once you made a muscle strong, right? So what you will do, you look at the bladder diary, you'll see the smallest interval. Suppose a woman is going every half an hour. The shortest interval is half an hour. So what will you do? This particular week, you will go every half an hour. Next week, you will go every 45 minutes. The week after, you will go every 1 hour. You will actually impose a pattern on the bladder. You will impose a bladder schedule where you will train the bladder to add 15 minutes more to the interval at which she goes. And if she needs to go to the bathroom before that scheduled interval, then I have already strengthened the muscles using Kegel exercises. I'll ask her to do 5 quick contractions of the pelvis. So what happens is that she's able to suppress the urge. So time voiding is extremely important to be given to the woman after she strengthened the pelvic muscles using Kegel exercises. Now, the unfortunate thing about Kegel exercise, which I think anybody will say, Dr. Niti will also agree with me, that half of the women do not know how to do Kegel. Why? Because they cannot identify their pelvic muscles. And 25%, actually 27% literally do reverse Kegel. So when you're asking them to squeeze up, they're actually doing reverse Kegel. They're pushing. And imagine what will happen to the woman. I get women who for 2 years are doing Kegel. And when I come and examine them, do their Oxford score, their pelvic muscles are completely weak because they're not being able to identify their muscles. So what do I do in these patients? Biofeedback. So in my clinic, when a woman comes to me with overactive bladder, they will get diet chart, they will get fluid chart, they will get a proper, reinforcement and training and education based on their bladder diary, and they will get biofeedback. Even in women who have got good Oxford score, I give biofeedback. It really, really works well. Now, what is biofeedback? Biofeedback is, now when I ask the woman to squeeze her pelvic muscles, right? You can't understand, right, whether I'm squeezing properly. I'll ask Dr. Nidhi to squeeze a pelvic muscle. I won't be able to see how she's squeezing, right? Because I go to the gym and lift some dumbbell, I'll be able to see the dumbbell being lifted. But somebody's contracting pelvic floor, I cannot see. So what do? I do biofeedback. What is biofeedback? I have a probe in the vagina and I ask the patient to squeeze around it. When I ask the patient to squeeze around it, I can easily see on the computer how well she's squeezing, right? Not only will I be able to see how well she's squeezing, I can see how many times she's squeezing and how many seconds she's squeezing, right? So that I will be able to use to make her, train her how to squeeze better, and then I'll give her homework. So how it works is, in Mumbai and in Delhi, I have this whole system, right? And this is very important. 70% of my patients do not require more than biofeedback, diet and fluid modification, medication. No one, that only 30% will go on to Botox or anything else, right? So how do I do it? This is a probe which goes in the vagina, and I'm sure this is something new for the audience, but this is very important. This is a 24 electrode probe, right? This probe goes into the vagina. Like I'm seeing this like a vagina, right? When it goes in the vagina, it's going to give me a grid, and I'm seeing every muscle group in the pelvis, right? Not only am I seeing every muscle group in the pelvis, I am able to compare the muscle group with a reference group. And I'm going to be able to see how strong the pelvic muscles are. So for example, if it's white, it means it's as strong as the reference group. If it is red, it means the muscles are hypercontracted. If it is blue, it means the muscles are very weak. So I can actually assess each muscle group's strength. Then I can do exercises. You see this? So when they come to me, I will do biofeedback. I will put the probe in the vagina and I will see at rest their strength. See, this is at rest. I will see for 10 seconds, 20 seconds, how at rest what it is. Then I will ask the woman to do maximum voluntary contraction. 3 quick contractions. You see this? Quick contractions I'll ask her to do. Right now, I do these 3 quick contractions because I want to see the strength of the type 2 fibers. The type 2 fibers are quick contraction fibers, quick relaxation fibers. So I will see level 9 type 2 fiber strength. Then I will do endurance contraction, right? Why? I will ask her to squeeze for 10 seconds, relax for 10 seconds, 20 times. Why will I do that? Because even if she's able to squeeze well, she may not be able to hold a squeeze, right? So somebody might have good strength, but may be able to hold only 2 seconds. So I'll give her homework where I will add 2 seconds more. Suppose she can, in my presence, she can only squeeze 2 seconds, hold 2 seconds, relax 2 times. Then I will give her homework. I will tell her squeeze 4 seconds, hold 4 seconds, relax 4 times. 2 seconds more than she could squeeze, 2 times more than she could squeeze, right? And 3 times a day. So, and I will exercise her type 2 fibers also. And give, then in the morning, she will do the 4 second hold, 4 second relax 4 times, and then half an hour break because I want to give rest to the muscles. And then the quick contraction also I will exercise 2 second hold, 2 second relax 4 times. So like that, every week she'll come to me. And I will keep on doing biofeedback, see how the muscles have improved. Next week, maybe she's 5 seconds she can hold. Then the week after she can hold for maybe 6 seconds. So that way we will strengthen the muscle over 10 sittings. So they come for 10 sittings, 15 sittings of biofeedback weekly to our clinic. And when she's looking at the computer with me, she's able to know exactly how to squeeze, right? How well to squeeze. So I'm able to teach her how to do it better, right? Now, also, every time she comes to me, I'm able to see her average EMG. See, you see, every time, no, after she's done the 10 sittings with me, I'm able to see her average EMG, peak EMG, and I'm able to see the average EMG and peak EMG at maximum voluntary contraction and at endurance, both, and able to see how it's improved over time. I'm going to give you an example of this woman, right? This is a woman who couldn't contract at all, couldn't do Kegel. She was doing Kegel for 5 years at home, couldn't do only. And when I put her on the computer and a biofeedback I did, look at this. I was asking her to squeeze here, that she couldn't squeeze. So I trained her how to squeeze using the biofeedback tool. And I sent her home. See, next week itself, look at how well she could squeeze. You see this? Believe me, if you strengthen the pelvic muscles, it really works well. It's a first-line treatment for both stress incontinence and urgency incontinence and overactive bladder, right? Now, every woman who comes to me, I also do electrical stimulation. I will do biofeedback and then do electrical stimulation. What is electrical stimulation? It is pelvic muscle strengthening like a lazy man's Kegel. Okay, it's like what it does is when it stimulates the muscles, it is causing passive contraction of the muscles and it strengthens it, right? And because in maple, I can actually say, I told you, no, I can show you a muscle grid, right? I am seeing a muscle grid here, right? When I see the muscle grid, I can see which muscle is weak. Now this muscle is weak here, it's blue. I can actually stimulate only these muscles using maple because I can actually choose which muscles to stimulate, right? So that is why I love it, you know, that I can actually understand which muscles group to squeeze, right? So here I'm choosing to only stimulate the near muscles, right? Here I might choose to stimulate only the upper and lateral muscle. And I would use different frequencies. Both stress incontinence women and urgency incontinence women will undergo stress electrical stimulation and biofeedback, but the frequency I use differs. In urgency incontinence overactive bladder, I will only use 12 hertz, but stress incontinence, I would use 50 hertz. So it depends upon the kind of leaking she has. Now, Cochrane review clearly says first-line treatment is pelvic muscle strengthening, right? In every woman of any kind of leaking. Now, once I have about 10 minutes more, right? Yeah. Yeah.
Yes, madam, you have time.
So now, along with, so I have done diet chart. So if a woman, I have evaluated the woman, I have understood what kind of leaking she has, right? I have realized stress incontinence and overactive bladder, both of them undergo biofeedback and electrical stimulation for 12 to 15 sittings, right? If they've got overactive bladder, I'm going to give them diet chart, fluid chart, right? Another thing I will give them is medication. Okay, overactive bladder, right? Now, medication, what is the medication? And what I have found, and there's enough evidence to say that if you do physiotherapy and drug therapy together, it works better, right? So we do multimodal therapy, right? Diet and fluid chart, medication, and physiotherapy. Along with medication, one thing I really want to about is...
Madam, can I just hold for a second? You have time till 2:45, so there is time.
Yeah. Now, In the medication, so I am doing, see, when you have overactive bladder, I'm given a diet chart, fluid chart, physiotherapy, and then I'm going to give her medication also, right? So in medication, what do I give her, right? In medication, I'm going to give her local estrogens, correct? Why I give her local, especially if she's menopausal. Any menopausal woman gets local estrogen. Why? Because when you do not have estrogen in the vagina, it can make the tissue raw and cause, menopausal atrophy, and that atrophy worsens any kind of leaking. So when you menopausal women, they are going to get Evolon cream, that's local hormonal cream, and not oral therapy, where the local cream is given every night for 3 weeks, right? Daily while going to bed at night, they're going to apply vaginally for 3 weeks, followed by twice a week for life. Okay, so daily for 3 weeks, followed by twice a week for life. And then what is the other medication I will give you is anti-muscarinic. So if they've got overactive bladder, I told you already, what is overactive bladder or urgency incontinence? These are women in whom they have abnormal bladder contractions. Correct? Now, when they have abnormal bladder contractions, I will give her anti-muscarinic medication. Correct? Why will I give an anti-muscarinic medication? Because you know what anti-muscarinics do. They will make the bladder wall quieter, right? So the problem with anti-muscarinics, however, is that a lot of side effects. Right? So unfortunately, it's like this, I would like to give her a pill that contains both the treatment and the treatment for the side effects. Right? It's almost as if like it's that bad, right? But there are newer anticholinergic medications, right? So what are the newer ones? Solifenacin, trospium, darifenacin. These are the newer drugs that help you make the bladder quieter, and they're specific for the M3 receptor. Now, how do they act? Right? So they are anti-muscarinic medication. So it's very simple. What do you mean by anti-muscarinic medication? You know that for any muscle to contract, right? So if you have a bladder muscle, this is a smooth muscle. For it to contract, acetylcholine has to attach the muscarinic receptor. You see the receptor here? Now, the thing is this, is that when you give anti-muscarinic medication, it competes with acetylcholine. Right? So when it competes with acetylcholine, if the drug attaches to the receptor, the muscle will relax. It's not able to contract. Right? So it's a competitive inhibitor of acetylcholine. Right? Any anti-muscarinic medication you give. Now, how does it act? Because competitive inhibitor of acetylcholine in the storage space, see, in a woman who's got overactive bladder, whose bladder has got abnormal contractions, and you want the bladder to remain quiet, that means during the storage phase, it's not supposed to contract. So what do when you give this drug? What it does is it prevents the bladder from, the acetylcholine attaching to the receptor, and keeps the bladder quiet during the storage phase. And in the emptying phase, it doesn't act. Why? Because in the emptying phase, there's a lot of acetylcholine. So acetylcholine will not be inhibited. But in the storage phase, where there's little acetylcholine in the body, that time it will inhibit. So remember, the drug will act only during storage. It will not act during voiding. So it will not cause any retention. That's why it's a good drug. And again, repeat. The drug acts only during storage because it will compete with the little amount of acetylcholine there and prevent bladder contraction. But during emptying phase, because it's a competitive inhibitor, there's a lot of acetylcholine there. The acetylcholine will not be removed and the bladder will be able to contract well, right? So you're able to store properly and empty better, right? Now, the thing is this, when you give anti-muscarinic drugs, they can act on any of the muscarinic receptors. We know that there are M1 to M5 receptors, right? There are so many receptors in the body, right? Now, if you realize M3 is the most important one on specific to the bladder. If you do not give M3 specific drugs, what can happen? You can have drugs that can act on the brain and cause cognitive problem, heart and cause tachycardia. So, you can have, eye problems, you can have loss of visual accommodation, right? So you do not want to give non-specific anti-muscarinic drugs, right? So you want to give specific drugs. Now, another thing is, because of these issues, right, all of these problems that can happen, what are the contraindications, right? So you do not want to give anti-muscarinic medication in women who have got retention issues, dysfunctional voiding. Suppose a woman comes and says that she can't pee or she got retention, then you have to be careful. And same thing, gastric retention. It's not able to, extremely constipated, right? Because the drug itself will cause constipation. Because the drug is making the bladder quiet, it also makes the bowel quiet. So you should be not giving it in patients with gastric retention. You don't want to give it in uncontrolled narrow angle glaucoma, right? Why? Because again, it can worsen it. You can give an open, narrow angle, you cannot give. The other type of glaucoma you can give, right? And pregnancy nursing mothers. Similarly, you have to be, careful when there's any decreased GI motility or controlled narrow angle glaucoma. You have to be careful. And you have to be careful during renal insufficiency and hepatic impairment. Now, what are the drugs? See, if we have to give specific drugs, right? So solifenacin is one of the first drugs. It's a very nice drug. It's M3 receptor specific, so it causes less side effects, right? So highly selective for the bladder, but it will still cause a little bit of dry eyes and dry mouth, okay, and constipation, but not as much as the non-specific drugs. So you may be seeing a lot of gynecologists giving, or doctors giving, the older drugs like oxybutynin. Please don't give it anymore. You should be giving solifenacin, right? Because they're specific for the M3 receptors, right? And the good thing is got a long half-life, 48 hours or so. You can use it once a day, right? It's normally given 5 to 10 milligram once daily. So what you do is you start off with a lower dose. It takes 3 weeks to act. If it doesn't act, then you can give 10 milligrams more, right? And main side effects, I mean, you can go on to 10 milligrams if the 5 milligram dose does not act, right? Once a day. Main side effect I told you already is constipation, dry mouth. Now, there are other drugs also. So if solifenacin, what happens is this: you've given solifenacin, it's not working that well, you can actually shift to another drug called darifenacin. Some women will do well with only solifenacin. Some women will do actually not well with solifenacin. You may have to give darifenacin. So it's not that if they're not active, one antimuscarinic will not work, the other will not work. You find patients in whom solifenacin is not working, darifenacin is working. Another patient, darifenacin will not work, solifenacin will work. So you should find out which drug works in them. So you give 5 milligrams of solifenacin, does not work, make it 10 milligram, does not work. You might change to darifenacin. And darifenacin is another tertiary amine, which is again M3 specific, right? It's again specific with the bladder, so causes lesser side effects. And again, you start off with 7.5 milligram dose, and you can increase it to 15 milligram once a day. Now, in older women, I will give something called as trospium. Why? Because trospium does not cross the blood-brain barrier. Very importantly, okay? If a drug crosses the blood-brain barrier, antimuscarinic, it can cause cognitive problems. In an old woman, you don't want that. And trospium is different from the other drug because quaternary amine, not metabolized by the liver and doesn't go across the blood-brain barrier. So in older women, I will give trospium, 20 milligram twice a day, or extended release 60 milligram once a day. Very important, right? So as I said, solifenacin or darifenacin, start with the lower dose, go to the higher dose. If the solid dose doesn't work, if one drug does not act, go to the other drug, right? And in older women, give trospium, right? Now, the problem with oral anti-muscarinic medication is that it's very difficult. Even when you give selective drugs, the persistence is poor, very bad. Because what happens is, when you'll notice this, if you send to urologists, they will give you this medication, but they'll come back 6 months, 3 months later. And most of them have stopped these drugs, right? Because it's very difficult to take these drugs, antimuscarinic medication, so many side effects. So there is another drug that's come in called beta-3 agonist. Now, one thing I tell you before I go to beta-3 agonist is, in my practice, because I do biofeedback and they come to me weekly, right? It's very important. See, you can't, women with overactive bladder, you have to give them time, right? You cannot, give them a medication, tell them come back 3 months later, because they're not going to be persistent. So what we do is that we really counsel them properly. And because they come into you with for biofeedback weekly for 12 sittings for 3 months, each sitting when they come, you're asking them whether they're taking the medication properly, solving any issues. If they've got constipation, we'll give them isabgol or some other medication. If they've got dry eyes, dry mouth, we might, titrate the medication, change the medication. So they are really persistent with us. If you just give them medication, tell them go back home, they're definitely going to stop taking the medication. But there are new drugs also that's come into the market called beta-3 agonist. Now, if you want some muscle to relax, what do? Either you prevent contraction, so the anti-muscarinic drugs prevent contraction, or what you will do is support relaxation, right? You will support the beta-3 agonist drug. What do? They support the relaxation pathway. So you have the adenyl cyclase pathway. I don't want to go into the biochemistry of it, but the adenyl cyclase pathway in the body supports relaxation of muscle. So beta-3 agonist supports this, right? So this is called mirabegron, right? So it will act on this particular pathway and support relaxation. Now, you start off with 25 milligram and you can increase to 50 milligram, but generally you need 50 milligram dose. Also, it takes time to act. Like I told you, even with anti-muscarinic medication, you have to wait for some time, 3 to 6 weeks. Even with beta-3 agonist called mirabegron, you have to wait for at least 8 weeks to say it's not working. The good thing is that in mild to moderate renal impairment or hepatic impairment, you can still use it. Okay, the dose, maybe you give lower dose, but you can still use it in mild or mild hepatic or renal impairment. Now, And I mean, I won't go into the details of these studies, but the studies have clearly shown that they are comparable to antimuscarinic drugs, and the persistence is better because they do not cause so many side effects. But the one thing that you cannot give is long-term surveillance has shown this, is that it works long-term. The problem, however, is that in women who have got hypertension, just this one thing, the adverse drug reaction, right? Who it is seen in? It is seen in women with hypertension. So the only place you cannot give mirabegron, beta-3 agonist, is women with uncontrolled hypertension. Uncontrolled hypertension, mirabegron is not good. Beta-3 agonist is not good. Controlled hypertension you can give. Please understand again. So controlled hypertension, you can give beta-3 agonist. Uncontrolled hypertension, it worsens it. Remember that. Okay. Another very important thing you must remember, I told you solifenacin or antimuscarinic drugs acts more often during when it's contracting abnormally, and during emptying it works well. It doesn't work and allows the bladder to empty. Similarly with mirabegron, it will only act during the storage phase, and during emptying of the bladder, it doesn't interfere. So both the drugs will not cause that much retention issues, right? Now, again, I told you, right, because mirabegron does not have that many side effects other than those women with hypertension, it has got higher 6-month persistent rate as opposed to antimuscarinic medication. So what do we do? Remember this simple thing. In short, medication, you will give solifenacin or darafenacin. You can start off with either drug. You'll give low dose, go to the higher dose if the low dose is not enough. Change the drug, either solifenacin, you can switch from solifenacin to darafenacin or darafenacin to solifenacin if either the drug doesn't work. If your higher dose not working or not enough, you will add mirabegron to it. So you can give both mirabegron and solifenacin, right? So together, I have patients on 10 milligrams solifenacin and mirabegron. So now, you've come to a point where conservative treatment is not working, right? So, and I'm now, in my practice, conservative treatment works in 70 to 80% of women because I do hardcore biofeedback. So diet chart, fluid chart, medication, biofeedback. Most women will do well, right? If at this point, right, and they're still not better, then you will have to go into invasive therapies, right? So like, I mean, every road leads to a bathroom for these women, right? So what do you do? What are the invasive therapies? Now, invasive therapies, I'm going to cover in very short, just to give you an idea of what these invasive therapies are, right? At this point, I will do urodynamics, right? I've treated her conservatively, it's not working. I will do urodynamics. Now, what is urodynamics, right? So I told you what it is already, so I'm not going to cover it. It's basically lab investigation of how the bladder functions. Now, I've done urodynamics, I've confirmed it is overactive bladder. The next step is something called as PTNS. I'm going to give you just snapshots of this. I'm not going to cover it in too much detail. Now, I told you already, overactive bladder is a bladder which is not listening to the brain, right? It is not, normally what happens is that when you're feeling the need to go, your brain is going to tell the bladder, keep quiet. And your bladder normally will keep quiet and not listen to the brain, However, in women with overactive bladder, the bladder is not listening to the brain, right? That means what? That the nerve from the bladder is not functioning properly. It's giving abnormal signals to the brain. So a lot of therapies have come around nerve stimulation, right? So if the nerve is not functioning well, the nerve is communicating from the bladder badly to the brain. What do? I will do neuromodulation, right? Now, if I have to do neuromodulation, what do? I have to do neuromodulation of the nerve that's supplying the bladder, correct? Now, there are various ways of doing it, right? So there's a peripheral kind of neuromodulation. What is a peripheral type of neuromodulation? I have got, there is a tibial nerve, right? I have got this is tibial nerve. Tibial nerve, you know that it comes along the medial malleolus, right? And tibial nerve is a branch of the sciatic nerve. And the sciatic nerve is a branch of the S3 root. And S3 root supplies the bladder. So the theory goes that if I do neuromodulation of the tibial nerve, I'll be able to prevent the abnormal communication of bladder to the brain, because when I do neuromodulation here, it will go and interfere with the functioning of the S3 nerve root, right? So this is percutaneous sacral nerve stimulation, right? So basically PTNS is a percutaneous tibial nerve stimulation. Okay, from the tibial nerve, I'm going to the sacral nerve root. Okay, this is PTNS. PTNS has, in China, they do acupuncture. It's like an acupuncture needle, See, this is like an acupuncture needle that you put it just behind a medial malleolus. Okay. Now, this is okay. It helps, when 60% of women might respond to it, but over time, there's decreased effectiveness. Okay, so that is one therapy, PTNS. You can try it before you do Botox. Now the next procedure is Botox, right? Now we know what Botox does, right? Botox is a drug that prevents the acetylcholine from releasing. All of us know that, right? So you can inject Botox directly into the bladder, right? And Botox is indicated in only those women who have got leaking. Botox is not going to act in women who have got repeated need to go to the bathroom. It only acts in those women who have got urgency incontinence associated with leaking. Why? Because it acts only in the motor phase, right? When the bladder is contracting. So how do you do Botox injection? You inject. So basically what happens is you inject into the bladder, generally distributed around the bladder, and you avoid the dome, right? Because you don't want to inject into the peritoneal cavity, right? So this is it. Like, I'm not going to go into details. You have around 0.5 ml of Botox injected through cystoscopy or around the bladder. Around 20 injections are given in the bladder, okay, using Botox. Now, and overall, you only use 10 units of Botox, 100 units of Botox, sorry. So what happens is that you have different doses, right? If you have overactive bladder, which is idiopathic, you will give 100 units. If you got neurogenic overactive bladder, you will give 200 units, right?
Madam, 5 minutes more.
Yeah, I'm last two slides now. Last two slides only, right? So I will give 100 units of Botox for the idiopathic, that's overactive bladder, which got no pathology. If the woman has got neurogenic problem, I can use 200 units of Botox, right? And the only thing about Botox is that it only acts for 4 to 6 months. You see that? If I give 100 units act for 4 to 6 months, 201 in neurogenic will act for 10 to 12 months, right? That's the thing about Botox, that you have to keep on repeating injection, right? After 6 months, you have to repeat, 6 to 9 months, you have to repeat the injection, right? Also, one very important thing about Botox is that it can cause UTI, urinary tract infection. Why? Because when you inject Botox into the bladder, it can retain urine, right? Remember that if I inject Botox in the bladder will not contract. If the bladder is not contracting, it can retain urine and become a cultured medium. So the women who have undergone Botox can have retention issues and they can increase chance of infection, right? That's very important to understand. And I'm not going to go through these papers, but all of them show that they long term, the effect is very, very, very good, right? The only thing is that you have to tell the woman who are undergoing Botox that they may have a little bit of retention issues for 6 weeks after Botox. So I may have to do catheterization of these women. So if they have retention issues after Botox, you may have to catheterize the patient, like intermittent catheterization has to be done. But normally what happens is if they retain urine, over time they get better. Lastly, I'm again now going to go into this. I used to do this in Cleveland Clinic when I was a student there, a fellowship, when I did my fellowship there. Now, last thing is sacral neuromodulation. It is very expensive. It costs around 5 to 7 lakhs. I've got only a couple of patients in whom in India, done it. But in the US, we used to do it very regularly. Now, I told you already about neuromodulation, right? You want to interfere with the functioning of the bladder in the brain. In peripheral tibial nerve stimulation, you are interfering with the tibial nerve. In sacral neuromodulation, what you do, you go directly on the spine. What you are actually putting a lead along the spine, S3 nerve, and it interferes with crosstalk of the S3 nerve with the spinal cord, right? And it helps you in overactive bladder, right? So basically what happens is you have you see this, there's a lead going inside, right? It's going to the back along the S3 nerve. So you will do a test phase. So how does it work, right? There's a 2-step procedure. You do a test phase, you put a, impermanent lead, temporary lead, you see for 7 days it's working. If it's working, then you will go into a permanent lead and you attach a battery. So what will happen is the woman will have a battery, and through the battery, you're going to do stimulation of the nerve continuously. It works for 5 years, the battery, right? So the way it works is that you have this temporary lead, you're going to put it in the OT, temporary lead around this S3 nerve. Then for 7 days after that, you're going to see if there is improvement. If there's 50% improvement, you will go in and put a permanent lead along the S3 nerve. And you'll have a permanent battery. It's called a programmer. And the woman can program it and keep on stimulating the S3 nerve. And it causes improvement in the patient's overactive bladder condition, leaking, right? It's called interstitial. So this is how it lies, so you see this in the spine, there's a lead rise in the spine like this, and it helps, right? And it clearly that both Botox, now this is basically showing that sacral neuromodulation works very well. It's a long-term study, and this is a study where they compared Botox with sacral neuromodulation, and both are equivalent. Now, very important thing, Botox only works in patients in whom there is actual leaking. Sacral neuromodulation will work in patients in whom they need to go to the bathroom also repeatedly without leaking. So it works in patients with leaking and patients who don't leak but need to go to the bathroom repeatedly, right? This is the treatment of overactive bladder, right? This is the algorithm. I told you everything, right? Initial screening, bladder diary, urine analysis, post-fight residual assessment, then you are going to do all the conservative management, you're going to do medication, you're going to do physiotherapy, biofeedback, diet and food modification, time voiding. Most women will only require this much. If it does not work, you can go to sacral neuromodulation, which can be tibial nerve, or it can be the direct spinal one, or you can do Botox, right? This is therapy for overactive bladder. Thank you.
Thank you, Dr. Aparna. That was really really lucid and extensive presentation. I think we are starting from the reverse order of the treatment, which should be avoided as a gynecologist. That is the most important take-home message. You have to spend more time in counseling of the patient and learn ourselves as a gynecologist and obstetrician when to consult with a urogynecologist. So I think that will be a really great message. And thank you, Dr. Aparna. Because we are short of time, we just cannot take question answer session. We like to have personal contact with you, anyone who wants to have the questions. And thank you very much. And over to you, Dr. Vijay Lakshmi Shinde.
Thank you so much, madam, with such an informative talk on Dribble the Trouble. And incontinence is indeed an important issue to be handled. Many times it gets ignored. The patient knows the pain, what is he is going through. I request Digishil to show the slides. IMA Dombivli would like to felicitate speaker Dr. Aparna Hegde with this e-memento. Also, I would request next slide, please. E-memento for our moderator, Dr. Niti Upasne. Thank you, both of you. Good day to you. Now we proceed to the next session. Thank you, Alembic Pharmaceuticals, OABF division.
Thank you.
And now we proceed to the next session. Good afternoon, everyone. The next session, an important session, familial cancers. Cancers have been not very new to us. We all know much about the cancers. Indeed, still short of the information we have. Generation to generation, there is carry forward of some genes, the familial genes, which change over time and pass on to generations to form cancers. I may not know the complete information on the familial cancers, but we have our next speaker, Dr. Pritam Kalaskar, who will speak on this topic. I request our moderator for this session, Dr. Bhakti Lote. Dr. Bhakti Lote, Madam is MBBS, Senior Family Physician at Regency Healthcare Clinic in Dombivli East. She is the Organizing Secretary of IMAFEST and Navrang 2020, Chairperson of the Mission Pink Health Committee of IMA Dombivli, and she is the President-elect of IMA Dombivli 2021 and 22. I request Dr. Bhakti Lote to take forward the session.
Good afternoon, everyone. Today, our lecture is familial malignancies. Malignancy itself is one of the most feared and dreaded diseases. It is a major cause of death all over the world. More than 1 million Indians suffer from cancer. Large number of them die from it annually. There are certain types of cancers that seem to run in families. There might be causes like exposure to risk factors like smoking, obesity, sometimes abnormal genes, etc. We are fortunate to have Dr. Pritam Kalaskar to teach us about these familial malignancies today. Dr. Pritam Kalaskar is cancer specialist from Thane. He has done his MBBS from Government Medical College, MUHS. He has done MD and DM, MD in internal medicine and medical DM in medical oncology. He has gone through rigorous training in field of medical oncology over last 10 years. His academic glories include MBBS first rank in state, first rank in internal medicine, gold medal in medical oncology. He had super specialization in treating breast, ovary, lung, colon, hepatopancreatic biliary, lymphoma, multiple myeloma, head and neck cancer, and bone cancers. He is director of Mumbai Onco Center. It is unique chain of cancer hospitals in state-of-art facilities for administration of cancer medicine. Over to you, Dr. Kalas.
Good afternoon, all. Thank you, madam, for the kind introduction. Can I share my slides?
Yes, you can share. Yes, sir. Yes, you can share.
So, good afternoon, all. And first of all, Sunday afternoon, I'll be speaking on cancer, that too on familial cancers, breast cancers, post-lunch session. So, I would keep it very crisp. But apart from the routine treatment, what we do in oncology, something which is coming up lately and very, very important is the genetic linkage of malignancies. Per se, in our country, there is a lot of ignorance, or I would say they tend to avoid when we ask them about getting genetic testings done. Even after emphasizing the importance of the need for it, there has been a lot of reluctance and ignorance, I would say, from the patient's point of view when we push them for this testings. I would be emphasizing why it is important and how it is changing the lives of patients, even those who have not been diagnosed, the patient's relatives, their family members. Also, before 2-3 years, the genetic testing was more so confined to only diagnosing the mutation and estimating the risk of getting these malignancies in the family. But with recent times, there has been evolution to use of drugs also on this specific mutation. So not only it only helps in identifying the mutation, but also it might help the patient himself or herself for a treatment modality which can be used to target this mutation. And we have seen some BRCA mutated prostate CAs or triple negative breast cancers who are lost with all options of therapy, and after they've been offered this therapy, the responses have been dramatic. So with that background, I'll move to my presentation today, which will more focus on familial breast cancer and some amount of ovarian cancer. So this sea of change in terms of genetic counseling and mutation analysis started from around 2030, when we all know Angelina Jolie posted her story in the New York Times about her aunt being diagnosed with breast cancer, and she was detected with BRCA1 mutation, and then she underwent a prophylactic mastectomy. So if you can see, after the publishing of article, the percentage of testing of this mutation went to almost 40% more in US. And that effect has started occurring in India in last few years. People have started doing those mutations, and this effect is known as Jolie effect. We all know that. How the presentation is going to be, I would just outline the four topics I have divided. I'll first just discuss what is sporadic versus familial, then what is hereditary breast cancer, what can we offer to this hereditary mutated or their family members, and lastly we'll discuss 3 cases of families with breast cancer, ovarian cancer, and prostate cancers. So as we all know, for the occurrence of malignancy, there have to be a mutation. So these mutations which occur are called as sporadic mutations in most of the cases, because not all of them are heredited from one person to other. If in total I take breast cancer, out of the 100, 80% of them are sporadic gene mutations, 20% are familial or inherited. So all of the cancers will definitely have a mutation to occur. There has to be a trigger for the body to go into carcinogenesis, and this trigger can or cannot be familial or inherited. And majority of the time, it is sporadic. Rest of the 20%, 80% sporadic, rest of the 20% when we calculate, this can be either familial or inherited. So what is the difference between familial and inherited? Sounds very similar when you say it is familial. This cancer is familial in this family. From one generation to another generation, it is passed on. And even when you say hereditary, it also sounds same. But the term familial is used when you say there are cases in this family, but we don't have the exact reason known, or science has not reached to identify that particular mutation, that particular gene which is causing malignancy in that family. So this can be an undiagnosed gene mutation or some factor to run that cancer in that family. Whereas when it comes to hereditary are, they run in family, and on analysis we know that these are the specific mutation, or this patient fits into this syndrome, or this patient has this gene mutation, maybe BRCA1 or BRCA2 mutation. So we can tell that this is inherited. So the only difference is in familial we don't know yet what gene was causing it. In inherited we actually know what gene or what syndrome the patient fits into. A small diagram to suggest the same. All the cancers are mutated, but 80% sporadic, less 20% are familial or hereditary. Why we say even after we have been knowing the genome since 2002, why we still say that in familial cancer we still don't know few of the mutations, or the few of the genes are yet to be identified. So if you see, the known BRCA1 and BRCA2 mutations presently are more than 2,600. So these many have been discovered, and there are so many duplications or deletions which humans are yet to know. So it is an evolving thing, and till date we have reached to more than 2,600 of these mutations. These are concentrated on two chromosomes. BRCA1 is on chromosome 17 and BRCA2 is on chromosome 13. The specific way of inheritance of this mutation is autosomal dominant pattern. What is autosomal dominant? I'll just show you in the next few slides. A picture showing the locations of these two genes. These two genes, as we go through the presentation, we'll understand they are related to the maximum number of malignancies or the proportion of malignancies we are facing today. How we test them? So the first thing what we do is, when we have a suspected patient, we do a BRCA1 and BRCA2 sequencing. Most 96% times, if the patient is mutated for any of these 2,600 mutation, these are detected in this sequencing part. Suppose the patient turns out to be negative, and I as a clinician feel there is a strong family history. There is a strong family history for this patient, or the patient herself has bilateral breast cancer, or it is a male breast cancer, and still if I'm not finding a BRCA mutation, then we proceed to another level of testing in that 4% of cases, which is called as MLPA, which is a multiplex ligation dependent probe amplification. So there are certain BRCA1 and BRCA2 mutations which are not picked up by the routine sequencing which is done. And when we have a strong inclination or strong suspicion there is a mutation, the MLPA helps us in labeling those cases. So by this complete approach, I would say more than 99% of the times you will find the specific mutation. At least 1 or 2% cases you might not find it, but 98 to 99% you will be bang on and finding these mutations. Autosomal dominant, we have all read during our UG days, the dominance, autosomal dominant, when it is completely dominating, you will find that it passes on to at least 50% of the siblings from the parents if one parent is affected, and it shows up in most of them. Another inheritance pattern. One thing is that if even at all, if it is autosomal dominant, not always it will be expressed. It can be silenced in or suppressed in one generation. That is something which we have to understand when we take the family history. Sometimes we get a bilateral CA breast and there is no family history in the first generation of relatives. When we dig into the history, we can find there is somebody in the second generation or in the third generation who had such kind of disease. So yes, even though it is autosomal dominant, sometimes it might remain silent, and it is not necessary that if the gene is passed, 100% of the patient of the carriers will have the malignancy. So that some generations might miss it, that doesn't mean that we don't test when we have a suspicion. This is a typical example for this kind of second example which I said, where there in the first generation there is no malignancy seen, but if you see the second generation is having breast cancer at 55. So even though autosomal dominant disease, if people say there is no malignancy in the family, neither of my sisters have it, but when you inquire, you will find an aunt or somebody in the family in the second generation might be having the disease. So a complete family tree is mandatory when you inquire about family history in terms of breast and ovarian cancers. This is another typical example where the patient is around 32 years old female with bilateral breast cancer. So bilateral breast cancer, which at such early age has to be BRCA mutated. It is one of the commonest presentation to have such early bilateral breast cancer. And if you see, even in the first generation or the second generation, there is nobody with mutation. So if there is no family history, but such typical presentation, still we advise BRCA mutation. I will go into the further details about whom to advise and whom to not, the BRCA analysis. This was just to highlight that the gene might remain silent for first or second degree relatives, but with typical presentation, we should not hesitate in referring the patient for genetic counseling. Typical presentations can be a bilateral CA breast, a male breast cancer, an ovarian cancer. These are typical presentations for BRCA mutations. That details I'll go into the further slides. Why are we discussing such details about these two mutations when there are such area of cancers available? So if you see, the amount of risk increased if the patient is mutated with BRCA1 or BRCA2. If for breast cancer, it is hardly 12% in general population, but if the patient is BRCA mutated, you can see as the age increases, from 46% onwards, it goes up till 87% to get breast cancers. This is up till 75 years of age. Similarly, for BRCA2 mutated, it increases from 38 to 84%. So if somebody is carrying this mutation and he or she survives for 70 plus years, it is 80% chance that that lady or male patient might get a breast cancer at that age. So such high linkage is there between these mutations when it comes to breast cancer. Also, somebody who has already got a breast cancer, if it is BRCA mutated, even if it is cured, in next 10 years, if you see it is BRCA1, there is 20% chance of getting a second primary, and also 10% chance in next year to get a second primary in BRCA2. For ovarian cancers, in general, the general population has only risk of 2%. Out of 100, only 2% patient might get ovarian cancers over the age of 70 years. But if the family is BRCA mutated and the patient also is BRCA mutated, the risk becomes like 40 to 63% in BRCA1, and in BRCA2 it is up to 30%. So if you can see, the risk actually multiplies into 20-fold times, 20 to 30-fold times in BRCA1, and almost 10 to 15% times in BRCA2. That is the importance of these mutations in this very, very common cancers that we are seeing. Today, breast cancer is almost the second leading in our country, and ovary is also one of the commonest malignancy to be found. Then we go on to some cancers which we are not aware that these are BRCA mutated. So when we say breast and ovary, we all know this can be mutated, but there are malignancies like male breast cancer. So male breast cancer, if even a single patient in the family, that is an indicator of BRCA mutation in the family. So if you find any relative whose relative is a male breast cancer, the whole family has to be screened, genetic counseled, because they are possibly harboring a BRCA2 mutation, because the occurrence of male breast cancer as such is only 0.1% in the community. We hardly see any male breast cancer in a general practice, but if we get a male breast cancer patient, then BRCA2 mutation has to be done in these cases, and the family has to undergo a genetic counseling. Something which is lately been very much encouraged in testing is the prostate cancer. So all the cases of prostate cancers, we are now testing them for BRCA mutation, because we have a drug in that. And also, if you see they are BRCA mutated, then the family members are 10% more to get it. Maybe the children of that patient are 10% more to get BRCA prostate cancers. So we advise screening for them from 50 years onward. So breast, ovary, male breast, prostate, and lately pancreatic cancer is also been diagnosed to have BRCA mutation, and that has been done for familial history, as well as in pancreas also we use a targeted drug called as olaparib, which can be used in metastatic CA pancreas. So not only limited to these two malignancies, BRCA mutation goes long to at least 4 or 5 malignancies in current practice. Now the question comes, you must be seeing a lot of relatives of breast cancer patient or ovarian cancer patients coming to your clinics, and they do meet their oncologist, discuss the treatment, but one question always lingers their mind is, what is the risk for the other family members? Take an example of a lady, a 65 years old lady, her son or a daughter would definitely inquire after completion of her treatment, is there any risk to the family of getting this breast or ovarian cancer when they cross certain age? So that is the reason we have found out who to be tested in the family and which cancer patient's family to be tested. Like suppose if you find a relative or a patient's relative with multiple cases of breast and ovarian cancer in the family, then they have to be investigated. These cases can be their first degree relatives, their second degree relatives, or even if you find an early breast cancer in their family, then they have to be investigated. So multiple cases or an early age of diagnosis less than 50. Even there is a single case of less than 35 years of breast cancer, still it has to be investigated on genetic counseling basis for mutation analysis, or there is a single member in the family with both cancers, breast and ovary, in a single patient, then also it indicates that it is possibly mutated. So multiple members in the family, less than 50, a single member with less than 35, a single member with both breast and ovary, we have to investigate further for genetic counseling. When I talk about doing this genetic counseling, what are the benefits? Why are we pushing for it? So as we know the importance of this gene, like percentage chance that the family members will get this malignancy if they are mutated, can something be done so that they are protected from that malignancy? Suppose they are going to get 86% chance of getting a breast cancer by 75. Is there any way an oncologist can help them, or we can guide them to reduce this chance of getting these malignancies? Yes. So there are measures. We can divide those measures into prophylactic measures or risk reducing measures. So if the family is having BRCA mutation, then the individuals who are mutated, they can have some prophylactic measures to reduce the risk. This can be an active lifestyle, reduce dietary fat content, avoid obesity. The benchmark for an healthy lifestyle to prevent cancer is keeping the BMI between 23 to 25, aerobic exercises, reduce alcohol consumption. These are some risk reducing measures that those can be done for even for everybody. But yes, those who are mutated, they can rigorously go through this, and this can benefit them in reducing the risk of getting the malignancy. However, when we talk about this, these are general measures and the evidence for that is not very, very strong. So what has a strong evidence is when we say risk reducing surgery. As when I started my presentation, I put up a slide of Angelina Jolie where she had undergone a surgery of simple mastectomy. That is the one type of risk reducing surgery. By doing this, the patients, I would say the individuals who are mutated, they reduce the risk of breast cancer, not altogether, but definitely around 90 to 95% of cases, they reduce the risk of getting it. And rest 5% to 6% resides with them because it can turn up in axilla, but at least that percentage of risk reduction occurs. So simple mastectomy is for breast cancer, which can be practiced, even though it is a very, very difficult task to convince a lady for this. But yes, somebody who has completed their family, 45 plus, understands the implications of cancer and is willing to undergo a reconstruction surgery, they usually understand and sometimes opt for this. Definitely, it is not the only way to go. It all depends on the mental state and understanding of the subject of the patient or the individual. Some opt for surgery, others opt for surveillance. So one surgery is simple mastectomy, other is an salpingo-oophorectomy to avoid the risk of ovarian cancer. So by just after completion of family or attending the menopause, they can go ahead with removing this. After complete genetic counseling and have a counseling session with the surgeon or the treating doctor, if they are comfortable, they can go for this. If most of the patients we find are not comfortable with removing the ovaries or the breast, more so in the breast, ovaries they usually may go after menopause. Then what is there to offer? Is surgery the only solution? I would say no. There are other ways of reducing the risk or achieving the target of picking up the cancer early and reducing the morbidity and mortality to the individual. These are called screening protocols. These are not surgical techniques, but these are screenings which are advised for BRCA1 and BRCA2 mutated individual patients. We advise monthly breast breast examination and annual mammography, which starts at age of 30. If affordability is not an issue, an MRI of the breast would be ideal around 30, because MRI usually has a higher sensitivity at a younger age. So this way we can do breast surveillance for BRCA1 and BRCA2 mutated patients. Also, when it comes to ovarian cancer surveillance, we can advise them transvaginal ultrasound CA125 every 6 monthly from age of 30 to 35 years. And at the recognition of any symptoms, they have to get in touch with the doctor. So one is the surgical part, other one is the surveillance part. And apart from this, there was lifestyle modification. So these three options are given to the patient. Lifestyle modification is that everybody has to follow. But out of the surgical part and the surveillance part, after taking consideration of the risk and their understanding, they take a call and they opt for either of it. Because the surveillance requires a lot of compliance from the patient or the individual point of view for timely imaging, and also the cost involved has to be taken into consideration. Third thing is the anxiety associated with it. Whenever we advise this mutation testing, not only the individuals whom you are going to test, but their siblings who are at a younger age, they are also affected significantly. So for example, you take a family who has two children, one girl, one daughter and one son. Daughter is suppose 18 years of age, applying for a 12th exams. Mother has been detected by CA ovary at the age of 50, and the doctor oncologist gets an BRCA mutation done for the lady just for the purpose of treating her also, because olaparib is available for ovarian cancer. Suppose she gets positive, detected positive, the psychological effect of this mutation being detected impacts the whole family as altogether. There has been episodes of depression in young child, because childrens, they are now exposed to the internet and they understand the implications of BRCA mutation. So before advising this test to anybody, we usually offer them a complete genetic counseling so that they understand the implications of this test, how long, how the way it can impact the family, and how long we really don't understand, because carrying a BRCA mutation for rest of the life is a very, very huge burden for somebody who's just 18 years of age. So these many things have to be thought before going for this test, and once the family agrees, they go ahead and then further things are taken care. So this was regarding mutation analysis. Then if they are mutated, what techniques and how we can help them in reducing the chance of getting the cancer. Now let us just go through three short examples of families which had this mutation and cancers, and then when we advise and whom we advise BRCA mutation in three cases. So I will be presenting three short cases who had cancers, and whether they require genetic counseling or not, we will understand. This is a slightly complicated chart, but you have to only look at the pink part of it, which is what is called as high risk for hereditary breast cancer, what is called as moderate risk of hereditary breast cancer, what is called as low risk or hereditary breast cancer. These are the three segments of that pink chart. Out of this, the high risk, if you see, it is the same as the one discussed before. So you can remember it in this way. 3 relatives on said side of family with breast and ovarian malignancy, any age. Start with 3, then 2 first degree relatives on said side of family less than 50. So 3, no age bar, 2, it is less than 50. And when you talk about only 1, so 3 to 1, 1 can be a early breast cancer less than 35, can be a both breast cancer, single patient with both breast cancer, can be a patient with breast and ovarian cancer, or can be a male breast cancer. So 3 relatives of any age in one side of family, first or second generation with breast and ovary, or 2 relatives less than 50 years of age, breast and ovary, or 1 relative less than 35, or 1 relative with male breast cancer, 1 with breast and ovary, 1 with bilateral breast. So any of these 1 criteria is sufficient for me to say this is a high risk family. So 3 to 1 is how we remember. If any of these criteria fits in, then I would say this family is at risk and they require a genetic counseling for the patient's treatment as well as for the family's future, the present family and the future siblings. Then we go to the class which is called as moderate risk. So whatever is there not in the high risk, apart from that, if you start with 2 relatives of breast cancers which are any age. In first it was less than 50, here 2 which are of any age, or one patient first or second degree relative which is more than 35. In high risk it was less than 35 for one, here it is more than 35. And in high risk for 2 patients it was less than 50, here it was more than 50. So these are the small differences. These are moderate risk. Anything which is apart from this is low risk. A small pink chart, you can take a screenshot for that, and this will really help if somebody, because lot of relatives come and ask whether we require it, whether we require genetic counseling. And as doctors, we understand that breast, ovary, or colon cancer or prostate cancer, these are genetically related. But when any kind of cancer occurs in the family, may it be head and neck cancer, which is commonly related to tobacco, not related to familial cases, still all of them have a query. My father had it, even my uncle in the native place had an tongue cancer, whether it is related familially. So be it be any cancer, this question is bound to come from the relative's point of view. So if you have certain background about breast and ovary, you can definitely guide them in terms of at least these malignancies. Let us move to our first case. So this is the patient here, and if you see in the chart, first degree relatives, there are 2 breast cancers. One is at 68, one is at 61. Then there is a colon cancer at 76. So 2 first degree relatives more than 50 years of age, where would you place them? Where would you place them? Whether they are high risk, moderate risk, or low risk. If you see it is 2, only 2 more than 50, then it comes out to be moderate risk. Then what would be my next step in terms of guiding them? So they are at moderate risk of hereditary breast cancer. I would suggest them getting an breast examination done here on self breast examination, and a mammography done yearly starting after 40, and lifestyle changes. I would not suggest them upfront for genetic counseling. This is our second case. Here we have our patient is here, first generation and ovarian cancer. A prostate cancer is first generation. Then there is a breast cancer in second generation. So here, so there are 3 cases of breast and ovarian cancer in the same family, and also a prostate cancer, and one was bilateral breast. So as I said, when you hear bilateral breast, then it has to be high risk. So this is an high risk family, and what I'll advise them, they should definitely go ahead with genetic counseling, and I would discuss with them the risk reduction techniques as well as lifestyle changes. So this family is definitely at risk of passing on the mutation or possibly harboring the mutation. And if yes, they are at a risk of passing on to the subsequent generation, and they require this counseling about lifestyle changes and risk reduction techniques. So this is the last case for the genetic counseling part today. Here is the patient. First generation, it is BRCA. This is breast cancer, and then there is a breast cancer 85, and this is a colon cancer. So where do you place it? This is a low risk case. This is a low risk case because they are related. There are only 2 cases and more than 70 years of age, one case, and one is less than 70. So this is a low risk case, and you don't require any genetic counseling here. This is possibly not related to hereditary breast cancer, very low chance of that. And I would suggest the same thing, cell breast examination and mammography beginning at 50 years of age, and lifestyle changes for these patients. So this was all about the presentation part in terms of genetic counseling, whom to be counseled. It is very much evolving, and even as a medical oncologist, I find it very difficult to find specific syndromes or genetic mutations. So there are special genetic counselors available who are expert in terms of identifying specific mutations in specific cases and to guide them. So if you suspect any patient or patient's relative or a family to harbor such kind of gene, you can definitely refer them to a genetic counselor. That will be the ideal scenario. I'll just give you an example at present which I encountered in my clinical practice. Was I had a young doctor practicing around 32 years of age. She developed an CA breast cancer. She had a lump during pregnancy. She delivered, and after delivery in a month, she identified that it was a lump and not just some thickening in her breast. Then she got it biopsied, and it was a breast cancer. After realizing that it was breast cancer, we investigated her. We got a PET done. On the PET, there was a thyroid nodule. An FNSC from the thyroid nodule was done. That turned out to be a papillary thyroid carcinoma. So this young doctor with breast cancer landed up with another malignancy of thyroid, and then she underwent surgery for both. And presently, she was on chemotherapy, and she inquired to me about whether this is somewhere genetically linked. I said, KL, I have to review the literature to identify which kind of mutation, but I asked the genetic counselor to have a look into it. When the genetic counselor saw her, she suspected it can be a Cowden syndrome. So, as a treating physician, it didn't click to me, but definitely when there are special people or special genetic counselor available, they actually pick up it in a very beautiful way. And then has been advised the hereditary panel, and possibly when we inquired and examined her, she had other symptoms, other signs suggestive of Cowden's also. So small informations from the history also give rise to very different diagnosis from the genetic counseling part. I would suggest whenever you find any kind of malignancy, more so in terms of breast, ovary, prostate, colon, at least these 4 malignancies, do inquire about the family history. And if you find any more patients in their family, or even if you find a young cancer in terms of breast, ovary, or prostate or colon in these families, you should definitely advise them to get a genetic counseling done. Because just a simple bilateral oophorectomy can prevent the patients from further getting an ovarian cancer by 90%. When we discuss about cancers, we always inquire whether there is a vaccine or whether there is a preventive measure so that people don't get cancers. But here with a simple test, you can definitely diagnose the vulnerable population, and with simple measures, if you can reduce the risk by 90%, then there is nothing like that. If I am able to save 100 out of 90 women from breast and ovarian cancer, you can imagine of the hereditary component, you can imagine the number of cases we will be able to save across the country. So my message for today will be genetic counseling, something very important apart from the treatment point of view of the patient, as well as from the prevention of the family members from getting these malignancies. With this, I end my talk. I thank IMA Dombivli for inviting me and giving me this opportunity for this presentation. It is always delightful to be on this IMA Dombivli part, and I am looking forward for the same in the coming years. Thank you. With this, I'll end my presentation.
Dr. Bhakti, unmute yourself.
Hello.
Yeah.
Thank you, sir. It was very lucid presentation. You have given very simple examples and simplified the topic for general practitioners like us. We learned that genetic counseling and screening is must in familial malignancies like breast cancers, ovarian, prostate cancers, and colon cancers. Lifestyle changes will reduce the risk of familial malignancies, like reducing the dietary fat, avoiding obesity, reducing alcohol consumption, regular exercises. This will definitely reduce the risk factors, and there are risk reducing surgeries also. So these are the advanced things which we learned today, and it was very nice to hear you, sir. Thank you, sir. Thanks a lot.
I think questions, I think we don't have any questions in the inbox. So thank you so much, Dr. Pritam Kalaskar. It's been indeed very nice. You have been a regular guest since few years, and we hope you keep coming to our conferences. Sir is very renowned and dedicated medical oncologist in Thane district. And I request the digital team would like, as IMA Dombivli team, we like to felicitate Dr. Pritam Kalaskar with our e-memento.
Thank you.
We would like to felicitate our moderator, Dr. Bhakti Lote, with an e-memento.
Thank you.
And we thank Mumbai Oncocare Centers for this very informative session on familial cancers. Thank you so much. And as we move ahead, the concluding session by Dr. Upendra Kinjavadekar, pandemic COVID, and in that the most important but not much spoken about pediatric COVID. COVID has shaken the world. Most is spoken in the guidelines in the media about many things related to the COVID virus, and guidelines speak about the treatment modalities in the adults. What is still not spoken in detail is about the pediatric manifestation, illness, and the treatment aspects. We still are in dark about the pediatric manifestations, a role of the virus in causing pediatric diseases. So let's hear more about pediatric COVID from Dr. Upendra Kinjawdekar. I would like to invite our moderator for the session, Dr. G.V. Kulkarni, sir. Digital, please slide of Dr. G.V. Kulkarni. Dr. G.V. Kulkarni, sir, from Malegaon, senior pediatrician practicing in Dombivli. He is known for his oration skills and he has developed it over years and much more and much more confident. Owner of 10-bedded Angkur Hospital and director of ACE Hospital, Specialty Children Hospital in Dombivli. His education is MBBS from Grand Medical College in 1976, MD Pediatrics and DCH from Grand Medical College in 1978. He has held various awards and positions like Dhanvantri Award in 2009, Adarsh Dombivlikar Award in 2014, past President IMA Dombivli, past President IAP. His motto in life is he will always be helpful to the poor and the needy children. Sir feel its service to be born to them and serve as a pediatrician. I request Dr. G.V. Kulkarni to take forward this session with Dr. Upendra Kinjawdekar.
Hello. Good afternoon, everyone. It gives me pleasure to introduce my very close friend, Dr. Upendra Javadekar. When I was told that we need a pediatric speaker, the first name that came to my mind is Dr. Upendra Javadekar. Upendra is a very young and dynamic pediatrician with practicing at Nehru for the last 21 years. He is an amazing speed master. Because why is amazing speed master? Because he's got a ability of presence of mind, which is unparalleled. Everyone knows about COVID because we have heard of COVID. So many seminars, so many webinars, and so many speakers about, and everyone thinks that he is a master in COVID, but that is an adult. And as you know, a child is not a mini adult. Manifestation, the different types of presentation in a child in a pediatric age group is altogether different. And there are so many gray areas as far as understanding of pediatric COVID is there. And I'm sure Dr. Upendra is going to touch all those gray areas. His speech is always full of humor, and I'm sure he'll make you laugh behind your mask. Dr. Upendra is the past president of IIP Maharashtra State in 2013, and he's going to contest for the national president in the next year. Dr. Upendra has written one book, Dr. Ek Vicharo in Marathi, and he has received a Marathi Sahitya Parishad Award for this book. Dr. Upendra, we wish you all the good luck for the president election that you're contesting the next year. And here I present to you Dr. Upendra for the management of COVID in pediatrics. Thank you. Go ahead, Upendra.
Yes, sir. Yeah, at the outset, let me thank Dr. Upasni, Dr. Kulkarni for that wonderful, lovely introduction. And this kind invitation is really a great honor to be with IMA Dombivli today on this Sunday, wonderful evening. But talking about pediatric COVID and enigma is not an easy task. More importantly, COVID itself has become really a tough nut to crack. All of us have understood that each one of us is affected, everybody directly or indirectly. Somehow or the other, we are all connected with COVID. Each one of us has directly encountered, now not at all that indirectly, either a self, a family, or a friend, somebody or the other has been affected with COVID. Some of us have lost our close, near and dear ones. Treatment guidelines were rapidly evolving from April, in fact, March to almost October, and last 1 or 2 months, it's kind of we are getting hold of it, and they are relatively stable. I have, as far as my personal humble experience of pediatric diagnosis and management of about 70 pediatric patients and at least 30 adults. So I can see some eyebrows getting raised, but mind you that this is telephonically managed because most of them, it's not extremely difficult for a mild to moderate COVID to manage, but medically I have taken care that some physician was always in the loop and somehow had to help some of them to get beds. And then being part of a COVID task force in Navi Mumbai gave me ample opportunity to interact with number of and actively get involved in management of some of the adult COVIDs also. Having said that, let me begin by paying my humble tributes to so many general practitioners and pediatricians in Maharashtra who have lost their lives, unfortunately, as COVID warriors. So this is the photograph of some pediatricians which we lost of our Indian Academy of Pediatric members till August 23. And unfortunately, the list just got a little bit extended over last 2 months, and many more have also succumbed to this illness. And somehow we pediatricians, though we see the number of pediatric patients coming to us are less, but we are falling prey to it. That is one of the mystery which many of us are not able to solve. So what I'm going to focus today is give a little bit of overview, which I've already told you, some neonatal presentations which can come to you, some pediatric presentations, what is the role of investigations exactly as of day to day, what are the treatment modalities, how does it differ from adult management, what is this MIC, PIMS, the pediatric inflammatory multisystem syndrome, the vaccine, what is the update on that, and some practice tips I think each one of us need to carry home at the end of the day when we are going to deal with COVID. Because let's remember one thing, most important thing is we have to deal with COVID for a couple of years more. Remember that. So can children get COVID-19? Yes. The first thing, get it clear that children of all ages can get COVID. Children appear to be affected less commonly than adults, but they can get COVID. In surveillance from various countries, children, typically the percentage varied from 1 to 8% of laboratory confirmed. Now, all of us know number of patients who refuse to get tested is enormous. The list is just ever expanding. And all of us have seen in practice, whenever you have told somebody to get tested, still they refuse. After a few days, they will say, Doctor Sahab, aise theek ho gaye. But then they were all probably had COVID, but then never bothered to test. But somehow, roughly in India, we have about 2% at pediatric COVID patients, we can say. And most of them were household contacts, thanks to the courageous decision by our authorities who have still kept the schools, colleges still closed. And I think now the decision of opening them up after Diwali, which I just read today morning, it's a little bit scary, but then somehow things are getting better. And as of now, in Navi Mumbai, I'm a little happy to say today that we had just 72 patients. So the figure has come to double digit. This is, I'm talking about total COVID patients, not pediatric. So somehow we are getting better. But let's wait for a while, because the second wave, which has hit badly in Europe, yesterday the headline in UK that they have stopped, some of the neighboring countries from Denmark, they've stopped coming them to UK. So countries are really getting scared now for the second wave, and hopefully we should not have it. So can children get it? Yes, I said. COVID had two elder brothers, all of us know, the SARS-1 2002-3 infections, and which affected about 7% and 2% the MERS, the Middle East Respiratory Syndrome, which is the second brother. Now, SARS-CoV-2, which is the youngest brother of these three, has the highest transmission capability, and all of us have witnessed it. It goes like a wildfire, and the number of people who are putting their masks down and are taking so casually, I'm sure this one of the closely related viruses causing SARS and MERS, this youngest kid of the block is really, as far as spread is concerned, we should be extremely careful about it. So what are the reasons why pediatric COVID is less common? Because less intense immune response to the virus than adults. So we have all seen it is the spike protein of the virus which gets attached to the ACE2 receptor of the respiratory epithelium. The moment it gains entry, it goes down into the respiratory tract, and then it causes havoc over there. But this kind of immune response is much intense. That is, I'm very fortunate that pediatric patients do not have it. The second reason being viral interference in the respiratory tract of young children of number of other organisms. all of you know that pediatric age group is one wherein number of respiratory illnesses are continuously going on around a year, and then they are competing in the respiratory tract. So somehow not allowing this COVID, in spite of it being so pathogenic, to get foothold over there. So that is one of the good reasons why we are not getting it. That means the pediatric patients. BCG and MMR vaccination. This is very interesting theory, which almost all our babies get BCG in India now. We have MMR vaccination, and those who have missed the earlier infantile MMR, we had a school campaign just a couple of years ago. Entire India, the MR vaccine was given, and somehow this is one of the reasons why pediatric COVID is much less. And I'll talk to you a little bit in detail about it when I talk about vaccines. There is a different expression. Somehow it is felt that adult expression of ACE2 receptor vis-a-vis the pediatric expression of ACE2 receptor is much different. And that's why this interaction of ACE2 and the spike protein of COVID, it's not taking place as intensely as it happens in adults. And relatively healthier blood vessels, of course, the effect of the cholesterol, the smoking, the obesity is not yet taken on the lungs and the blood vessels. So that's why it is much lesser. And we know the complications in COVID can happen only because the damage to the vascular endothelium. We have thromboembolic complications. The second way is the hyperimmune response with what we call as cytokine storm. And the third way is ARDS. So fortunately, all these three things are much less. So that's the reason why pediatric COVID is less. But can children transmit? Yes, they are the silent spreaders. In fact, we are all worried, and one of the reasons why pediatricians are affected is the intense cry. The child cries, not putting mask on face, and then it releases so much of acute viral load on the face of pediatricians, and that is one of the reasons. And even in asymptomatic children. So they had a study which was done in Massachusetts General Hospital. About randomly they selected 192 children, and they found 49 of them were positive. That was almost 1/3 of it. That was huge. And they found that they had great viral load. So the initial theory that viral interference, a minimal force of cough and milder symptoms. So probably pediatric COVID won't be transmitting it to adults, but it is not so. And they did a study. They did not only stopped over there, but then compared it with adults in ICU. Now, adult who is COVID positive in ICU, that means he's seriously ill. And amount of COVID viral he can release, and vis-a-vis compared to asymptomatic pediatric, they said that pediatric patients were releasing much more. So this is one of the reasons probably those who are in contact also do get COVID. So if not, the child himself is not so much at risk, but then he can give it to others, especially the elder at once, especially those who are immunocompromised or who have comorbidities. We should be really careful about them. So schools and college reopening, this is going to be the major factor which is going to determine this. Now we have limited knowledge. I must confess here that pediatric studies are extremely few as far as pediatric COVID is concerned. Most of the studies were done in adults, and we have all extrapolated the data to pediatric population. So because the disease is just 10 months old in the world, so we need to remain updated, all of us. Now, for example, the loss of taste and smell symptoms. None of us were aware when the first Janta curfew came or the lockdown started for about 2 months. This symptom was never talked about, and it suddenly came up, and then we have started picking them up. So similarly, now we know not only that if you start off with a COVID with a loss of taste and smell symptoms, it is a prognostically good sign, because almost all of them, those who have this symptom to start off with, recover completely. That's a wonderful thing. Remdesivir, we had not heard of it. We thought it was some political game going on, but then found to be useful over a period of time. So this is how we need to get and remain updated as far as management is concerned. So the basic aim is protect ourselves and our patients. That is what you and me as physicians can do. As far as age distribution is concerned, as I said, we have about 2 to 3% of total pediatric patients getting affected. And amongst them, there are only 2 age groups which I'm really worried about. One is from 1 month to 1 year, so infants, that is first age group. And the second is 10 to 18 years, the adolescent age group. So 34 and 22, so they more than 50 to 60% of the patients come to this category. And let's be little bit more careful if you are dealing with a pediatric COVID positive patient coming to this age group. With that, let's discuss this further with a couple of cases. The first one is a 28-year-old previous LSCS mother. She came, a woman, she came in labor to our hospital. The swab was sent. Now the practice is usually it is sent in 36th or 37th week, depending on how people are changing their practice priorities. But then it was sent. she suddenly came in labor. So report awaited, and then she had to be taken up for LSCS. Full-term baby, cried immediately. So our first job was done. But the baby unfortunately developed respiratory distress on the background that mother's COVID report was not known. So SpO2 was 90. So definitely this baby had hypoxia. So now I had three things in mind, whether I was dealing with a COVID pneumonia, congenital pneumonia, whether it was a transient tachypnea of newborn, which is a very well-known fact after especially LSCS delivery, or whether I was dealing with a congenital pneumonia. This is also another disease which can come up in pediatric, especially neonates coming with respiratory distress. So how do I deal with it? So I did a basic preliminary investigations like a CBC, CRP, blood culture, and they started on this antibiotic because the dictum in neonatology is a neonate with a respiratory distress has to be started off with antibiotics because the pneumonia is one of the most common and treatable cause. So X-ray chest was done. So this is how it was shown that there was pneumonia definitely on this child's X-ray. And by the time in 24 hours, the first two antibiotic doses had gone. Mother's RT-PCR came negative, baby gradually improved. So it was a case of congenital pneumonia. The point to remember is non-COVID causes are more likely than COVID. So this is how this baby ultimately improved and discharged. So the point to be remembered in neonatal COVID is the infants of mothers with suspected or confirmed COVID-19 should undergo COVID positive testing at around 24 hours of age. Repeat testing may be performed at 48 hours if the first test was negative. And if you're planning to do only a single test, then in between 24 to 48 hours of age, one single test is all that is what is required if the mother is COVID positive. So neonates at risk, there is definitely some vertical transmission, vaginal delivery probably more commonly associated. But the take-home message as far as neonate with COVID is concerned, more than 95% of babies, in spite of getting affected from mother, will have mild disease. Extremely reassuring to all of you, those who are dealing with newborns, and excellent prognosis. So don't worry about it. But certain precautions when you're talking about neonatal COVID is after delivery, rooming in, always keep the mother and baby together unless contraindicated. Of course, if the mother is in ICU with COVID, that's a different story altogether. Continue breastfeeding, exclusive breastfeeding for 6 months. Mother should wear, or those who are taking care should wear face mask. Hand hygiene by mother should be followed. And it's usually the 10 to 12 days. Now this has become common for all age groups, the 10 to 12 days. After 10th day, a COVID positive patient cannot infect others. Is now the final line is conclusion is drawn on this. And please give all the vaccinations. Even if this baby was positive, then BCG, oral polio and hepatitis B, and the routine 6-week vaccinations also continue. Now many stories are getting unfolded, like this study which was published, गर्भावस्थेतील बाळाला corona होण्याच्या शक्यतेवर अभ्यास. Now they are studying whether it is possible those who had contracted, mothers who had contracted COVID during their pregnancy, what kind of effect. There are a number of the case studies are still small. The final conclusions are not drawn, but then studies are being published. And somehow exceptionally you get preterm newborns with severe virus infections. Sometimes they had to be given steroids, but fortunately all of them recovered in spite of having a prolonged hospital stay. So that's reassuring. Now with that, after neonate, let's come to case 2. So now we have a 1-year-old child comes to me because mother is COVID positive. So this is relatively probably asymptomatic, but somebody is COVID positive in your house. So how do I deal with it? The first question I need to ask is, does this child have any comorbidities? One of the most important question. And second is history of contact. Now, obviously this baby had a history of contact with mother. Should we test, investigate, severity, treatment, hospitalize? So what is the treatment for an asymptomatic pediatric positive? So the question 1 was comorbidities. So which are the ones which I'm extremely worried about? Congenital heart disease, neurologic, genetic, metabolic conditions. If the baby had chronic renal disease, immunocompromised, extremely obese patients, sickle cell, type 2 diabetes. So these are the comorbidities. If they have any one of them, I'm going to take this patient to be already sick, and I'm extremely vigilant about these patients. If may require, we have to hospitalize for observation. But then these are the comorbidities one should keep in mind. So what are the symptomatology? It doesn't differ much from adults. The fever, myalgia, headache, and diarrhea. This is all, even my experience, that these are the commonest symptoms: fever, myalgia, headache, and diarrhea. Diarrhea, initially I was fooled for a couple of patients, but then turned out to be one of the symptoms of COVID also. And these cutaneous manifestations, please be on the lookout for this, a maculopapular urticarial or a vesicular rash, which can, all viral illnesses have their typical rash. And this COVID toes is an interesting finding. Red or purple bumps sometimes we come across on toes. These are with pain and redness, similar to chilblains, what we get. But then somehow these children do get better in about 2 to 3 weeks time. So you can watch for COVID toes. Whom to test, underlying conditions if it is there, because otherwise routinely testing is not recommended now. But underlying conditions, yes, you should. If there is a known exposure to a confirmed positive, yes, you should. Symptomatic child, one must. And then as far as surgery is concerned, now some of the surgeons, in fact, in our hospital also, both the surgeon and anesthetist don't make it compulsory before. So just yesterday we had a child have operated for congenital hernia, and then it was not tested. So because we felt that there was no other reason for to suspect, and we have stopped doing routine testing of every pediatric patient before surgery or before admission also. Diagnostic test, that doesn't differ much from adult, nothing. In fact, there are only 2 tests that are at our disposal. I think tomorrow the salivary test is coming. So I'm looking forward to 9th of November when the salivary test is going to come in India, probably launched by ICMR also. So right now the rapid antigen test, though it is great, 15 to 30 minutes we get the result, but sensitivity is much less. So a symptomatic child, even if it is a rapid antigen test is negative, one must confirm it with RT-PCR. So these are the only 2 standard tests that are available and at our disposal, and we must use it whenever required. How to grade severity, it again remains same, doesn't differ much from adults. So what I'm interested to know whether the child is severely or critically ill. Moderate is evidenced by only radiological or clinical evidence of pneumonia without hypoxia. The moment hypoxia sets in, we consider it as severe. So simple to categorize these patients. And if the patient has respiratory failure, shock, or severe respiratory distress, saturation is less than 90, then I call it severe. And then maybe along with signs of respiratory failure, he'll go into critical sick child. And then differences from adults, as you can see, another reassuring factor. 94% of our pediatric patients are mild compared to 81% adults. Moderate, our percentage is 5%, severe is 0.6%. So that is how adults have about 5%. So it is, everything is much less. So 94% is a huge chance that your baby child is going to be perfectly all right, even if he's a COVID positive. And maximum complications have been noticed either in less than 1 year with comorbidities or some adolescents who had complications later on, which we'll come to in a short while. So how should children be managed? Don't do anything. Document prevention, transmission, keep them at home with mother or some caregiver, especially younger children, monitor for clinical deterioration and offer supportive care. Investigations, nothing, mild, no test. Moderate to severe, the typical test that we do as same like in adults. So severe COVID, let's pause for a while and talk about it. It's extremely rare to get severe COVID. It's seen in infants with comorbidities, tachypnea, hypoxemia, admit in critical care unit, treatment as per adult protocol. The oxygen, low molecular weight, heparin, steroid, remdesivir, they all standard of care remain same as far as severe COVID. But again, reassuring fact, as I said, less than 0.6% of your patients are going to be severely COVID affected children. Case 3, this child was a 10-year-old child who was symptomatic. So no investigations, again, even at this stage. Nothing CBC, CRP, people do it right, left and center. Let's stop it. A humble plea to each one of you. Only symptomatic therapy with paracetamol and cough. No azithromycin, no doxy, no hydroxychloroquine, no favipiravir, no ivermectin in pediatric patients who are mildly sick. Monitor fever and SpO2, that's it. Investigate only if high fever and not for COVID, other causes. If this child had low grade, so that's why no investigation. If he had high grade, then I was worried about dengue, I was worried about malaria. Moderate to high, I'm worried about typhoid also. But then these are the chikungunya, so many things can come up. But mild, low grade fever, cough, body ache, nothing. But counsel for PIMS. And this is the last case, that is 10-year-old child with high grade fever. We has a typical red eye, strawberry tongue, toxic looking, but RT-PCR negative. So we had something called as a Kawasaki disease, but this child was COVID IgG antibodies positive. And this has happened after a few days when the child was completely all right. So this is how these presentations can come. This is actually a case of Kawasaki disease, but somehow this MIMSI, the multisystem inflammatory syndrome in children, or the pediatric inflammatory multisystem syndrome, or PIMS, which is called in Europe or America, please be careful. And I want to just tell you that please monitor these 2 symptoms, the nausea, vomiting, abdominal pain, and diarrhea, and the child suddenly coming in shock. So if your child right now in next couple of months, be on a watch out for these two kind of presentations. A severe iliac fossa pain, something like appendicitis. Sometimes people have done appendicectomy also. Actually turned out to be because of COVID. Then we have nausea, vomiting, diarrhea. Some coming with severe hyponatremia, renal failure, or those who have sudden shock-like thing and nothing else. And they may say that 2 weeks ago they're probably RT-PCR if it was a negative, but then do their COVID antibodies and you will find them positive. So these are the patients of called multisystem inflammatory syndrome. So again, these treatments have no role in pediatric. Please remember that. Remdesivir only in hypoxic children. Steroids, please never ever give it on OPD basis. Tocilizumab, no role in pediatric patients routinely. Convalescent plasma, it's also even adults' role, it has gone down. So last sometime on COVID vaccine, this is very exciting, which is coming up. We know that the ACE protein, with the spike protein which the COVID virus has, it goes and joins the ACE2 receptors. So somehow we want to prevent that. So there are a number of preclinical phase 1, phase 2, phase 3 and approved trials. I need not go into the details of what are these, but it suffices to tell you that preclinical studies are done on animals and only 2% of all these trials, they actually go into phase 1. Imagine the failure rate in preclinical. And at phase 2, the success rate is 20%. So as you go right side, the success of getting a good vaccine are much more. So many preclinical stages itself, it gets died down. So Sputnik V is the vaccine which Putin gave it to his daughter also. So that was one of the first one in Russia. Epivac Corona is a genetically modified vaccine that also comes from Russia. And the CanSino is a Chinese vaccine. So these are the only three which are approved. But then we have Indian, the Oxford with AstraZeneca is the one, and then Oxford is also doing the studies with Serum Institute of India. We are very excited about this vaccine. The ICMR NIV is doing with Bharat Biotech, that's a second vaccine. Sputnik is joining hands with Dr. Reddy Laboratory, that's the third one, and Zydus is also coming out with its own DNA-based vaccine. So these are the 4 Indian companies which are, in frontline, breaking news kind of things. They're making COVID vaccine. Chinese, there is an interesting thing I would just like to share. This CanSino, Wuhan, Sinovac, these are the vaccines they have used in Chinese military populations. Now China says we do not have COVID. So they are doing these phase 3 studies in Saudi Arabia, Brazil, so outside China. So in a way it is good because China studies nobody can believe. So fortunately they are doing studies somewhere else. So we would be able to believe in these studies. So something may come up from China also. And this Moderna, all of you know that the share prices just zoomed up when they released that they are also coming out with vaccine. Pfizer, J&J and GSK Sanofi, they're also coming out with their vaccines. Finally, let us remember this repurposed vaccine. Many of your patients must be coming and asking, doctor, or you may be having these thoughts in mind, why not give BCG? So many things are talked about BCG or MMR, what's the harm? So what is the status is these are repurposed. The BCG was for tuberculosis, disseminated tuberculosis prevention was the role of BCG. But when it came in 1927, Sweden did a study and they found there were so many collateral advantages of BCG. All-cause mortality went down. So what was the reason for this? And then it was substantiated by further studies in 1950s, 60s, 70s. They found that because of BCG, other illnesses going down. So what is the reason? So this is a non-specific effect to reduce morbidity and mortality due to unrelated infection. How does it happen? It's a trained innate immunity. Though long-lived, there are certain myeloid-derived suppressor cells that inhibit lung inflammation. So this BCG somehow stimulates your T cell response, which trains the innate immunity, and it can live for about a year. So whatever other organisms also you may get protective response because of trained innate immunity. How long does it last? It may be 1 year. So it's good enough. So 1 year, if I give BCG and I'm protected for a year, by that time, at least a antiviral will come or some vaccine will come. So this is just to bridge the gap, not bride, I'm sorry for the mistake there. It's bridging the gap till the vaccine or antiviral drug. Same is with MMR. So they have found the number of countries, those who are giving MMR routinely, the chances of getting severe COVID were much less. So that's why adults started asking. But to tell you honestly, right now, there is no, the WHO does not say that use BCG or MMR as the, general recommendation to inhibit or protect yourself from COVID. And now there's an interesting study which was done by BJ Medical Hospital, Pune. They have used BCG as a therapeutic vaccine. So they had 2 arms. One arm was given BCG and other arm no BCG. These are COVID positive patients. and they followed them up, and they found that really BCG was protective in some of these adults. So they were encouraging studies by use of therapeutic use of BCG. So this is an interesting finding, and which was done by BJ, so our own country's publications, and we must respect. And there's a recombinant BCG also will be coming. So it's something right now to think about it, but I cannot tell you as a general recommendation, start using or you yourself take BCG or MMR, because these are all still at trial basis and you cannot make a general recommendation. So when the vaccine comes, who will get it? Of course, we healthcare workers, elderly with comorbidity will be the second choice, then elderly, then adults, and last priority. So all other vaccines, usually our pediatric patients get the priority, but here they are least, and I'm not bothered because it's okay. The rest of the population, those who are at high risk, should get it first. And in fact, I would say that politicians should get it first, and they're going to grab it irrespective of all this. They're going to be the first, because at least people will have, they have taken and nothing is happening. So that will be a good message going down the public also, that this vaccine is really safe. So finally, some practice tips for you. So please, in a COVID patient, use only paracetamol, no to mefenamic acid or any other NSAIDs. Inhaled medications should be avoided. Try to not use nebulization. So you can give MDI with spacer if you have a child who is coming with severe wheezing and you have to use a bronchodilator. No nebulization. Provision of empiric antibiotics is not really required. Vis-a-vis the influenza, which we had, where the staphylococcal infections were common, here it is not so. Bacterial infections are not common in COVID. So please do not give every patient azithromycin, and a humble plea to restrict the use of azithromycin, which is extremely misused drug and should be reserved for multi-drug resistant typhoid fever. So no antibiotics for COVID routinely. Bacterial co-infections are infrequent. Please remember, I don't mind even if you give zinc, vitamin C, D, multivitamin, fine. Let it work as placebo, no problem. Manage your OPD timings, avoid crowd, one person at a time, one relative. Keep duration, they say 15 minutes, but let's be 10 minutes should be your maximum consultation time. Always maintain 6 feet distance. Do not remove mask, laugh, smile, sing, nothing in front of the patients. No unnecessary talks. Use smartphones. The use of smartphone has tremendously increased. If I finish and the patient has a couple of questions more, I ask them, please go out, sit in your car and call me back. I don't mind speaking for 5 minutes more, but then not in front of me. Sterilization of surface and hand wash. Please don't touch your mask every now and then. Not even drinking water, you should remove mask. If you want to drink water, you stop your patients to coming in your OPD, tell the receptionist to stop, remove it, wash your hands, have water, wash your hands, put your mask back, and then call the patients again. Let's be extremely strict about it. When examination of oropharynx is necessary, personal protective equipment must be used. In fact, initially they said don't see throat, but we have the tonsilopharyngitis is one of the most common DDs in pediatrics, so we have to see it. And practice tips, this UVC light, I have tremendous faith in this, and I'm using it since last almost 6 months, more than 6 months. So this is very good if you can see, and not very costly, and it's found to be really useful that the surface cleaning with this UVC is really great. WHO says no mask for children, in general, children less than 5 years. So this is basically on safety and children's overall capacity to handle mask. But if you feel so, if the child is wearing, you did not discourage them. So if the patient and the child is comfortable, and most of our patients are really now the new normal norm, even children have learned it. So probably they are using it, no problem. So we family doctors can help. Disruption of immunization had happened tremendously, and forget COVID, and we may get measles or chicken pox or hepatitis, and so many other illnesses can just come back. So please allow and take every vaccine. Even if the child is recovered from COVID, the moment he's symptomatically better, within a week you can give again his whatever remaining vaccines are there. Prolonged home confinement gave opportunity for better parent-child relationship, but the physical and mental health because of addiction to media had increased. So children became less physically active. They spent more time on electronic devices, ate poor quality diet. So as a family doctor, you must counsel them. And mental health stressors, you have all seen, I think all of us, we can have a separate session only on mental health stressors because of COVID and because of infection, fear, boredom, social isolation. From adults to pediatric, everybody is affected. So to conclude, I would just say pediatric COVID, it's low incidence. That's extremely reassurance, which I said about 2%, and 95% of your patients are going to have mild COVID. It's going to be of a shorter duration. In fact, now last 1 month, almost all my patients had just a single day fever and they become all right on second day. And even if a couple of patients had severe pneumonia, they had extremely good outcome. So all of us take care of this until the proper vaccine comes. Remember, the SMS vaccine is going to always work. The social distancing, mask and sanitization, and let's use it. Let's, whenever given opportunity, never talk to anybody who is not wearing a mask. Take care of ourselves, our family and our patients, and I'm sure we are going to really learn to live with this new normal very soon. Thank you very much. Sir, unmute kara, unmute.
Sir, unmute kara.
Hello, can you hear me now?
Yes, sir.
Thank you, Upendra, for covering this topic of pediatric COVID, because there are so many misconceptions about the pediatric COVID. And you have covered such a huge topic in a small time that is allotted to you, that's 30 minutes. Now, only 2-3 questions here on my behalf. That you said about so many pediatricians died because of COVID. Because initially we thought that children won't transmit the disease to the and the symptoms of pediatric COVID are less. Children are not affected. Then my pediatrician got affected so much.
Yeah, so one of the reasons which I said, that children, when they cry loudly, they release a large inoculum. So that was one of the first things, and which was taken very lightly by pediatricians themselves. Probably some of them, we also know that they were not wearing mask or something like that, you know. So little bit of a casual approach in OPD timings. That was one of the reasons. Second thing that they have found, that of course the comorbidities even in these pediatricians had. So many of them had hypertension, diabetes, were obese. So these were the factors which were responsible. But somehow amongst the medical professionals, yes, pediatricians were really greatly affected.
Yeah, and the manifestation of pediatric COVID are different, because I remember we had one case of intercession, like child passing blood in a stool, as 8-month-old child, and we thought it's an intercession. We were about to take this child for surgery, but fortunately this child went to JJ hospital, and on third day we got a phone call from JJ that this child is suffering from COVID.
Correct. So this
In
is
initial
another.
phases.
Yes, so that's why I gave you example of appendicitis, same thing, the similar presentation came. So this is again an immunological response. So immunology goes overboard and this kind of complications can happen, and you can really get misguided because of this. Yes. So one should be really careful, especially when these GI complications which are coming right now. Please, if RT-PCR was negative, still do COVID antibodies or go into details of some history. Yes, the child had some fever about a month ago or something, you will get it. So yes, you should be really careful about this.
Like in adult, they get a cytogenic storm. Do children also get it?
No. So that's a good thing. That cytogenic storm, no. But then PIMS is common. So that's why we said. So that's why this cytogenic storm, and that's why the use of tocilizumab is almost not in pediatric COVID. It was not used. But then if you get PIMS, which is again immunology goes overboard. So which happens later on. So it happens 4 to 6 weeks after your acute infection is over. And at that time, this immunological response can go so much high that then one can get complications because of this. So something like a Kawasaki presentation, which I said, and it almost always affects either of the two systems, the CVS or the GI, apart from CNS. And another important clues is hyponatremia, renal failure. So if you do routine electrolytes and you find, even now also, some complicated child comes to you, and if you find sodium less, please do, go into the details of this, and this child may be having a PIMS hidden within him. And then pro-BNP, the CRP markers, D-dimers of these patients who have, or suddenly a child comes in shock. Right now, tomorrow, if you are sitting in OPD and child comes in shock, please suspect PIMS as one of the probabilities, because these children had COVID about a month before, and in between they were all right. And there is a sudden deterioration. So high alert signal for these PIMS is extremely important for picking them in time, and then they become better. And they have only 2 treatments for them, IVIG or a methylprednisolone. So these patients do not require tocilizumab, fortunately, but then they become better if you pick them up in time.
Thank you, Upendra, for covering this pediatric COVID, googly for all, including pediatricians also. And thank you once again for covering such a topic. The manifestations, the treatment, the vaccine part, the role of BCG, the role of MMR, and the role, why not azithromycin. So thank you once again for accepting our invitation and covering this topic. Thank you.
Thank you, sir. Thank you very much.
Thank you so much, Dr. Upendra and Dr. G.V. Kulkarni, sir. As we conclude, this was the concluding session for IMAFEST today. I would request Digital to please display the slides. IMA Dombivli IMAFEST team would like to felicitate our speaker, Dr. Upendra Kinjavadekar Sarji, with our e-memento. Thank you so much, sir.
Received.
Yeah, thank you. Welcome, sir. And Dr. G.B. Kulkarni, sir, we would like to felicitate you with our e-memento.
Thank you.
Welcome, sir. Now we will proceed further with our valedictory function. I request our valedictory team and hand over the further proceedings to Dr. Niti Upasni.
Thank you, Upendra.
Yes, thank you, sir.
Okay.
Good evening, everyone. With this last lecture, we come to the end of this scientific session. 2 days of scientific session. It was an excellent. Each and every lecture was excellent lecture with a real treat to the brain cells, and we all the team IMA Dombivli IMA Scientific Committee hope that everyone has enjoyed these 2 days of lectures. We'll be uploading the MC credit card soon, and
Ma'am, unmute. Ma'am, please unmute. Hello, ma'am, please unmute. Ma'am, please unmute.
Stay tuned. And do enjoy the
Hello? Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Yes.
Coming to the end of the program, the most important is the valedictory function. On the foremost, IMA Maharashtra State President Dr. Bhondwe sir for entrusting IMA Dombivli to carry out a huge responsibility of Navrang and IMAFEST and taking out time from his busy schedule to visit our branch in person for the inauguration and also being the chief guest for Dr. U.P. Rao oration. We thank him and also the state and national dignitaries for guiding us for Navrang and IMAFEST. Dr. Mangesh Patel sir, IMAFEST organizing chairman, a true patron of our branch, in guiding us in every aspect to make our IMAFEST and Navrang successful. A true pillar of IMA Dombivli to whom we can turn for any smallest of doubts. And the way he smoothens all the creases is commendable. Thank you, sir, from the bottom of our heart. Dr. Archana Pate, organizing chairperson, Navrang, and Dr. Pate, sir, for providing their OPD premises for conducting the conference in a lavish and comfortable atmosphere with a great hospitality. It is worth mentioning that Archana Pate madam and sir had closed OPDs for 3 days for smooth running of the conference. Thank you so much, sir and ma'am. Hats off to Dr. Archana Pate madam. Though she was working 24/7 for the well-being of her COVID patients, she managed to find hours beyond 24 hours to work for Navrang 2020. And you have seen the picture till date, how beautifully and superbly it is turning out to be. My organizing co-chairperson, our organizing co-chairperson, Mr. Dr. Nokran Ganpule, always a helping hand with a smiling face. I thank him for arranging lectures and hosting the Hasya Kavi Samman. Dr. Meena Pruthi madam, organizing co-chair of Navrang, most soft-spoken and the sweetest person with her trademark meticulousness. keeping the smallest things perfect and making the function to run smoothly. Thank you, Dr. Meena Purti, Madam. Dr. Mukti Lote, Organizing Secretary, IMAFEST, Co-Secretary, IMAFEST. Thank you, Dr. Bhakti Lote, Madam, for your valuable contribution as a moderator, MOC, Event Head for IMAFEST and Navrang. Dr. Naina Chowdhury, Organizing Secretary, Navrang, a silent worker. She had done the toughest job of organizing and numbering of all the entries of Navrang on the drive. Dr. Vijay Chinsole, sir, Organizing Treasurer. Thank you, Dr. Vijay Chinsole, for arranging lectures and keeping track of all the expenses of IMAFEST and Navrang. Dr. Hemant Patil, Organizing Secretary of IMAFEST, our lifeline of the organizing team, both for the IMAFEST and Navrang. He has proved the famous saying, Jack of all trades and master of nothing wrong. He has mastered all the aspects to require, which is required for the organization to run smoothly. He is now the new phase of IMA and great asset for the whole team. And of course, he is the most soft-spoken person and always ever smiling. Dr. Niti Upasni, scientific chair person, IMAFEST, an apt person for heading the scientific chair, aptly supported by Dr. Ashwini Acharya, the co-chairperson. Thanking you for a great feast of superb scientific lectures for all the delegates and superbly crafted lectures with lots of thought. And what lecture will be interesting and full of knowledge to all the delegates. Aptly supported by Dr. Vijayalakshmi Shinde, Dr. Shirale, Dr. Adhe, Dr. Makaran Ganpule, Dr. Kirti Patil, Dr. Utkarsh Bingare, Dr. Vijay Chinsole, Dr. Krishna Kumar, Dr. G.V. Kulkarni. Thanking you all for arranging lectures and making the arrangements for the entire conference to run smoothly. The AV team, hats off to them. What a group. Dr. Niti Upasni, Dr. Vijayalakshmi Shinde, Dr. Hemant Patel, and Dr. Bhushan Kene. We have seen the beautiful slides, the videos over the past 3 days of all the presentations, and I think most of the delegates and the participants have enjoyed. Thank you all so much. No conference can be run smoothly without the funds. And I thank Dr. Mangesh Pate sir, Dr. Pramod Bhayekar sir, Dr. Archana Pate madam, Dr. Nilima Datte madam for the fundraising. Community team, great work by Dr. Suchitra Kamath, supported by Ashwini Dharmadhikari, Dr. Naina Chowdhury, Dr. Anjali Vaidya, for fantastic e-souvenirs of Navrang and IMAFEST. Superb topics as always. It's a treasure to have a e-souvenir as a reference book and a very classy presentation. And as always, Dr. Archana Pate, the advisor of the souvenir team. Thank you all. Registration committee. A big thank you for the whole team for keeping track of all the registrations. A big thank you for the managing committee and IMA members and all the delegates who joined the IMAFEST and all the participants who joined the Navrang. I'm thankful to the all event heads of Navrang, Dr. Nilima Datte, Dr. Alka Gadgil, Dr. Vijay Chinsole, Dr. Naina Chowdhury, Dr. Niti Upasni, Dr. Deepa Shukla, Dr. Meena Purti, Dr. Bhakti Lote, Dr. Ashwini Acharya, Dr. Hemant Patil, Dr. Vijayalakshmi Shinde, Dr. Makaran Ganpule, and Dr. Bhushan Kene. And aptly led by our own Dr. Archana Pate. They have worked 24/7 to make our Navrang a great success. And now I hand over for the further introduction to our organizing secretary, Dr. Hemant Patil.
Thank you, sir. Thank you for an encouraging and kind words. Arranging an annual cultural event of Maharashtra as well as a brand, IMAFEST 2020, in this COVID pandemic would not have been possible without a good digital platform and technical support. So I would like to extend my thanks to Team DigiShield, Mr. Dipen Mehta and Mr. Aditya Kuche for handling all the tech support and providing us the digital platform. Thank you. Thank you, DigiShield. These friends, you are watching an excellent inauguration videos for both the events with beautiful slides, mementos. They are created by 19 Creative Hub team. Aarti Badguzar madam, hats off to you. You're really good. Then the most awaited video of Navrang, which is going to be aired tonight at 10 p.m. Has been helped and prepared by Mr. Khanzode and his audiovisual team It is really pleasure to watch that video. We are also thankful to the companies Alembic Pharma, all three divisions of Sun Pharma, Cipla Pharma, JB Chemicals, NSV Pharma for being an educational associate, and last but not the least, the Fortis Hospital Mulund for providing two excellent speakers for the lecture. And of course, the first lecture of our series, that is Cleft Lip and Palate, was held by Smile Train organization. Thank you. I will also like to thank the staff of Asta Hospital for their great hospitality. Thank you, Asta team. Also, I'd like to extend my thanks to IMA Dombivli staff, Ms. Reshma Joshi, for her constant support. And at the end, I will like to thank the Lord Ganesha, for bestowing his blessings on all of us for making all these events a grand success. Thank you all. Thank you. Jai Hind, Jai IMA. Thank you.
Thank you all. Thank you all. Thank you so much. हेमंता सॉरी 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 व्हिडिओ चालू आहे.
Hello, Aditya. Hello, Aditya.
Yes, sir.
I think we can sum up.
Yes.
Yeah, so please join at around 6:30, right?
Yeah.